Hello, mic testing. இல்ல அங்க மேம் இதுல போனலனால ஓகே ஜஸ்ட் கோ டு தி ஆடிட் திஸ் யாருன்னா பாருங்கம்மா நீ போய் பாரு just come on just see if you can hear me நீ ஒண்ணும் பண்ணடா நீ ஸ்டேஜுக்கு போ
Hello.
You can hear me? Hello. பிரதீபா ஆர்னு இருக்கீங்க அதுக்காண்டி தான் கேட்டேன். Okay, fine.
Anjali, all set?
Yeah, all set, Anju. Just checking down voices. This.
Here, this one, chairpersons have not joined yet.
Sorry?
Chairpersons have not joined.
No, but they're there. Ma'am has already spoken to them. Just 1 second, just got them. Anju, I'll just get my video on in a second. I'm just going down for something and coming back.
Yeah, sure.
Dr. Chandrakanta and Dr. Vinod Kumar.
Vinod is here. Chandrakanta is having some difficulty joining, I think.
Okay, okay.
Vinod?
Yes, ma'am. Good morning, ma'am.
Yeah, Vinod. Vinod, the light is coming.
Light is, yeah.
Yes, ma'am.
Light is very
See
nice. Switch it on, na? Yeah. There's reflection behind. That's your. That's
Yes, ma'am. One second.
Yeah.
Ranjit sir. Ranjit sir, Dr. Mittal will join in some time, sir. So we'll just start off with you. He said he
Yeah,
will.
anyway, I'm supposed to be the first.
Yeah, you're first. Yeah, he'll
I
join.
think Chandrakanta is still not joined. She's
Yeah,
supposed
she's
to be the first.
struggling with some internet issue.
She's struggling with some internet issue. If that's the case, Vinod, you
So,
introduce.
we'll wait till 9 o'clock, and if you're not able to join by that time, we'll start off with Vinod.
Yeah,
Yes,
Vinod,
sir.
you introduce Ranjit in case Chandrakanta is not able to make it. Okay.
You could put some more light, Vinod?
Yes,
Vinod,
ma'am.
you look like you're in a haze, ma'am.
Yeah,
Yes,
very,
ma'am. Yes, ma'am.
very hazy.
You maybe need to change the angle of the camera.
I think
Yes,
the
ma'am.
light is coming from behind him. That's the
Yeah, that's why,
That's
right?
the problem. It's actually the reflection behind. Yeah.
No, the light is coming.
Ah,
from-
yeah.
now good.
Better. Little more you can come. If you can turn a little more towards your right. Perfect. Then the light is falling on you.
Yeah, now
Yeah.
it's better, Vinod.
Chandrakanta, can you put on your video, please? We can see your. Dr. Chandrakanta? She left again, huh? Dr. Chandrakanta? No, audio also she's not spoken. She's locked up. Yeah, that's fine, Vinod Kumar.
Okay, ma'am.
That's fine. Yeah.
We have 2-3 more minutes. Chandrakanta, do you want to switch on your video?
She's logged in again.
Yeah, she's here. Chandrakanta?
She got logged off.
Ah, yes. Okay.
Good morning, ma'am.
Good morning. Good morning. Nice to see everybody. We'll start exactly at 9, okay?
Okay, ma'am.
It's 9, Ranjini.
A very good morning to everyone. On behalf of Dr. Mohan's Group of Diabetes Institutions, I extend a very warm welcome to each and everyone present here in this virtual space on day 3 of the 8th Dr. Mohan's International Diabetes Update 2021. Guiding you through the proceedings of the Professor O.P. Gupta Hall today will be myself, Ranjini.
Is there an audio? Because we can't hear anything. If
Oh, there is. So we have an interesting lineup of sessions, and we'll now start with our first symposium for the day, which is on COVID and diabetes. This session will be chaired by Dr. Chandrakanta Jha and Dr. Vinod Kumar. Dr. Chandrakanta is a consultant diabetologist at Dr. Mohan's Diabetes Specialty Center, Hyderabad. She completed her MBBS and MD from Rajendra Institute for Medical Science, Ranchi, certificate course in gestational diabetes from PHFI, postgraduate program in diabetology from the Johns Hopkins University School of Medicine, postgraduate diploma in clinical endocrinology and diabetes from Royal College of Physicians, UK. She served as attending consultant from Department of Endocrinology, Medanta Med City, Gurgaon. She's delivered several lectures at webinars and conferences. Dr. Vinod Kumar is a consultant diabetologist at Dr. Mohan's Diabetes Specialty Center, Puducherry. He completed his MBBS from Meenakshi Medical College, Kanchipuram, fellowship in diabetes from Dr. Mohan's Diabetes Education Academy, certificate course in evidence-based diabetes management, and also the certificate course in gestational diabetes from PHFI, and also the certificate course in cardiovascular disease and stroke. His areas of interest is diabetes retinopathy, neuropathy, He has delivered lectures in several conferences and also conducted several camps for diabetes screening. It's a pleasure to have you both with us, dear chairpersons, and I would also like to welcome our speakers for this session, Dr. Ranjit Unikrishnan and Dr. Amrish Mittal. I hand over the dais to you all. Please kindly introduce this first speaker.
Thank you, Dr. Ranjini, for your kind words. First of all, I would like to thank Dr. Mohan, Dr. Anjana, Dr. Ranjit for having me here in this great update. I am deeply honored and privileged. So we have already witnessed 2 great days of academic feast, today being the final one. I believe this will be as awesome as the previous 2. And so to begin with the session, I would like to invite Dr. Ranjit Unikrishnan sir for the first talk, which is on COVID and diabetes. What is the connection? Dr. Ranjit Unikrishnan, he is our Vice Chairman and Consultant Diabetologist, Dr. Mohan's Diabetes Specialty Center, Chennai. He is Regional Faculty for Certificate Course in Evidence-Based Diabetes Management, CCEBDM, CCGDM, and CCDR. He has been conferred Fellow of Royal College of Physicians, FRCP, FACP, FICP, FACE, and Specialty Certification in Endocrinology and Diabetes, Royal College of Physicians and Society for Endocrinology, UK. He is also the recipient of Best Doctor Awards by the Tamil Nadu Dr. MGR Medical University, Dr. Selo Memorial Lectureship in Experimental Medicine Award by the Association of the Physicians of India, and he has contributed over in 180 publications in peer-reviewed national as well as international journals and delivered lectures at national and international conferences. Over to you, Dr. Ranjit, sir.
Thank you, Chandrakanta, for the kind words of introduction, and a very good morning to everyone, and welcome to the 3rd day of Dr. Mohan's International Diabetes Update. So today I'll be speaking to you on a very current topic now. I don't think any conference nowadays is complete without a session on COVID, and this being a diabetes update, we have a session on COVID and diabetes. So with your permission, I'll now try and share my screen. Are my slides visible?
Yes, sir.
Yes, sir.
Okay, I'll try and make it full screen. Yes.
Yes, it's coming.
So now with 2 waves of COVID already over and the 3rd wave in the offing, if the counts from Chennai and Tamil Nadu and Kerala are to be believed, it's all the more important that we know what is the link between COVID and this very important metabolic disease that is diabetes, which affects more than 75 million individuals in India. So before I start my talk, a couple of disclaimers. I have no potential conflict of interest to declare with respect to this particular topic. And even more important disclaimer is that I am not involved in the direct care of patients with COVID. All the information I'm sharing with you is freely available on the internet. Specific questions on how to manage COVID in people with and without diabetes are better directed at other members of the panel who may have more experience in treating these patients. So the first question I would like to look at is whether individuals with diabetes are more likely to get COVID just because they have diabetes. Because we now find that many of our patients, we have patients who are not ventured out of the house for more than 1.5 years for fear of catching COVID. So is it that people with diabetes have an increased risk of contracting COVID? If you have 100 people, is it more likely that the people with diabetes are more than 10 times likely or 15 times likely to get COVID-19? It turns out the answer is no. If you take people with COVID-19, they are not enriched in people with diabetes. That means just because you have diabetes, it does not mean that your susceptibility to get COVID-19 is higher. And which probably stands to reason, because if you remember your pathology, your physiology, your microbiology, you know that diabetes is not associated with increased risk of upper respiratory tract infections. And we all know that COVID-19 starts out as an upper respiratory tract infection. So the presence of diabetes does not confer an increased risk of getting COVID-19. But if you do get COVID-19 and you have diabetes, especially uncontrolled diabetes, you are at higher risk of getting adverse outcomes. So that is why people with diabetes should be more careful not to contract COVID in the first place. Because if you do get COVID and you have diabetes, your risk of adverse outcomes is much, much higher. And this has been known from the early days of the pandemic. This slide was actually shown by me during our last update. Subsequently, there have been many more studies, but I have not added them to the slide for want of space, number one. And number two, because they are all showing the same picture. There's no additional information which has come in the last 8 to 10 months. The message remains the same. So if you look at all these adverse outcomes, mortality, severe disease, need for artificial ventilation, need for ICU admissions, all these things, you find that individuals with diabetes have a significantly increased risk. Twofold higher risk, threefold higher risk, fourfold higher risk. So I don't think there is any doubt that if you have diabetes, your risk of adverse outcomes from COVID is increased manifold. And how does diabetes rank when compared to the other risk factors for severe COVID? Now, on the left-hand side, you see the various known risk factors for adverse outcomes with COVID. We all know that advancing age is the number one risk factor for developing adverse outcomes for COVID. You see where the hazard ratio is somewhere else. It is far away from all the other risk factors. But the presence of diabetes, particularly uncontrolled diabetes, is not too far behind. So that means that even at younger age, if you have uncontrolled diabetes, or if somebody whose HbA1c is not known, that means that they're probably uncontrolled because they have never tested their HbA1c ever in their lives. So we don't know what the A1c is. Poorly controlled diabetes is one of the strongest risk factors for adverse outcomes in COVID-19. Of course, there are other risk factors also, but remember, many of these conditions are rare in the general population. So you might say the population attributable risk, what you mentioned for the risk of diabetes, that sort of risk is low for many of these conditions. Because very few people have organ transplant, connective tissue disorders, and so on and so forth. Here we are talking about a condition which affects more than a quarter of the population in many places. And this is a condition which confers high degree of excess risk of adverse outcomes with COVID. So that's the importance of diabetes and diabetes control in COVID infection. Not that people are more at risk of getting COVID, but they are more at risk of developing adverse outcomes. So why is it that people with diabetes have adverse outcomes with COVID? Now, recently a very interesting review article was published by this group from Korea and from Germany. Michael Nock was one of the authors. And this was published in Nature Reviews Endocrinology, I think just last month. And this is a chart showing what happens to the immune system and to the inflammatory cascade when you get infected with COVID-19 or SARS-CoV-2. Remember, this is not specific for people with diabetes. It happens in everyone. But the steps which are marked with this lightning bolt are actually accentuated, or they are more prominent or predominant in individuals with diabetes who are infected with COVID-19. You see here that when you get an infection with SARS-CoV-2, you get an increase in the inflammatory cytokines. There is increase in the lipopolysaccharide level. Interferon gamma levels increase. Natural killer cells get activated. And both of these can lead to lung damage, can lead to lung fibrosis, increase in the permeability for the pro-inflammatory products into the interstitial spaces. And this leads to acute lung damage and ARDS. Any infection, including COVID-19, can also lead to increase in the reactive oxygen species as the innate immune system tries to get rid of the infection. Reactive oxygen species levels increase, interleukin-6 levels increase, and this can lead on to insulin resistance and hyperglycemia. We'll be coming to that in a second. And insulin resistance and hyperglycemia, we know very well, they are risk factors for the development of endothelial damage. Generally, in type 2 diabetes, this sort of endothelial damage occurs over a long period of time. When you get intense activation of the insulin resistance cascade, this endothelial damage can occur over a short period of time, especially in individuals who already have pre-existing diabetes. Plus, you also have activation of the renin-angiotensin system. We know very well that the receptor for the entry of SARS-CoV-2 into the cell is the ACE2, or the angiotensin converting enzyme 2. Plus, in any stressful situation, the renin-angiotensin system gets activated. This can again lead to vasoconstriction, vascular endothelial damage, and ultimately it leads to cardiovascular events, thromboembolism, and DAC. Plus, we know very well that COVID-19 infection as well as diabetes are prothrombotic states. There will be increase in markers of coagulation such as fibrinogen and D-dimer, which again leads to increase in blood viscosity and increased risk for cardiovascular events, thromboembolism, and disseminated intravascular coagulation. Ultimately, these are the factors which lead to mortality in severe COVID-19, much more than lung disease. Now, it has become more and more clear that COVID is not just a pulmonary disease, but it is a systemic thromboembolic disease, and that is what leads to mortality in the majority of cases. So this is from a clinical aspect. Earlier I was mentioning from a pathogenic aspect, and this is from a clinical aspect. We see what happens in individuals with diabetes who get infected with SARS-CoV-2. Metabolic rate increases. There is dysregulation of glucose metabolism, which we'll talk about later. Already diabetes is a pro-inflammatory state. There is all chronic low-grade inflammation going on in diabetes, which gets aggravated. And there is some degree of immune modulation. Already diabetes is an immunocompromised or immunosuppressed stage. On top of that, you get further modulation of the immune system, leading on to tissue hypoxia, glucotoxicity with its attendant risks, endothelial damage, increased oxidative stress and release of harmful cytokines, leading on to lung damage, thromboembolism, and the damage to various vital organs, leading on to severe disease and even mortality. So this is how diabetes, especially uncontrolled diabetes, is said to lead to adverse outcomes from COVID-19. So what is the link between glycemic control and outcomes in COVID? We saw that people with diabetes have high risk of adverse outcomes. Now, is there any link between controlling these high sugar levels and improvement of outcomes? We find that people with high sugars, and this is the definition of high sugar, many individuals, many researchers have used the HbA1c, many have used the hyperglycemia at admission, and whatever be the parameter used and whatever be the adverse outcome studied, there is a clear link between uncontrolled diabetes and adverse outcomes. So it's not just the presence of diabetes, but the presence of uncontrolled diabetes that leads on to the increased risk of adverse outcomes in COVID. So that brings us to the question, how to treat diabetes during the COVID pandemic in somebody who has COVID? Important question, can all the anti-diabetic drugs be continued? There have been a number of reviews on this topic, including one from our group, which was published in the Journal of Diabetology. There is another, Dr. Daniel Drucker and his colleagues in the Lancet Diabetes and Diabetology, which I would encourage all of you to read if you have the time. It is still relevant, even though it was published more than a year ago. Generally, what we need to look at is what is the severity of the COVID and how is the glycemic control. If somebody has got mild COVID being treated at home, ambulant patient, and the glycemic control is appropriate or adequate, there is no indication for changing any medication. If something is working, please do not change it. First, do no harm. But if the patient develops moderate to severe disease, has to get hospitalized, it is always better to switch the patient over to insulin. Similarly, if somebody's glycemic control deteriorates, either due to the infection or due to the treatment of the infection, it is always better to start insulin. Now, it says here that SGLT2 inhibitors should be stopped in hospitalized patients, and this is only because of the risk of dehydration and probably ketosis in these severely infected patients. This slide summarizes the use of various anti-diabetic agents in different types of COVID. In somebody with mild disease, you can probably continue all anti-diabetic agents. Be careful while using sulfonylurea and AGI because they may not be eating properly due to loss of taste and smell. So when somebody is not eating, the risk of hypoglycemia is more with sulfonylurea, and you may not need to be using alpha-glucosidase inhibitors. SGLT2 inhibitors, for the reasons mentioned earlier, are better avoided in people with COVID-19. Thiazolidinediones, there has been some evidence that thiazolidinediones may actually improve outcomes because they have anti-inflammatory effects. But that is overridden by the risk of heart failure when these agents are used. Plus, when you start thiazolidinedione in somebody with COVID-19, it takes around a couple of weeks to a month for the effect to be evident. So it may not be of any benefit to use it as an acute agent for reducing the hyperglycemia. Otherwise, you can give all the other agents, insulin, DPP4, metformin, GLP-1, and so on and so forth. But when you have somebody who is hospitalized with severe disease, it is better to just stick to insulin. DPP4 inhibitors can also be given. There is some evidence from small studies in Italy that people who are given sitagliptin have better outcomes of COVID-19 hospitalized patients. Unfortunately, that has not been reproduced in any other studies, but at least the drug is not harmful. Metformin, yes, it is a very useful drug. It may have some benefits, but again, in somebody who is severely hypoxic, severely infected, be it COVID-19 or any other infection, it is better to avoid metformin. GLP-1, again, a useful drug, but it is associated with nausea and vomiting. Again, it does not have any acute benefits. It takes time to act. So it may not be a very useful agent to initiate during COVID-19. There have been some reports which show that SGLT2 inhibitors actually improve outcomes in hospitalized patients. And to study that, a trial was designed. It's called the DARE study, DARE 19 trial. The results were published in the ADA meeting last month. Unfortunately, the reports were negative, so it doesn't seem that SGLT2 inhibitors are associated with any improvements in outcomes. So what are the targets? Plasma glucose levels 70 to 180, or even you can say in severely ill patients, try and keep it between 110 to 180, which is the same guidelines what we give for all patients hospitalized with other diseases. HbA1c, of course, you can't bring down the HbA1c during the course of the admission, but to get good outcomes, you need to have an A1c below 7. That's the importance of controlling diabetes during the pandemic. Should not wait for COVID-19 to affect you before you control your diabetes. Should be under control even before. It's like pregnancy. Before you get pregnant, you have to get your HbA1c under control. You're using a CGM, which Dr. Amrish Mittal will be talking about in the subsequent talk. Target is time in range above 70. Avoid hypoglycemia. And nowadays, with the advent of the continuous glucose meters, it has become very easy to monitor hospitalized patients. With minimal risk to the healthcare providers, you can actually monitor your glucose by means of flash glucose monitoring and other technologies. So can COVID precipitate new onset diabetes? Again, from last year, we have been reading about this. The answer is an emphatic yes, and there are different mechanisms which are involved in this. Even people who don't develop COVID during the COVID pandemic, lockdowns and other stresses and strains and lack of exercise, inability to meet the healthcare providers, all these can lead to development of de novo diabetes as well as deterioration of glycemic control of those who already have diabetes. There is some evidence that SARS-CoV-2 can directly invade the beta cell because ACE2 receptor is expressed on the beta cell. So it can directly invade the beta cell and destroy the beta cell. This is why many patients with new onset diabetes after COVID continue to have diabetes even after they have recovered from COVID. That is because of beta cell destruction. Of course, nowadays we have corticosteroids, which are the cornerstone of treatment. They are potent diabetogenic drugs, and that is, of course, a topic for discussion on another day. So Dr. Anup Mishra has actually classified hyperglycemia during the COVID pandemic into different categories. And this is one article which I co-authored with him in Nutrition and Diabetes just a couple of months ago. And how we have divided the hyperglycemic stage during the pandemic is that people who don't have COVID-19 infection, they can also get hyperglycemia for reasons mentioned above, due to the lockdown, stress, strain. They cannot comply with medication, diet advice, so they can get new onset hyperglycemia and diabetes even without COVID infection. You can get new onset type 2 diabetes, you can get new onset type 1 diabetes also. And you find that the proportion of people presenting in DKA has actually increased during the COVID pandemic, be it type 1 diabetes or type 2 diabetes, probably because they cannot access healthcare during the lockdown. If you have COVID-19 infection, like I mentioned earlier, you can have direct effects of the virus on the beta cell, plus you can have effects of the infection or effect of the treatment of the infection on the beta cell. All these can lead to new onset diabetes, worsening of existing diabetes during the COVID pandemic. Some of the drugs used for treatment of COVID-19 can also have an effect on diabetes control, most common one being corticosteroids, which can worsen glycemic control. Unfortunately, many a time what happens is that, especially when you start steroids on a domiciliary basis, people do not think about looking at the sugars before you start the steroid. That's a very bad thing to do actually. Before starting anyone on steroid, you should be sure about the glycemic status, and if necessary, insulin has to be added. Hydroxychloroquine, of course, nobody talks about it anymore, but it's one drug which has been shown to have some beneficial effect on glycemic control. Whether it works in COVID or not is a different matter altogether. And all the other drugs are commonly used. Remdesivir really doesn't have much of effect this way or that way on sugars. Lopinavir, ritonavir, no longer recommended for COVID, actually worsens the glycemic control. And IL-6 inhibitor like tocilizumab actually have been shown to improve glycemic control. So finally, what about vaccination? Now we have lots of vaccines available for COVID-19. Some of them are more effective than the others. But one thing in diabetes is that people with diabetes have been shown to respond appropriately to all vaccines, including pneumococcal, influenza, and so on and so forth. So there is no reason to assume that the response of these individuals to COVID vaccination will be any different from that of non-diabetic individuals. And most of the vaccine trials have included individuals with diabetes. Number one, there is no signal to show that they respond any worse or any better than people without diabetes. And there have been no safety signals or danger signals identified. Plus, people are at high risk of getting COVID complications. So people with diabetes are placed in high priority for COVID vaccine. They should be vaccinated as the first available opportunity. So these are some of the studies which have looked at the vaccine efficacy. I have not shown the full page, full entire analysis because it will take more than a couple of slides. But see that most of the vaccine trials, most of the important vaccines which are available throughout the world have included a large number of people with diabetes in their phase 3 trials. So this means that Most of these vaccines, the safety and efficacy in people with diabetes has been established beyond reasonable doubt. So I'll conclude by saying that there is a bidirectional relationship between diabetes and COVID-19. COVID-19 has emphasized the need for controlling diabetes. So this is actually an opportunity for all of us as diabetologists to reiterate to our patients the importance of maintaining good glycemic control. I generally say if COVID-19 pandemic does not induce your patient to get his sugars under control, I don't know what is going to. Because such a deadly disease, people are running scared here and there. If even that does not make a patient with diabetes realize the seriousness of the situation, I do not think there is much scope for further discussion with that particular patient. But there is definitely more research required on this new onset diabetes after COVID. How frequent is it? How long does it last? Is there any difference in the pathophysiology, the treatment, and the risk of complications? Plus other things like development of mucormycosis, which again is a topic for further discussion later on. And I think these are some of the aspects which need further research. I will stop at this stage and thank you once again for giving me the opportunity. Thank you for the patient attention. And we'll be taking the questions, I suppose, after the end of next talk. Thank you.
Thank you, sir, for the excellent talk. We will be taking questions, answers at the end of the session. Over to Dr. Vinod now.
Amrish sir, welcome. Just wanted to add a welcome.
Welcome, sir.
Good morning, sir.
Pleasure to have you here.
Vinod, over to you.
Yes, ma'am.
They should consider having some audio for this, no?
The long ones, yeah.
Okay.
There's one more, I think.
Or is that?
Yeah. You can go ahead.
Yes,
Nope.
ma'am.
Yes.
So good morning, everyone. First, I would like to thank Mohan sir, Ranjit sir, Anjana ma'am, and Pradeepa ma'am for organizing this virtual scientific meeting in a wonderful manner. We had 2 days of excellent sessions. Now we'll be discussing about the role of CGMS post-COVID care in patients with diabetes. And it's my great honor and privilege to welcome Dr. Amrish Mittal sir. He is the chairman and head Department of Endocrinology and Diabetes Max Healthcare, New Delhi. He is the domain expert, governing board of National Health Authority of India and honorary president of AIIMS, Gorakhpur. His areas of interest include vitamin D nutrition, primary hyperparathyroidism, osteoporosis, cardiovascular outcome trials in diabetes and NAFLD. He is the past president, Endocrine Society of India, and founder and chief advisor in Indian Society for Bone and Mineral Research. He is the past editor-in-chief, Indian Journal of Endocrinology and Metabolism. He has published several articles in peer-reviewed national and international journals, and he is the recipient of several awards, prominent among them being one of the highest award given by the Government of India, the Padma Bhushan Award, Dr. B.C. Roy Award, Laureate Award from Endocrine Society, and Fogarty Fellowship, and several others. Sir. Over to you, sir, for the next talk, sir.
So you're muted. You're
You're
muted.
sir.
Can I share my screen?
Welcome, Amrish. I also wanted to just say welcome. Always a pleasure to have you with us. And I think today's talks are all by the who is who of diabetes in India. And it's so difficult with both halls, heavyweights on both sides. It's very difficult to choose. But, your presence makes a big difference. Thank you, Amrish. Looking forward to hearing you.
Thank you, Mohan. Thank you for including me always in this very important annual event in the endocrine diabetes fraternity for our country, but also internationally. As we know, it is one of the best attended events and has always been one of the best organized ones, with very little compromise on quality of the science being presented. So I'm very happy to be here and sharing a little bit of our experience with management of diabetes during COVID. And I think Ranjit has set the tone really well, set the stage very well, and I'm glad that I removed many of my slides last night, so that the overlap is much less than it could have been. So we'll talk about CGM, and we all talk about continuous monitoring, ambulatory monitoring, or flash monitoring, or whatever terminology you give it. But the fact is that it's something that's here to stay. It started with higher use of technology, higher technology use for monitoring blood pressure, pulse all the time. Similarly, blood glucose has entered the fray, and really we are now looking at everything at knowing more and more about our bodies. And one of the ways to do that is to monitor glucose continuously. So let's first look very briefly, summarize what Ranjit presented to us so elegantly about diabetes and COVID-19. And I'm not showing you the relationship, that's very clear. We'll show some glimpses from our own study. But does glycemic control matter in patients with COVID? Yes, it does. And I think that's very important. It's one thing to say that there's a correlation. It's like an HDL type of correlation. You have a low HDL, you have greater degree of heart disease. But does raising HDL make a difference? We don't really know. But in this case, when we talk of poorly controlled diabetes leading to poorer outcomes, the value of good control cannot be overemphasized. In some of the larger studies that came out from China, and I borrowed this slide from my friend Nikhil Tandon, basically, if you look at those studies, quite clearly, in poorly controlled diabetes, there was greater use of steroids, greater use of immunoglobulins, vasoactive drugs, oxygen inhalation, non-invasive ventilation, invasive ventilation. So it's quite important that we realize that there is a significant impact of the control that we achieve during COVID on the outcome. And that's important to understand. Similarly, glycemic variability. You can see if there is significant glycemic variability, you would get poorer outcomes. Again, to emphasize again, look at the differences in respiratory disease, or respiratory distress syndrome rather, heart injury, kidney injury, and septic shock. Left column is well controlled and the right column is poorly controlled diabetes. And you can see there is a very significant difference in the acute heart injury or ARDS following COVID if you are well controlled versus poorly controlled. And quite clearly, those people with diabetes who are poorly controlled have much poorer outcomes. And coming to the final proof, that is the mortality. There are numerous studies on mortality in diabetes patients, but the fact is, we know that people with diabetes have greater mortality. There is no doubt about that. It may be 2 to 4-fold depending on the study you look at, depending on the population you look at. But very importantly, is the glycemic control related to mortality is what is relevant for us, because we are looking at tools and technologies to help us improve glycemic control. And if by improving glycemic control, we are improving outcomes, we are doing a good job. Otherwise, it doesn't matter. If you improve glycemic control and doesn't have much impact on outcome, then the motivation to do so is much less. So well controlled versus poorly controlled, 1.1 versus 11%. That was the largest study. Of course, here the prevalence of diabetes was not so high. But the fact is that it's increasingly clear in numerous studies, the first ones coming out from China, the later ones which I have not included, all showing the same thing. Better glycemic control, less glycemic excursions during the COVID-19 disease itself led to much better outcomes in terms of reduction in mortality. And I think nothing could be more telling than this. And as Ranjit said, really, if this doesn't drive us to better glycemic control, I don't know what will. This is a nice sort of representation, a cartoon of the same thing, of one of the studies which actually showed this is the usual survival in COVID-19 with well-controlled blood glucose. But what happens when glucose goes down as the control goes down? That means as diabetes is more poorly controlled, you slide down this staircase. you fall down the staircase, ultimately leading to much higher prevalence of death or mortality. And this is the way we have to look at it. And very often in this pandemic, control of diabetes was given a backseat because physicians and patients were dealing with too many things, and they really did not worry too much about glycemic control. And we faced the consequences of that in the so-called epidemic of mucormycosis that broke out after this. And we will face that in the long run also. I mean, endocrinologists and diabetologists are going to be busy because of the use of steroids and uncontrolled diabetes in many of our patients during the pandemic period. We will be left with many consequences to deal with. Briefly touching upon our own study, which looked at 401 consecutive patients, and we actually found much higher prevalence than what is described in literature, 7%, 8%, 9%. Quite clearly, these were consecutive patients in August, September last year. And what you do find very clearly is that if you look at the diabetes versus no diabetes, the red bars are diabetes. Okay, so 189, 212. What do you find here? That the red bars are always higher than the blue bars, which means severe cases, mortality, 4 times mortality, oxygen requirement, ICU admission, inotropic support, renal replacement therapy, steroid therapy, and at that time, convalescent plasma therapy. The requirements for all these, as judged by the treating physicians, was higher, and it turned out that we analyzed the data that they were significantly higher in people with diabetes. Again, what happened to inflammatory markers? Our study clearly showed that inflammatory markers in COVID-19 patients with diabetes, look at the red bars again, CRP, IL-6, ferritin, LDH were all higher. And most importantly, on the outcomes based on glycemic status. If you look at, well, we divided into 4 categories. I'm not going through the whole paper. That's not the subject today. But of course, people without diabetes, and here they are red actually, the colors have changed. Hyperglycemia without pre-existing diabetes. That is new onset hyperglycemia, right? Which we know has the worst prognosis. And you will find that they did have the worst prognosis. The blue bars are the highest here. Then previously unknown diabetes, people who didn't know they were diabetic and they were diagnosed on hospitalization. Again, and the gray bars are the ones which are people with known diabetes. So quite clearly, as we all know from other studies, new onset hyperglycemia showed the worst outcomes here. Again, in showing, this study did not look at glycemic control and outcomes. But as I've already shown you, that the impact of glycemic control on determining outcomes is very strong. Baseline A1C in our study correlated with severity of disease and poor outcomes. But as I said, 38% roughly of our patients who were admitted were known diabetics. 9% were detected to be diabetic there with high A1Cs and high blood glucose without knowing it. Another 5% point some percent were actually found to be new onset hyperglycemia. And while these numbers may vary in different studies, this is the data that we have, possibly indicating a lower proportion of new onset hyperglycemia, perhaps because people are getting diagnosed earlier with diabetes in the metros. But fascinating in terms of COVID outcomes. So almost half the cases had pre-existing or either known or newly detected diabetes, more serious forms of COVID. Severity was twice and mortality was 4 times greater in diabetes group. We had a lower percentage of NOH than most other studies, but poorer outcomes. We can leave this. When you do a multivariate analysis, the concept that glucose may be just an indicator of overall metabolic health bears fruit, and really the ones who had poor outcomes are the ones who had multiple comorbidities rather than just a blood glucose. So when you do multivariate analysis, diabetes alone is not a great predictor, but because it comes with so many partners in crime, it actually leads to poorer outcomes. What do we do? It's very important to control hyperglycemia. And you know that steroids are the major thing. Of course, you know that in patients with viral infections, severe infections, glucose goes all over the place. But in this case, it was compounded by a lot of use of steroids, in sometimes indicated, sometimes not indicated, but definitely in hospitalized patients. In the second wave, we managed 90-year-olds at home through remote monitoring And on steroid with severe hyperglycemia, there was just no bed available at that point. So therefore, it's important that we understand that we need to learn to control steroid-induced diabetes even outside the hospital. Daily glucose monitoring is the key. And obviously, we have to set targets. And we know that if you give a single dose of steroid, or say methylprednisolone in the morning, it's the afternoon sugars, evening sugars that are very high. So you have to, based on which steroid you're using, you'll have to tailor your therapy. You'll have to almost always start insulin, even in patients who are not hospitalized. It was a challenge for us to initiate insulin and manage insulin therapies in patients who were at home and often alone in their room because they didn't have any help. So not only were they monitoring, they were also using insulin. And I think that experience over the last more than a year, and now we've crossed more than 9,000 video consults that we've done in this period of the pandemic. So it's been very educative, and as it helped also for us to understand how to manage this better. So some of them, we definitely use CGM. Given the intensity of monitoring advised and the level of fluctuation that happens with steroids, there is no doubt that if you get a continuous monitoring graph on your phone or laptop or wherever, you will find that it is much, much easier to manage patients rather than doing 2 glucose values or 3 glucose values a day. So insights into glucose, there's a lot of inter-individual variation also. The same degree of steroid doesn't lead everyone to respond the same way. And you have very many things that determine response, their obesity, their prior state, so many things. So without going into details, this is, I think, Arvind's article. We know that there is a need for insulin therapy, very important. We have to initiate insulin therapy, and one simple way that we used at the start was really to add an intermediate acting insulin with the first shot of steroid, with the first dose of steroid in the morning. And that actually often covered, even an NPH. We often use glargine or levemir, but even NPH covered the evening sugars quite nicely, and then you have to titrate accordingly. And of course, we know, and I'm happy for one thing, that basal bolus regimens have become standard of care. We've been struggling with that for years to explain to people that mixed dose insulin, pre-mixed insulins don't work as well as basal bolus regimens. There are many criteria, and the group at AIMS tried to develop criteria for hospitalized patients, level 1 monitoring, level 2 monitoring, level 3 monitoring. Almost all our patients did require level 3 monitoring at a particular stage, especially the older ones with comorbidities. So it's quite a challenge to do that, 6 to 7 values a day. And therefore, we need higher and higher frequency of monitoring during this stage. So if you're hospitalized, there is no doubt that we have to use SMBG as we've always been doing, but we also know the limitations, which we'll not go into, pre-analytical factors, the hypoxia, hypotension, chemistry used by glucometer, certain test strips may not provide accurate values. We know all this, changes in hematocrit. But if you compare CGM and POCT, you find that CGM will detect nocturnal asymptomatic hypoglycemia. People on single dose steroids often get hypoglycemia early next morning, whereas they get severe hyperglycemia the same afternoon or evening. So all those things, monitoring improves, and we use CGM with a fair degree of comfort and with good outcomes, has been shown in the study, where again compared comparable clinical accuracy to POC with additional benefits. Overall, we'll not bore you with this. You know very well TIR. I think it's very well understood now to this audience that when we use continuous monitoring, we try to keep 70% values within the target range. There's 70 to 180, and Ranjit also mentioned it, so we won't waste time on that. But the fact is that you can devise your TIRs also, because it's possible that in patients on high dose steroids, risk of hypoglycemia, you may want a TIR of 50%. So that is possible for you. And in some, you may want a TIR of 80, 90%. So you can customize that. But in general, 70% time in range between 70 to 180 is what one would like. That's a general statement. And of course, if we have less or more, especially below range, has to be less than, especially if it's severe, like below 54, has to be less than 1% or even less. So those are the criteria that you will follow with the ambulatory glucose monitoring. This is the time in range, time above range, time below range, the concept that all of you understand very well. The green part is the time in range, yellow part, time above range, and the pink part is time below range. We have to minimize, try and keep our patients in this range with complex, often complex and complicated insulin regimens, but that's the requirement of the day. We know that TIR has been shown to correlate with microvascular and macrovascular, but that's not the topic today. Long-term complications we're not talking about. What about COVID and TIR? And the last few slides will explain that. There are studies that clearly have shown CGM in COVID-19 patients. It is an effective method of glucose monitoring, seem to result in improved outcomes. Look at this study here. Look at the two lines here, how they're separate. Calibrations are not necessary. It provides comprehensive information about glycemic fluctuations, hyperglycemia and hypoglycemia. And a very important point, which is shown on the next slide, it reduces the risk of biological exposures. It reduces, especially if the patient is not able to do the glucose themselves. Reading it with a non-invasive method, virtually just implanting the device once and for 2 weeks you're safe, is a huge, huge benefit. The contact between healthcare worker or the caregiver in this case with the patient is dramatically reduced. And that's the big advantage of using continuous monitoring technologies. And the last part is in the post-COVID period when we advise a lot of changes in nutrition to our patients. We really talk a lot about eating more, recovering well. Patients are weak, they have lost weight, their protein intakes are down. And again, the requirement changes. And the use of a continuous monitoring device at this point, when nutritional requirements have changed, are being emphasized, higher protein intakes, we are not restricting so much calories in the immediate post-recovery period, we will again need to recalibrate their insulin requirement. And there again, CGM plays a big role. So for example, use of CGM to optimize diet. It reveals impact of each food item that the patient consumes. So while giving the patient the correct mixed balance of diet, we will also be able to advise the patient on what is raising the blood sugar. And there's a lot of autocorrect in this. When patients see what the glucose values, how they are fluctuating, they're able to adjust themselves very well. So for example, protein intakes are the biggest challenge in India. And during this period, we insist a lot on higher protein intake. So again, the value of CGM cannot be emphasized. Others have shown, again, similar things that I've already spoken about, the feasibility, accuracy, lockdown conditions. We all know that. And as I said, we all have, or most of us have, good experience with CGM during lockdown conditions. And I said, both pre-COVID, during COVID, and post-COVID. And during COVID, even for those not hospitalized, we were able to manage at home with a lot of ease because of the availability of continuous glucose monitoring devices. And in other countries, there was a lot of challenge with routine HbA1c and all. In India, that was not a challenge because home care continued throughout the pandemic, and our laboratories were able to provide us lab data even during the pandemic. And we sometimes don't realize how lucky we are to be in a country like India where these things are possible. There was no way of getting lab tests done for my family and colleagues who were living in the US or UK during the stricter periods of lockdown, but it was possible in Delhi and Chennai and other parts of the country, I'm sure, because people go home to collect the sample. So to summarize, there is a pre-COVID level of control where we uncontrolled diabetes. We want to use CGM sometimes to control diabetes better, particularly in those who are on multiple insulin shots. Particularly, of course, we're not talked about type 1 today, and there's no controversy about CGM in type 1. That's well established. Pediatric patients, again, same type 1 or other pediatric patients. During COVID, very clearly, people who are uncontrolled, maybe not always in the controlled patients, but in uncontrolled patients, we were very, very happy with the use of CGM. We also used in some hospitalized patients, again, with a fair degree of success, because a lot of care, even for hospitalized patients, that we were able to provide during the pandemic was through the phone. We were not visiting and hand-holding the patient as we are used to normally. We were doing it through remote, and therefore, these values helped us a lot. And post-COVID, because of changes in requirement, and many of our patients are unable to reach the pre-COVID levels several weeks or even several months after COVID. So in all that, with changing dietary requirements, changing schedules, sometimes lack of physical activity post-COVID, people are so tired, we're not pushing them for aggressive exercise. So all those things are important. And just to summarize, we all know this. This is a general thing. Why CGM? Technology that adds value, wide application, user-friendly technology, 3-in-1 solution, proven clinical efficacy and outcome efficacy. How green is my Delhi? You can see these days with the monsoon. This is the park behind the house, the nature park, and everything is green these days. You can see every shade of green that you like, 50 shades of green. One point before I sign out is that one of the challenges that we have faced in continuous monitoring technology is a degree of variability sometimes. And I think it's important that discordance between the values that are seen on CGM and that are seen on glucometer or glucose meter versus laboratory, these have to be standardized even more. There is improvement in that, but particularly in the lower limit, I think the technologists, the companies need to work harder, whether educate patients better, there is some mistake that's being made, or whether, so there is the odd patient where it won't give you accurate information for some time, and that can be misleading. So we need to work harder on that, but by and large, it has been a very invaluable asset in managing managing diabetes during COVID times. Thank you.
Thank you, sir. Thank you for the wonderful talk, sir.
Thank you.
Beautiful talk, Amrish. Superb. I just sent you a message saying, can you write a brief review on this for Journal of Diabetology? I mean, it's the indication for, CGM itself. And you mentioned how it got approved in US because people are scared to go near the patient. Yes. And so keeping it at the foot end of the patient and seeing it on CGM, these are all things that, but for COVID, it would never have come. So this particular indication, if you can write, just even 2-3 page kind of commentary, kind of an article, it would be worth sharing this. But I don't think people are aware of this. The other point that both you and Ranjit made is that we know, how much of data both of you presented to show that uncontrolled diabetes is the main cause, not only of bad COVID outcomes, but also of mucormycosis and steroid use and everything you can think of. And yet people, I didn't see people in India emphasizing diabetes control enough, and that's why I said, let's call June as a control month, just to create that hype, because this is what you have to do. And such an easy thing to do. You're just showing, bring it down within 70 to 180 and bring your A1C down, and 80% of the problem you can solve. Such a low hanging fruit. I don't think we have paid enough attention to it, or we're not given enough importance to it, I thought. So
I think Mohan, what we're trying to do, and I think that's working, and Ranjit said that very well also, actually. The fact that if this will not spur you on to control your diabetes,
exactly. What will?
For a 40-year-old, the talk of a retinopathy or something is very vague, and, he doesn't worry about, he's at the peak of his career, busy in his company or whatever. But the fact that he might get bad COVID is a lot of motivation. So we are driving home that point a lot in the OPD.
Absolutely.
We've had all our patients vaccinated. Hardly any are left. Literally you can count on the tips of your fingers. We are really pushing very hard for good glycemic control and vaccination for our
fantastic talks, and I think very much needed at this hour. I thought while I'm there, because before I switch to the next hall, I'll welcome Dr. Arpan Dev and Dr. Sambit Das, Dr. Debmalya Sanyal, and Dr. Vaishali Deshmukh. Great honor to have all of you in this meeting, and look forward to the next thing. I'll sign off and go to the other one. Thank you.
The chairpersons, would you like to?
Yes, ma'am. We have some questions in the chat box.
Yeah. Thank you, Dr. Mittal sir. Excellent presentation. Now we'll have the question and answer session. So there's question for Dr. Ranjit. As you gave into an insight into use of oral hypoglycemic agents and insulin in patients who were COVID infected. So one question is there. So how many days should insulin be continued post hospitalization, and what is the best time to restart the oral hypoglycemic agents?
I think you just have to follow the rules which we follow for any hospitalized patient. That means once the patient is considered as recovered from COVID by whatever definition you use, and once the patient starts taking a reliable oral intake, and they do not have any contraindications to oral agent use, you can definitely restart the OHS. But beware while stopping the insulin, don't stop it all of a sudden because the goalposts may have changed. You may have developed a bit of pancreatic damage during COVID, which may have converted the patient into a non-insulin requiring patient into an insulin requiring patient. So don't stop the insulin abruptly, stop it gradually, taper it down, and restart your OHS.
Thank you, sir.
Yes, sir. So one question to Amrish, sir. Sir, in your study in the hospital regarding diabetes and COVID, sir, did you see any cases of obesity-related COVID complications, and any opinion about it, sir?
So the opinion is very clear. Obesity has a significant impact on COVID outcomes. So there is no question about that. There is data worldwide. Severe obesity for sure has poor impact. That's evident. I mean, that's also physical problems of ventilation and other things, and so that is one. But even moderate obesity has definitely got impact on COVID outcomes. Unfortunately, and this is one of the weaknesses of our study, we didn't have the weight for all our patients.
Okay.
Because there was so much panic and people were getting hospitalized. So whatever we had, and that's like less than half. So that's not very encouraging data, but it did show some correlation. But we didn't mention it because it's embarrassing to say you didn't have the weight for all your, but we didn't. People were coming in remotely, getting admitted, here, there was a lot of turmoil. So we didn't have accurate weight records. But in one line, the answer to your question is we didn't look at it carefully, but quite clearly obesity has an impact on COVID outcomes.
Thank you, sir.
May I ask a question, please?
Yes.
Yes. So actually, the question is for both of you. And so suppose you have someone who's admitted for COVID and there's, a hydration status problem and something like that. So to Ranjit, there's this recent thing that came that DAPA is actually safe. Although we think about dehydration, SGLT2, there was this recent study that said DAPA was safe. So what do you think about that? Can we use it? And to Amrish sir, what about CGM at such a point in time? You were saying something about accuracy and things. So is it okay in such a patient, to use CGM?
I would think as far as the DAPA is concerned, when somebody is sick enough to be dehydrated, it is better to avoid all oral agents in the first place. Because if nothing else, you do run a risk of ketoacidosis or hyperosmolar or hyperglycemic state. So when somebody is dehydrated, it's always better to give fluid and insulin rather than any OHS, leave alone SGLT2.
Yeah, I mean, I think I'll further add to Ranjit's comment about DAPA, and he's absolutely right. I mean, we were managing diabetes in hospitalized patients before SGLT2 inhibitors also. So I don't think there is a reason to push SGLT2 there. There is no reason to discontinue, as he very correctly pointed out, in the mild cases. But in sick hospitalized cases with dehydration and ICU, borderline oxygen, I mean, we have other options. We are going to use insulin anyway, maybe add a gliptin there or something, but why should we, throw in a new drug which we're not so confident about? So you can use it, but I would prefer not to in sick patients. And you had a question from me, Anjana. What
CGM, the CGM in a similar
yes,
kind of.
Of course, in patients who are hospitalized, as I said, since it is almost like remote care during COVID, so I think use of CGM we found quite useful. I see
The accuracy, sir? The accuracy when there's
accuracy is an issue in very sick patients, but recently it has been approved for inpatient care. Again, patients who are hypotensive in the ICU on ventilation, you can debate whether we should use CGM or not. If there, even we know that even glucose monitoring, the regular glucose strip monitoring, is sometimes questionable. But for those who are in the ward, and putting it very clinical practical, those who are in the ward, not in the ICU and not that sick, CGM proved to be very useful. And it is.
And maybe maybe the real-time accuracy is a bit better there, maybe, than the Pro and other.
Yes, I would always, if I had a choice, I would use real time, because I think that makes a big difference. Pro in such a situation is not very useful in an acute situation. Pro we use more in the outpatients to figure out, the whole trends and discuss with the patient. Here we are looking at quick control, rapid control. And I think real time, Anjana, I completely agree, is one. And by and large, there are some concerns about accuracy, but by and large, it is much better than what it used to be a few years ago.
Thank you. Thank you.
Sir, there is a question for Mittal, sir. Are there any data on cases of type 1 diabetes developing post-COVID infection?
Post-COVID in type 1, I'm not aware of long COVID or post-COVID with type 1, but I suspect that they will also be prone. I mean, they would be prone, especially if they're not very well controlled. So post-COVID syndrome in type 1 diabetes specifically, at least I'm not aware of any data. By and large, our type 1 diabetes have handled COVID quite well, actually. They are younger and, they have managed well. It's the in-between ones, the type 2s who are on insulin or more LADA type of diabetes that have faced a lot of problem. But younger patients with type 1 diabetes have been able to handle COVID well if they were managed for their diabetes during COVID. But I have no specific answer about post-COVID in type 1.
Is there any increased incidence of type 1 post-COVID infection?
That's $1 million question, Chandkanta. You know that we don't know yet. A lot of excellent studies, excellent hypothesis. Let's see if it really, it will be very hard to figure out, firstly. Okay, let me tell you, to figure out if type 1 really increased post-COVID. If you know that type 1 can be triggered by any viral infection, so we don't know, but let's see. It's very interesting. But that's
if I may add, we took a quick look at now, incidence of cases coming into the hospital with type 1 and type 2 pre and post COVID. So obviously this is no causal analysis, but just a real life analysis. There was no difference in the incidence pre and post COVID, although there was some suggestion. There was no decrease in C-peptide for the type 2s or, evidence of beta cell damage. We weren't able to, we published this with Anupusha sir recently. So there doesn't appear to be at this point in time a difference, but we don't know yet.
So I think that there is some worsening of glucose control that continues post-COVID, but at the moment, I'm not really convinced that they're developing greater degree of insulin requirements or anything by the large numbers that we are seeing every day. They are taking some time to go back to pre-COVID state, but I don't think that they're really facing any long-term damage at the moment, but this is all very clinical data, not solid studies.
Sir, one question to Ranjit sir. So that was an excellent talk, sir. So my question is regarding the use of antiplatelets and anticoagulants in patients with diabetes in COVID times, sir. So is there any clear indication of the
general guidance about antiplatelets and anticoagulants states that in all hospitalized patients, you should be starting an antithrombotic agent, either heparin, or in our population, in our patients, we generally use the oral agents like apixaban and rivaroxaban. And there is no guidance which says that just because you have diabetes, you need to start somebody on these agents at an earlier stage. Obviously, if somebody is already on an antiplatelet agent or on a statin, you should be continuing them anyway.
Thank you, sir.
Chairpersons, can we wrap up?
Yes. Thank you, sir. Thank you, Amrit sir and Ranjit sir and ma'am.
Thank you for the fantastic session.
It was a really nice session, sir. Thank you so much.
Thank you.
Thank you, sir.
So with this, we now move on to our next interesting session, which is basically a panel discussion on a dialogue in diabetes injectables. The discussion will be moderated by Dr. Arpandev Bhattacharya, and the panelists are Dr. Sambit Das, Dr. Devmalya Sanyal, and Dr. Vaishali Deshmukh. We welcome you all. It's my pleasure, a very pleasant privilege to introduce Dr. Arpandev Bhattacharya. He's a consultant at the Department of Diabetes and Endocrinology, Manipal Hospital, and Professor, Department of Endocrinology, JJM Medical College, Davangere, Karnataka. He's the co-chair of Shivjyoti for treatment and research in diabetes and endocrinology. His areas of interest include patient education in the field of diabetes and endocrinology. Dr. Arpandev has developed guidelines, protocols, and hospital management of diabetes, diabetes management, and after CABG and cardiac surgery, diabetes management after acute MI, endocrine management after pituitary surgery, glycemic management in pregnancy. He has published several publications, over 100 in peer-reviewed and national, international journals. Welcome you, sir. I also request all the speakers who have also joined in, welcome you. And sir, I request you to kindly conduct the session and introduce the speakers.
Thank you very much, Dr. Ranjini. It's good morning and welcome all the delegates for our session. I hope you are as excited as I am to join this panel discussion. I need a bit of a slide share control, please. It is telling it's not. The few of the reasons is going to be, I am very excited to see this. One is it's Dr. Mohan's program. We know that he's a big person to put our diabetes map to the world. Secondly, this meeting is being sponsored by Eli Lilly, and we always respect their program as complete scientific discussion. It's like the advertisement of Sprite, no Bokuwa. So we will not be talking any off-level indication of the molecule we are going to discuss. Thirdly, I have three wonderful panelists. I'm not going to tell their senior, because if I tell them senior, then I'll become Pitama Vishnu. But all three of them has more than 12 to 15 years experience post-DM. Professor Shambhit Das from Bhubaneswar, Professor Debmalia Shanyal from Kolkata, and soon to be Professor Vaishali Deshmukh from Pune. Welcome all the three panelists. You can project the slides. We know very well each other, so most of the time I'm not going to tell Professor Shanyal, I'm going to tell Debmalia what's your opinion. So the way the session is going to go, a few slides I'll be showing just for the context setting, and then I will be trying to discuss a few points. For all the audiences, please put your question in the chat box. Even if I cannot finish my question, I'll definitely take your questions. And please put your chat box, because it will be open and I'll be doing this very frequently.
So you have access, sir?
Yes, I have projected that. My slide you can see, isn't it?
Yes, sir. Yes, sir.
Okay, fine.
Thank you.
Let me do it with slideshow and point. So this is all diabetes injectable. So we have around 50 minutes. So half of the time we'll spend on insulin, and half of the time we'll be spending on the injectable other treatment, that is our GLP analog. We all are contracted speaker with Eli Lilly for this meeting. We know that we have 100 years, and that's what it will look like the picture. So we have seen this again, but it's wonderful to see. The first time insulin discovered, this is Lilly's insulin called iletin 1921. Then you have purified animal insulin. Some time went, we didn't have anything much. Then we have NPH, neutral protein hexadron. Then we knew insulin structure. We knew a little bit of a different concentration. Then DNA recombinant technology, and we are really exploded from there. 1982, DNA recombinant technology. We have the first insulin analog, which is the rapid acting insulin analog, insulin Lispro, in 1996. I think in India it is available just after 3 or 4 years after that. 97, we have a concentrated insulin U500. Then we have insulin aspart, analog basal insulin glargine, we have glulysin, insulin datamide, U300 glargine, also a big one in 2015, U200 Lispro. And we have digludac, the basal insulin, longest acting and quite flat. And then you have a better than the analog aspart insulin. There is a faster insulin aspart, which is available to us, and soon it will be available with the faster acting insulin Lispro. Even if we have so much advancement of the insulin, the fact remains that there are quite a bit challenges there. Let me start with the challenges for the type 1 diabetes. As you all know, whether you are thinking of neonates or the young children or the adolescents or at any age, getting a tight control, achieving a glycemic efficacy in people with type 1 diabetes is quite a bit difficult. A lot of challenges there. With this, let me start my asking my panelists. Now, quickly, Vaishali, what do you think, what do you in your practice finds about the challenges in type 1 diabetes?
Yeah, good morning, sir, and good morning, everyone. And before I answer the question, I'll take this opportunity to congratulate Dr. V. Mohan and team. I think they've done a fantastic job. I'm thrilled to read all the feedbacks on the group, and I'm really privileged to be a part of this. So I'm sure that everybody's enjoying this whole meeting, and I think I talk on behalf of all the panelists. So, okay, coming back to your question then. So, the major challenge in type 1 diabetes is acceptance. So first of all, when they're diagnosed as diabetes, the classic Kubler-Ross phenomenon sets in. So classically, acceptance of the disease is the major issue that the initial phase we have come across, and we come across unanimously in the family also. So not only from the patient's point of view, but the family and the support. Then it comes to, once the acceptance has set in, then that is a place where actually the problem begins, where there is a scare, there is a fear, there is a worry, there is a need for optimization of therapy when it is emphasized. First of all, acceptance of the therapy as injectable. So going on something like an injection for life, I think that is the first scare and worry, not by the patient, but the family also. Second thing is that being a lifelong disease, there are a lot of concerns regarding day-to-day lifestyles. There are concerns about schooling, colleges, how to manage their diets, their nutrition. And in terms of the fear of prick, major concern has been how many pricks to be given, why not minimize the pricks, can it be on oral tablets? So this kind of a search for something like a cure for that disease goes on from all the ends. So I think that first and foremost is accepting the disease, then getting used to the therapeutics of that particular disease. Then the third major challenge is failure to optimize from both the angles, from the doctor's perspective as well as the patient's, because we are scared that the patient might land up with hypoglycemia. The patient is scared that if she doesn't have a proper control, she will get complications or he will get complications, or if she overdoses, then hypoglycemic risk is there. So there are a lot of abstract physical as well as psychological issues which play a hindrance into optimizing that control. And then they are like occupied with self-care. So they are like throughout the day, the parents, the family, the patient, they're occupied with pricking. They get obsessed also at times. You see that they keep on monitoring and they keep on getting worried as to why the sugars are not coming under control. So there is a very complex interaction. And I'm not talking about the psychosocial aspects and the economic aspects at all. Those are additional to all these things. So the economics of therapy, the psychological, the social peer support, and all these things also play a role. So I think it is a multifactorial upset in the whole day-to-day routine of a type 1 diabetes. And we have to really do a problem solving technique at each and every step for a treatment of type 1 diabetes.
Thanks, Vaishali. I think perfect. Absolutely, I agree with all your points. Now, Shambit, just Vaishali mentioned about getting a good, optimize the glycemic control. So what are your strategies to get a good glycemic control in the type 1 diabetes?
Thank you, sir, for that question. Good morning, all. And at the outset, my sincere thanks to Mohan, sir, and the team for giving this opportunity. Now, coming to the question that how we can reach a good target in type 1 diabetes. Now, there are some couple of points to that. Like, first thing is that it's needless to say that for a type 1 diabetes, insulin is one and only therapy, and that has to be continued. And let me be a little bit upfront in telling that multiple subcutaneous insulin or the basal bolus therapy is the ideal. And if the patient can afford, maybe a continuous subcutaneous insulin infusion is also good. But premix insulin is usually not to be preferred. And for basal bolus therapy, I think we should choose a good basal insulin which has got more flexibility, longer duration of action, maybe lesser glycemic variability, maybe the newer second generation basal insulins are good. And we must choose a good bolus insulin also, because as Vaishali ma'am told that the compliance, the flexibility are always an issue. So maybe a rapid acting insulin analog is a good option because it provides a more physiological glucose control, maybe a better PP control, more flexibility, and maybe suitable for the children. And the third important thing is frequency of monitoring. Monitoring is very important in type 1 diabetes, and they should at least adopt some form of monitoring, maybe an SMBG or a CGM. And the fourth point is, which is last but not the least and very, very important, is a good diabetes education. And I think we must make the whole family understand about the situation, understand them about insulin techniques, diet, carbs, and exercises. So these are the few points. If we address all these things, I think we can manage a type 1 diabetes in a better way.
Arpandev, can I make just
please.
one observation?
Yeah.
Both, I think, Vaishali and Sambit have mentioned it, but what I've begun to realize, quite recently, and getting convinced more and more, especially in treating children with type 1 diabetes, is that more than us, whatever we say, they kind of, in fact, one or two patients ask me, do you have type 1 diabetes? No. Then you will not understand. There's no point in even talking to you, because you're not one of us. You're not one of us. You're an outsider. It's easy to take insulin. You don't realize it. Same thing, if you get a type 1 peer to talk to them, you should see the magic happening. The children know their face opens up, and then after that the control becomes easy because it's all in the mind. See, one thing is whether you give basal, bolus, this one, that one, premix. This, of course, there's no role for premix in type 1. But I'm just saying that it's not that at all. More than that, it is the mind. And that mind, if whatever we say, they think, we're either, number one, we have no empathy because we're not having the disease. Number two, he has to say that he's paid to do it. So he'll tell us, take your insulin regularly, test more number of times, come back. That's how they look at us. Whereas when a peer, and especially somebody who's had 20, 30 years, they talk and say, look, the last 35 years I've been taking it. I'm perfectly all right. Somehow that has a tremendous, I think we should bring in, if we have one peer, educator as a peer who's type 1, that makes a huge difference. I thought I'll just raise that point and then just leave it because it's very, very important to connect to them on a psychological level.
Absolutely perfect. I totally agree. And actually, in a lot of different meetings and abroad, particularly the patient group is very, very important. We have like Turner's group, DSD group are there. They can discuss, and it's good for the parents also. And certainly, totally agree with that.
Thank you.
Okay, let's move to this third question in this session. I think I need to move it a bit quickly. It's all very interesting to listen to all of you. Now, can I ask Debmali? I think Debmali, your video is off. I can't see you. Debmali, you can hear.
No, it's on.
Yes.
Hope you can hear me on that. Yeah.
Okay, fine. So some people are using some concentrated insulin. You will be talking now. Here you see, particularly in the children, that you require very small dose. Say 1 unit may be also good. So we need to make it half. So now we are very happy to have this Humulog Junior Quick Pen, which can give up to 0.5 unit. So how much do you think it is helpful in your practice, Debmali, for young type 1 diabetes?
Yes, at the outset, I would like to thank Dr. Mohan sir for the kind invitation. And with regards to type 1 diabetes, it's as we have seen yesterday, we had fantastic sessions where we have seen, the overall survival in type 1 diabetes has now extended over 50 to 60 years. The data was presented by Dr. Mohan sir. And not only we have children, but we have also elderly people with type 1 diabetes as well. So what is very important to realize is that nowadays the targets, if you go by the NICE guidelines with regards to HbA1c control even in type 1 diabetes and even the ADA, the NICE guidelines suggest an HbA1c target of less than 6.5. The ADA also suggests less than 7 in almost all type 1 diabetes, whether they are young or elderly. So that is very important to appreciate. And that is very important to appreciate because about 50% of these patients of type 1 will die because of CKD, which is preventable by a good glycemic control as well. So we need to have a very good glycemic control from the beginning. Now, especially early on, when these children, they, first of all, with regards to pathogenesis of type 1, they do not have insulin resistance as a pathophysiology. Secondly, their body weight is less and they are extremely insulin sensitive. So in these group of patients, because of low body weight and because of their insulin sensitivity, even 1 unit dose adjustment can lead to a hypoglycemia. Whereas if you reduce by 1 unit, there can be significant hyperglycemia as well. So we term them, actually misclassify them as brittle diabetes. Actually, it is a failure on our part to actually titrate. And we have heard again yesterday a lot of talk regarding precision diabetes and accurately titrating our doses. Again, if you have to accurately titrate, as Shobhit has rightly pointed out, with regards to the continuous subcutaneous insulin pump, that's the ideal probably, but it's not affordable for majority of patients, because then we can titrate it even more slowly with smaller doses. But with regards to 0.5 units insulin, it gives us flexibility in terms of titration, because all type 1 diabetes should be treated with basal bolus therapy, and we can adjust their carbohydrate according to their carbohydrate count if they are doing it with their postprandial glucose level. The both hypo and hyperglycemia is also reduced. Not only that, there are recent papers as well, which have, I was asked to review a few months back, and we had a publication there also, that what we found out was that the quality of life also was significantly improved because of lower risk of hypoglycemia, better glycemic control as well. Not only that, it is not only in children with type 1 diabetes, but also elderly in type 1 diabetes, as well as type 1 diabetes who have other complications like CKD as well as or CLD, where we can use this especially to titrate this accurately. And with accuracy and precision, we can achieve better glycemic control, better HbA1c long-term control, reduce the risk of complications, reduce what we call brittle diabetes, and also significantly improve the quality of life.
Thanks, Dharmali. I think some of the questions that I was planning to ask you has already been answered. So let's quickly move to the type 2 diabetes now. So this is what UKPDS has taught, the longest trial then. Then at the time of diagnosis, your 50% of beta cell is gone, and as the diabetes progresses, your beta cell you lose. And if you project backward, this curve starts 100% around 10 years back, which means this beta cell problem started 10 years before diagnosis. We know this very well. Now, once we start metformin and 1 tablet, 2 tablet, and we need to get it quickly on insulin, because unless proved otherwise, everybody with a type 2 diabetes at one point of time, they will require insulin. And this is what my question comes. Now, let me start this question asking first to Shobhit. Let me start. We know this very well. Just for a recap, a quick indications for initiating and indications of insulin and how you initiate.
Thank you, sir. So I think that's a very important and practical question also, and many guidelines have addressed, and they have their points where insulin has to be started in type 2 diabetes. First of all, when a type 2 diabetes patient fails with 2 or more OADs, and that failure is defined as in various terminologies, but maybe the HbA1c is more than 8 or 8.5 with 2 or more oral anti-diabetic drugs. If any time the fasting is more than equal to 250 or random is more than equal to 300 or HbA1c is more than 9, so even from the beginning also we may start for the early initiation for a shorter period of time. Any patients with type 2 diabetes having emergencies like maybe hyperglycemic, hyperosmolar state, or any stressful events like surgery, illness, maybe a perioperative period, steroids, infections like tuberculosis, I think there the indication of insulin is absolute. And suppose, as you have told, that almost at the diagnosis 50% is lost, and in due course of time there will be beta cell exhaustion, and later if the patient presents with any osmotic symptoms or symptoms like that, then we can start with insulin also.
Well, thanks Shobhit. So this is, we are talking about type 2 diabetes. So we are with insulin, we'll combine with, unless proved otherwise, combine with oral tablets, also other injectable like a GLP-1 receptor analog that will be coming in the next session. But what sort of strategies you follow when you use the combination therapy, combining insulin? Which one you modify, which agent you modify, which you don't modify? Some tips for us.
Hello, am I audible?
Yes.
Yeah, with with regards to combination therapy with insulin, and especially if we come to OAD, especially metformin, is something which has been shown to reduce insulin dosage, which has been found to improve glycemic control, as well as have been associated with less of weight gain with insulin. That is definitely to be continued unless there are obvious contraindications. Second, of course, with regards to OADs is DPP4 inhibitors, which has also shown data with regards to better glycemic control, reduction in insulin doses, as well as because of the GIP effect on the glucagon, where during hypoglycemia, the glucagon levels actually improve, and they have a protective effect during hypoglycemia. So now also that would also really go a long way, especially there are studies to suggest with when we are using combination of DP4 inhibitors with insulin, not only dose requirement is less, control is better, but also the hypoglycemia is less. So that is again something we can continue. Now we have evidence with regards to SGLT2 inhibitors as well, which we should be continuing, especially in view of the advices where the different bodies have suggested because of renoprotective and cardioprotective effect and protection in heart failure, and also reduction in insulin dose and weight. But one important caveat when we are using empagliflozin along with insulin is that sometimes we tend to rapidly reduce the dose of insulin. That is something we should not be doing, because there are several reports suggesting that this, especially in a patient with long-standing diabetes, may precipitate diabetic ketoacidosis as well if we rapidly reduce the insulin dose. So something we should be also careful about. Otherwise, they are helpful. Now, with regards to pioglitazone, there is some amount of confusion because that may cause additional weight gain. But in some patients with requiring very high dose, we sometimes use low dose pioglitazone because that may reduce the insulin requirement. But the European authorities do not advocate use of pioglitazone along with insulin. Now, with GLP-1, this is one of the most favored concept over the years. Now it has come up, the basal with GLP-1 concept, which actually they are actually complementary. Basal insulin, especially controlling fasting, the GLP-1 controlling the postprandial spikes, the weight is neutralized, or weight, actually there is further weight reduction with addition of GLP-1, and also the hypoglycemia effects are also reduced. So obviously GLP-1 and insulin, especially basal insulin, makes a very rational combination as well. And we have also data with bolus insulin and GLP-1 as well, especially with the longer acting GLP-1 as well. So nowadays, if you see the recommendations of certain societies like ADA suggest use of GLP-1 as the first injectable, then we can add insulin later on. If the patient is very uncontrolled, having catabolic state, then we start insulin, then we subsequently add GLP-1. So the either way, the options are there.
I completely agree. So now on this session of the type 2 diabetes, Baishali, my last question about what are the tips you are giving to us that to manage this type of people when you started on insulin, about the monitoring frequency?
Okay,
And
so
the target, obviously the target also.
yes, sir. So basically, insulinization involves 3 steps. So one is initiation, second is titration, and third is optimization. So I think unless titration is offered, the insulin therapy doesn't make any sense to the patient. So this needs to be explained to the patient that we are starting you on insulin, but you definitely need to titrate it. Otherwise, it's not going to help your control. And not only titrate it to target. So 3 important thing which patient needs to know is that he needs to monitor once he's on insulin. Secondly, he needs to know his targets. So I have to give each and every patient what target I expect him to achieve by taking this insulin. Thirdly, I need to empower him as to how I can do that. So probably the simplest way, especially when we are talking about basal insulinization as a first therapy, or maybe a single dose of insulin, it is better to target the fasting first. So the concept is that we tell our patients that you get your fasting under control. Don't be in a hurry to increase the doses very drastically. Go very gradual, 2 to 3 units every 3 to 4 days, or maybe even weekly in certain patients. And once they are empowered, the loop is completed. It's not that we have just started insulin and the patient is not monitoring and he's not getting you under that particular phase of completion of the circle of control. So I've seen in practice most of the times the insulin is begun very enthusiastically. The failure remains in the patient to uptitrate as well as doctor to tell him to uptitrate. So there I think it is a dual responsibility that the doctor, the educator, as well as the patient needs to understand how he is going to go about with titration. And the titration algorithm may differ for every patient, or you may have a standard algorithm. So you can give, I usually do that in my clinic. I give them a standard printout or a WhatsApp message that this is the way you should go about if your fasting is above so and so. And once the fasting is reached into a target goal, then we insist on getting the postprandial under control. Most of the times when patients have begun on insulin, I see that they are followed up within 15 days to a month's time, so that we can guide them further on how they should go about in further titration. The frequency of titration can go down eventually once the patient has achieved a better control. So you need not be very intense, and that may be decided individually and on the basis of what type of diabetes the patient has. So I think this is what it's a part of education which needs to empower the patient.
Right. Thank you. So we got the import. I'm sure the audience, all of you are very comfortable with the clear answers. We need a customized target. We need a bit empowerment, patient empowerment. They can handle themselves. That will give them confidence and fix fasting first. That is very, very important, this type of people. Let's quickly move to the type of insulin. Now we talk about conventional insulin. I have shown you a flowchart, analog insulin. Then there are regimen of insulin, whether basal or premix or a basal bolus insulin. And then there is a combination of insulin. So basically, we have now conventional human insulin, then analog human insulin, like in regular insulin and insulin Lispro, which is the first one. And the different authorities, they recommend about which regimen to start. As you are very aware, the ADA, AAC are very interested to start the fasting first, the basal only. But we do see our people, the postprandial peak is a very issue. So we have a definite place for premix insulin also to start with, whichever premix, whether conventional with analog. So in this context, let me just ask a bit one or two questions to answer very quickly. Now this will be for Deb Malia. So you see that when you are searching a short-acting analog insulin, we call this very quick-acting, it's very flexible, so you can each shift the time. How much these wordings are acceptable or preferable in the clinical practice? How many people like?
Well, again, this is something very important to realize that, especially, when it comes to our busy schedule nowadays, what we have, and also if you ask most of our patients, regular insulin probably still is prescribed to most of our patients considering the cost. But if you ask most of our patients, rarely any one of them, in spite of being advised, would be taking the insulin half an hour before their meals. So most would be injecting them immediately before the meals. And again, there is limitation with regards to flexibility. And also we find in a lot of patients, there is a between meal hyperglycemia, and also the postprandial glucose is not well controlled. So in such a scenario, especially with regards to when the control of postprandial glucose is inadequate, there is between meal hypoglycemia, as well as when a person requires flexibility, then this analog insulin has definitely an important role, especially it matches the first phase insulin secretion which occurs naturally, and so that there is better postprandial glucose control, there is better flexibility. You can inject immediately or even inject sometime right after the meal, especially in patients who are hospitalized. There is a very important issue because the insulin is given and immediately the meal is served. So that is also something we have to always take into account when we are using this in hospitalized patients. So obviously they have a role because of their flexibility, their ease of use, better postprandial control, and also lower hypoglycemia risk. But with regards to HbA1c, the data is still not very convincing with regards to whether they actually have a big impact on HbA1c between regular and the analog insulin. But these are the important issues where we can consider the analog insulin.
Right. Thank you very much. Now, can I ask the next one to Vaishali? Say you have taken an example. You have a type 2 diabetes people, say 5 years or 6 years, we have given tablet. Control is not good. We have decided to put on insulin. So on one hand, I am giving you a regimen of basal bolus insulin, and another hand is the premix insulin. So what are the factors that that comes to your mind when you decide about which person should go on a basal bolus, who goes to premix insulin?
So once the patient is being initiated, the guidelines also say, and my practice also I follow this, that I prefer using the basal first, because mainly, especially if the patient is having fasting hyperglycemia, my concept is to fix the fasting, and the patient gets acquainted better for to insulinization with the basal insulin, because the risk of hypoglycemia is less, the administration time is very flexible, and the patient doesn't really need to take care of his meal timings and all these things with the basal insulin. So I think to break the ice and start the insulin, basal insulin is the easiest in practice and easiest for the patient to accept. Now, coming to where I would think of premixed first as the first choice is when patients have very high HbA1c and they are actually candidates where they are having a lot of postprandial spikes. They are patients who are eating 2 large major meals, very high GI food intake, or maybe if they are having they are actually indications for basal bolus but are refusing to take 4 doses. These are the patients where I think of starting premix first. So I think it would be individualized very much, but given the comfort and given the strategically scientific approach, I would prefer starting with basal, then going to a premixed, and then going to a basal bolus kind of regimen based on how the patient accepts it.
Right. Just as a part of a continuation to this, if I can ask Shambit, so what is your Indian context? How often you initiate them with, say, Humalog Mix 25 or Humalog Mix 50?
In these situations, sorry. Go ahead.
Thank you, sir. So I think I agree with Vaishali ma'am, but in Indian scenario, it is a little bit different, because most of the time the postprandial is higher, the patient needs more flexibility, and compliance is an issue. So premix insulin still holds important role in Indian setup, and though we need to do individualization for each patient. Why I tell premix insulin is also important, because it's easier to initiate with one pen, then you can optimize, you can uptitrate, you can intensify in the same pen or the same insulin also. You don't need 2 types of insulin at a given time. So in that sense, I think the Humalog Mix 25 and 50 are good in that you start with one, then go for 2 and maybe 3, and there are evidences to suggest that that optimization and intensification can be done with the premix insulin. Now coming to high mix and low mix, we have definitely a good array of mix 50 and mix 25. And the advantages in Indian patient or in many patient is that the postprandial sometimes is a big issue while intensification or optimizing the therapy. And probably the post breakfast and the post lunch are always an issue. And there, if we are giving a high mix at the breakfast and the lunch time, and maybe a low mix like Humalog Mix 25 at before dinner time, so that will take care in a much better way.
Right. Thank you very much. I think we need to move little quickly. My last session on this, on the special situation, I will pick up 3 special situations. One is pregnancy, one is CLD, CKD, and one, obviously, what we will be discussing all the time about the COVID and steroid-induced hyperglycemia. This is a real, difficult situation. As you have all understand, I work in Manipal Hospital, Bangalore. So we are really people with 400, 600 blood sugar. And most of our people are actually on a basal bolus insulin, and is correctly told, Indian people plus steroid, the postprandial control is a real problem. And we have just one concentrated short acting available for us at this point, that is a Lispro 200, and that's what we are using. Shambit, do you use this, and how much helpful in this situation?
Yes, sir. As you have rightly told that with steroid, the postprandial hyperglycemia is a huge problem, and they are absolutely in insulin resistant state, and maybe the usual doses which we start like 0.2 or 0.3 units per kg per day, I think that goes to more than 0.6 units per kg per day. So, and a higher bolus requirement. So even if we are giving a basal bolus therapy, which is the most ideal, then the basal bolus division is also different as per the different guidelines. Like 30 to 40% should be basal, and maybe 60 to 70% is bolus by most of the guidelines in steroid-induced hyperglycemia. And fortunately, we have a concentrated insulin in the form of bolus insulin of Humalog 200. And many times the bolus requirement goes more than 20 units per day. And probably there a concentrated insulin is better, because in a given pen you have more units, like maybe 300 in a less concentrated to 600 units in a given pen of Humalog to 200 IU per day. Lesser volume of the same dose can be injected, and they've also shown some better gliding force and better compliance. So I use the concentrated insulin in patients who are admitted.
Right. Thank you. So I think nobody can be better at this point to answer my next special situation. Devmala is very interested in putting some people making a series, and I very nicely read your articles, Devmala. Congratulations. But a quick answer to a question. Choosing the right insulin and CKD CLD, do you find analogs better?
Yes, with regards to CKD and CLD, the pathogenesis, if you look at in brief, in both CKD and CLD, in the early stages, there is a huge rise in insulin resistance. Whereas, as we are all aware, that both the kidney and as well as the liver are important sites for insulin clearance, as well as neoglucogenesis. Liver contributing 70% and kidney contributing 30%. So early stages, especially, we require higher doses, especially with patients with early CKD or even NASH, where we require higher doses. And because of higher insulin resistance, probably basal bolus therapy, and especially as Shombit mentioned, here the postprandial spikes are even higher. So we would require a concentrated bolus insulin or a higher amount of premixed insulin, premixed 50-50. Whereas as the CKD or the CLD progresses, especially in stage 3 and stage 4, so what happens is, one is the neoglucogenesis comes down, as well as the insulin clearance decreases. So both these factors increases the risk of hypoglycemia, whether in CKD or CLD as well. So in those cases, the basal insulin requirement goes down, as there are certain recommendations when the GFR goes below 50, we need to reduce the basal requirement by 25%, and especially if it goes below 15, reduce the basal insulin requirement by about 50%. Especially patients who are on dialysis, on the day of after dialysis, where there is a reduction in insulin resistance because of because of dialysis, and you get rid of the toxins, uremic toxins, there also you need to reduce the basal insulin dose by 25%. But mind you, there is not much change with regards to bolus insulin. And in this group of patients, probably the requirement of basal insulin comes down. We generally depend on bolus insulin. And again, because of higher risk of hypoglycemia in this group of patients, probably 0.5 units insulin may also be beneficial, because we can titrate better and we can have a lower risk of hypoglycemia in the late stages of decompensated CLD or late stages of CKD requiring dialysis.
Okay, that's very nice. Thank you very much. And we'll wrap up with the insulin session with the last question to Vaishali. A quick comment. I have attended, Vaishali, your sessions about pregnancy diabetes management. Wonderful talks. I have listened so many times. But just tell a bit in a simple way, human conventional insulin versus analog insulin in pregnancy, say in GDM. Let's speak of in GDM. Do you always use analog insulin in the pregnancy?
So I have recently started preferring analog insulin for various reasons, because pregnant women have very erratic meal patterns, and they may be vomiting and issues related to intakes, lot of acidity problems. So I prefer that something which is given immediately at the meal time is what is more preferred for these patients. Most of the GDMs tend to have postprandial spikes. So I have hardly seen fasting hyperglycemia as a major problem in GDM. So most of them require prandial insulin. So prandial analogs have a good safety data, and I think that they do not, these insulins do not cross the placenta. So our fear that it will harm the fetus or it will cause any teratogenic effects is also not there. So I think the comfort of using analog insulin in pregnancy is much more, and especially with the junior pens, I have seen that they require usually 2 units, 1.5 unit, 4 unit, very minute amount of insulin. So I think even those pens work wonders in pregnant women. So I think that it's a very good asset that we have in our hands for GDM management.
Yeah, thank you very much. I think we have around 15 minutes left, so let's utilize this time for the other injectable treatment. We are in injectable symposium, and we'll be quickly going through this, and little bit of a context setting I'll do, just because we are changing one injection to the other. So we all know this very clearly, that if you give glucose by oral route, that is the green, and by IV route, that is yellow, to raise the same amount of glucose, insulin levels are completely different. This is a normal healthy volunteer. If you give oral route, insulin is much more in comparison to intravenous route, and this gap is extra insulin called incretin effect, which is something coming from the gastrointestinal system. And this is for the healthy volunteer, and we know that people with the type 2 diabetes, this incretin defect is deficit. To improve the incretin effect, we can inhibit the enzyme which degrades this GLP-1, which is basically the incretin, by using gliptin, or we can use the GLP-1 receptor analog. So this is an injectable treatment. That is our next concern. So beginning of this century, we had exenatide to be given twice a day. After that, we have liraglutide to be given once a day. And now, last around 6-7 years, we have once in a week injection, that is dulaglutide. This is the only once in a week GLP-1 receptor analog available in our country. So we will go through this injectable portion about treatment in the people with the type 2 diabetes. Okay, type 2 diabetes, once in a week injection of GLP-1 analog, which is dulaglutide, available in the name of Trulicity. Now, this is what I wanted to ask you. Now, on the left side of the screen, you see the randomized control trial where you are comparing dulaglutide and liraglutide. So liraglutide 1.8 milligram daily and dulaglutide 1.5 milligram in a week show equal HbA1c control. If you compare dulaglutide and glargine, dulaglutide once in a week, glargine daily on top of metformin, sulfonylurea in people with type 2 diabetes, very surprisingly, HbA1c control is much better. And if you forget about the weight gain and hypoglycemia thing, which will all favor dulaglutide. Even when you are using the bolus insulin, basal bolus regimen insulin glargine, if using dulaglutide, and people with the CKD, Devmale already mentioned about the CKD, and actually showed a quite HbA1c control. And the right side, you see the real world study, and these arrows are from the Indian. There are 6 studies published till now for the Indian with the dulaglutide, and you see the average HbA1c control is actually quite good, and lot of studies showing more than 1%. And this brings me to the first question to Dr. Shambit. So what are the factors you think that influence that about type 2 diabetes when you are starting on somebody dulaglutide 1 in the injection? What are the factors that you consider, including the combination therapies?
I think once the A1C reduction you have shown in the randomized control trial versus the real world setup, there was more A1C reduction in the real world setup. And I think the HbA1c reduction depends on many factors, like what other drugs we combine with this dulaglutide. I think the real world evidences we have shown that as the baseline A1C is higher, the better is the reduction of A1C. And some of the associated drugs, like maybe the use of an SGLT2 inhibitor, sulfonylurea, insulin, the metformin and its doses, all influence the extent of A1C reduction if we are using a dulaglutide with that.
Right, Devmala, I will come to that with the weight issue, because the weight is very, very important with the treatment of type 2 diabetes. So there are clear data available that if you increase the weight by 3 kg, it nullifies your benefit of HbA1c reduction by 1%. I repeat, in treatment of type 2 diabetes, if you increase the weight by 3 kg, you nullify the benefit of reduction of HbA1c by 1%, such a big magnitude. So whatever treatment we are giving, they should not cause weight gain, they should be weight neutral, and if possible, they should cause losing weight. And that's what happens with the dulaglutide. If you see this 1.5 milligram, that is our dose, that causes a very significant weight. The awards reach of the trial And also in the right side of the slide, the real world evidence also quite significant. Some of the Indian centers showed actually 6 kg weight loss in a period of 6 months with one dulaglutide. So Demala, what is your opinion about the benefit that you see in our real life about the weight loss? And do you have a place to think? I know the dose is 1.5 milligram, that you see that when you increase the dose, weight loss is a bit more?
Well, one is, as you just rightly pointed out, the HbA1c weight paradox, especially with regards to HbA1c reduction with medication and the weight increase. So obviously we have, we had few published data, early published data, even with a low dose of GLP-1s suggesting similar amount of HbA1c and weight reduction. And especially probably because of our GI intolerance, especially in our population, which Orpunda, you are also very well aware of, because of a lot of GI intolerance. A lot of patients are unable to tolerate the higher doses of GLP-1. So even with a low dose, like means 0.75 milligram of dulaglutide or a lower dose of liraglutide as well, we have seen that we have a significant amount of weight loss and good glycemic control, and the tolerability especially is improved. There is a significant proportion of patients even with dulaglutide who actually attain a huge amount of weight loss, more than 6-7 kg. I have had patients about maximum of about 10 to 12 kgs of weight loss, who have had 10 to 12 kgs of weight loss. But those are probably the outliners, but average we generally see a weight loss about 4 to 5 kgs in most of our patients with a standard dose. But even with a low dose of 0.75, because sometimes we cannot up titrate from a lower dose because of GI intolerance, because once we up titrate, they do not tolerate it well. So even with those, they have a reasonable amount of weight loss, about 3 to 4 kgs in a significant proportion of the population. And if we look at the randomized control trials as well, if you see the difference in weight loss as well as with regards to HbA1c, it's not very much significant, about 2 kgs with 0.75 and about 2.5 to 3 kgs with 1.5 milligrams. Similarly, the HbA1c reduction is between 1 and 1.5. So that's not a very big difference. And in a significant proportion of our patients, probably in our Asian population, we can achieve those similar amount of HbA1c and weight reduction with a probably lower dose, which probably is required in a population of ours, in a section of patients who do not tolerate the higher dose.
Right, absolutely agree. So let's move on a little bit from the glucocentric. We are talking about the glycemic efficacy, HbA1c control, to the organ protection centric. That's what we know, because 2/3 of the people, the mode of exit with the type 2 diabetes is the cardiovascular, atherosclerotic cardiovascular disease. So we need to protect this thing. Now we have people with cardiovascular risk factor. I'm going to ask this to Vaishali. We have people with a cardiovascular risk factor and cardiovascular disease. Cardiovascular disease will mean they had a bypass graft, they have an angioplasty, they have an AMI or something like, or they had an ischemic stroke or something like that. And the risk factor means they can make the risk of developing the cardiovascular disease more. So as you see, the different clinical trials to show the improvement of the cardiovascular outcome, we have always recruited more people with the cardiovascular disease, because the events will be early, and you can get the statistical number early, so you can finish the trial early. But this is one of the cardiovascular trial which is called Rewind with the dulaglutide, where 30% of the people only have a disease. Though 69% of the people have cardiovascular risk factor as our in the routine clinic. And that's what exactly I wanted to ask Vaishali. In your clinical practice, when you are seeing in your OPD or in a clinic or in the hospital, so what is the sort of proportion of the cardiovascular disease and the cardiovascular risk factor? And that can motivate us so that people with a higher risk factor, we can recruit more people with the dulaglutide. It gives us long-term cardiovascular benefit.
Yes, sir. So I think in our practice as diabetologists and physicians managing diabetes, we come across more patients with the risk factor rather than the established cardiovascular disease. And this may vary anywhere. If you have to go to the Indian literature, it may vary anywhere from 40% to 70%. So if you take risk factors like hypertension, dyslipidemia, 60 to 70% of our diabetics would have that. Even in my own practice, I would say around 30 to 40% do have very high risk factors based on the ASCVD calculator. So I think and if you talk about diabetes as a cardiovascular equivalent disease or angina equivalent disease, I think all our diabetics are at high risk. So considering this whole scenario, I think Rewind has a very good implication in our patients, because this is the kind of population that we deal with. And if you have something like dulaglutide, which is actually preventing the cardiovascular progression or risk, I think it's a good achievement for early diabetics, and the progression of cardiovascular disease and renal disease is much less in that kind of a scenario.
Well, thank you. So basically what we have seen in the Rewind trial, that in comparison the placebo and standard of care, the dulaglutide arm did do well with the 3-point MES, that is non-fatal MI, non-fatal stroke, and the cardiovascular death. And this happened people without prior cardiovascular disease and people's whatever HbA1c, they are less than 7.2 or more than 7.2. You look at that 7.2 we are talking. Now, to prove this, we had to continue the trial for a long time to get the statistics right, which is around 5.4 years. So can I ask this to Shambit now? So how do you find this, that the follow-up is long? So we have long exposure data on the people on the dulaglutide in comparison to any other molecule in this spectrum for cardiovascular outcome trial. How much reassuring is this in to start somebody on dulaglutide?
Yes, sir. I think Rewind trial, as you have rightly mentioned, that it's a event-driven trial, and more for the primary prevention or only risk factors. People with risk factors were more, so it took a longer duration, maybe around 5.4 years. So that's actually a very positive point, in that I find in clinical practice that we have a huge data, or the patient years exposure to this kind of drug is really good in comparison to other molecule in this class. So we can actually extrapolate that the safety, adverse event, and any other serious adverse events, where definitely we have a better data with this group of molecule compared to other in that same class. We just cannot tell about the efficacy, but definitely we can tell that at least for 5 years we could maintain the durability of the glycemic control. So these are the 2-3 points which come in our clinical practice from Rewind data.
Good. Thanks very much. Now, if we see a bit of a CKD, now, Vaishali, what sort of your cutoff GFR you will give dulaglutide?
So dulaglutide in various studies, especially the award studies in CKD, has shown that it has been tried between eGFR of 15 to 90. So I think the safety range is very wide for eGFR. Below 15, there is no such data available, but as of today, we are using it in eGFR above 15.
And Devmale and Shambit, do you have people on CKD on dulaglutide in your routine practice?
Yes, we have patients, especially especially CKD 2, 3, 4. Obviously, in CKD 5, patients would not tolerate it, and it's not recommended, as the cutoff is about 15. And the glycemic control is good, and especially most of these patients would not require, a significant proportion of these patients would not require insulin, and especially in these late stages of CKD, the hypoglycemia risk is also significantly less. And in some patients with CKD also, weight is an important issue, and therefore that also is controlled to a good extent, and especially the most important factor remaining a good control with low risk of hypoglycemia in this group of patients. And also this is probably the only agent in the GLP class as a whole which has shown, though as a secondary outcome, has shown a hard renal outcomes data. With regards to the other GLP-1, they only reduce the albuminuria. Only dulaglutide has evidence, though as a secondary outcome, with regards to preventing progression of CKD, with regards to decrease in GFR, as well as end-stage renal disease. Probably the only data is there with dulaglutide. Other agents only decrease the albuminuria.
Shambit, do you have anybody, Shambit?
Right, sir. I also echo the same thing as Dr. Debamalya. Only thing is that practical point is that when we are using in CKD and mostly in advanced maybe 3 and 4, so probably the GI intolerance has to be taken into account. And if the patient nausea and vomiting is more, I think we should be slow or we may discontinue also. Otherwise, it has got a very good data on CKD progression also.
Yeah, I think whatever the answers I wanted to get, I was asked if I got of them. This is one of the slides which showed about the adherence. Now we understand very clearly if the adherence is better, compliance is better, control is better. And this slide, as you see, up to 300 days of data, actually dulaglutide scores the maximum. Overall, GLP-1 is also good, but dulaglutide is better than the average it is doing. And we understand there are some adverse effects, which are basically the gastrointestinal, the nausea, which goes off with time. I think all of us have similar experience. Around 4 or 5 weeks it takes, but probably 1 or 2% of the people will have to withdraw that. We'll have to accept, because most of the diabetes molecules, everybody, 100% of the people will not follow. And I thank very much for all the panelists, Vaishali, Shambit and Dev Malia, and also Dr. Ranjini, giving us an opportunity. Good luck to you all. I think we are just in time.
Yes, sir. Thank you so much. Wonderfully moderated, sir. You covered everything.
Thank you. Thank you
so
the
much. Thank you. With this, we move on to the very important symposium, which is on diet and diabetes. Generally, the symposium in our live conferences, we'll have some 500 women attending, and it's a big, big hit. So doing this virtually now, we have equal amount of audience looking and hearing in virtually too. It's my very pleasant privilege to introduce my senior colleagues and friends here in this symposium. So the chairpersons for the symposium are Dr. Jagmeet Madan and Dr. R.M. Anjana. Dr. Jagmeet Madan is the principal and professor in Department of Food, Nutrition and Dietetics at Sri Vitaldas Thackeray College of Home Science and SNDT Women's University, Mumbai. She's the national president for Indian Dietetic Association. She's a member of National Registered Dietitian Board, National Steering Committee of NET-PROFAN, FSSAI, Government of India, National Expert Working Committee on Asian and Indian Consensus Statements and Guidelines on Obesity, Diabetes, Cardiovascular Disease, and Physical Activity and Gut Health. She's an Indian representative for International Confederation of Dietetic Association and Asian Federation of Dietetic Association. She is a recognized guide for PhD, SNDT Women's University, Mumbai. Dr. Jagmeet is the principal investigator for several international and national projects and has several publications to her credit. We welcome you, ma'am, to our conference. I next invite our chairperson, Dr. R.M. Anjana, Managing Director, Diabetologist, Dr. Mohan's Diabetes Specialty Center and Vice President, Madras Diabetes Research Foundation. Her main areas are prevention of diabetes, epidemiology, physical activity, translational research, and technology related to diabetes. She's a PI and co-PI for several national and international projects. Dr. Anjana is a recipient of several awards.
We can skip. Yes.
Let me just wind it up. So including many awards, including one of the main ones, Shakuntala Amit Chand Prize from ICMR. She has several publications to her credit, and I will hand over the dais to both of you and welcome my friends Cheryl Salish, Shilpa Joshi ma'am, and Sudha ma'am. Look forward to a good session.
Thank you very much, Ranjini, and welcome Jagmeet Madan ma'am. We're so happy to have you here. So welcome to also all our speakers, Cheryl, Shilpa ma'am, and Ms. Sudha Vasudevan. It's a bright Sunday morning, the perfect time to discuss diet. Over to you, Jagmeet ma'am, if you'd like to introduce.
Before Jagmeet, introduces them, I just wanted to, thank Jagmeet for being here. And I wanted to say that it's a coincidence that the three S's are going to speak in this session.
Oh my goodness.
All three women and all three S's. So I was struck by the coincidence of that. So thank you, Cheryl. Thank you, Shilpa. And thank you, Sudha. The three S's, the three S stars.
Thank you, Dr. Mohan. I'm extremely privileged and humbled for this opportunity. And believe me, it's such a joy to be a part of Dr. Mohan's International Diabetes Update 2021. It's much sought after event every year. I think every year, all of us look forward to this event. Let me make a submission, Dr. Mohan, in your august presence. That I was really personally inspired to read your keynote address on my 40 years journey in diabetes research. I think it was just so inspiring, so phenomenal, starting from a medical student and how you, favored your journey from simple researchers to collaborations, networking. And I think Indian database is indebted to you, Dr. Mohan, for the kind of research you brought in the Indian scenario, the threads which have emerged starting from like in the whole sphere of diabetes, starting from the prevalence to the the medical and nutrition management, to the detailing of the phenotyping of diabetes patients, and now you're looking at precision diabetes, microbiome, genetic mapping. I think sky is the limit, and we are folded hands. We are extremely thankful to you, sir, to bring this kind of literature to Indian database. My only humbling request at the at the outset and the beginning of this session is that on this dais I extend on behalf of the entire fraternity of nutrition and dietetics a collaborating hand to further strengthen the the vertical of nutrition science along with the diabetes science. I think we really need to strengthen and generate that evidence-based nutrition data, which goes very, very strongly with the diabetes management. So I think I just thought this would be the right opportunity to make a request, and it's an open request from the entire fraternity that, like you said, there is so much strength in coming together, in collaborating. So we are here, sir, to brainstorm the research questions in the arena of nutrition and dietetics and diabetes, and take it forward under your esteemed guidance and your very, very eminent team, which is already doing such a fantastic job.
No doubt, happy to collaborate, and we are waiting for such an opportunity because I think we need national level collaboration. And after that's the very idea behind bringing all of you together. You'll find different people together. We need some kind of a national first meeting. Dr. Anjana, I'll keep in touch with you, and Sudha, because we have some very, very exciting data coming up from INDIAB. And so I think that will form the framework on which we can build some kind of national guidelines and also continue to collaborate and collect data. Thank you.
Thank you. Thank you, sir. Thank you so much. So I think, Anjana, we are in a symposium which is really very, very much sought after. And I know I've been physically once to this symposium in Chennai, and that's where I had the good fortune to visit your Madras Diabetic Research Foundation. And Sudha was so kind to invest that kind of time. So I think we have an excellent panel of speakers today. And let me, without wasting any more time, come to the first speaker. That's Ms. Cheryl. Cheryl is a very, very dear friend, very dear colleague, and I think we worked together for years. And let me introduce you, Cheryl. She's a founder and director, Nurture Health Solutions, Mumbai, a very, very sought after diabetic expert. She's a registered nutritionist, naturopath, certified diabetes educator, wellness coach, lecturer, health writer, and insulin pump specialist. She has a huge, 20 years of experience in the field of dietetics and diabetes education. And let me definitely add, she is the author of the award-winning book, Diet and Diabetes Simplified, your personal diabetes nutrition coach. And I have myself, recommended that book to so many of my colleagues, my students, anybody whom I knew. I felt that it's a huge contribution. And I also take this opportunity to place on record, Dr. Mohan, I think your books and your videos have done wonders during COVID times. And I think the way you can explain so many things related to diabetes, I think it is heartwarming. So Cheryl, without any further ado, I invite you to make your presentation.
Welcome, Cheryl.
Thank you. I just share my slides. Are my slides visible?
It's coming up, Cheryl.
Yes, yes.
At the outset, I'd like to thank, I couldn't have had somebody better to introduce me, and thank you so much, sir and Dr. Anjana, for this invitation. It's a pleasure and an honor being here. And in the next 15 to 20 minutes, I'm going to take you all on a virtual tour of India, because we're not going to be traveling by plane, but I'll try and do my best and ensure that I make you hungry enough for lunch. And I think this is something that, is quoted very often in all the nutrition sessions, as well as by doctors, the START study and What India Eats. That was a document released by the NI and ICMR. And we know that, Indian diets are very high in carbs with deficiency of protein, and we're celebrating the protein week, and we're all emphasizing the need to improve our protein intake in terms of quality as well as quantity. Even if you look at the protein that we're getting from is mostly from cereals and millets, and therefore not of the best quality protein. Cereal consumption is very high in our country, and there is a declining trend in terms of protective foods like pulses and milk. And Indians are consuming fewer carbohydrates and proteins from your pulses and vegetables, etc. The PURE study, in which sir has definitely been a very, very integral part of, has clearly shown that high carbohydrate intake is associated with higher risk of total mortality, whereas total fat and individual types of fats. It's, I think, every decade there is a nutrient which is focused on. We had fat, which was a villain, and today we're talking about carbohydrate being a villain, and people are confused as to what to do. But this clearly has shown that, yes, a high carbohydrate diet is detrimental to health, and looking at good quality nutrients from carbs, protein, and fat is very, very essential. Now, we all know when we see our patients, when they visit us or during follow-ups, that the A1C has always been a challenge. With average A1C for our country is around 9%, and compliance is very poor. And also, if you look at the data, the HbA1c, at a higher HbA1c also, they've seen a contribution of postprandial blood glucose. And since we are a carb-loving country with high intake of dietary carbohydrates, this in fact reflects your high postprandial carbohydrate levels, and therefore moderating carbs is very, very essential. Now, if you look at our snacks, even when we take dietary recalls, not only are our snacks very high in carbs, and fat, especially saturated fats and trans fats, but also the dinners have been replaced by snacks today. In fact, from the side of the country that I am from, western part of the country, we have a large population which have replaced their dinners with snacks such as pani puri, sev puri, sandwiches, and there's a lot of carb intake, especially refined carb intake and fat intake, which is impacting health in an adverse manner. Now, lockdown has not really proven to be beneficial because people have been home. There's a lot of anxiety, stress, physical activity has been very low, and the consumption of fruits and vegetables because of availability. And also that, mothers have donned their chef caps. And even if you look at YouTube, the most popularly researched or, Googled food was how to cook restaurant style cooking, and banana bread was one of the most popularly made bakery item. And the sale of bakery products also went up during the lockdown. And again, eating out is becoming common, ordering in is becoming very common now, and unhealthy, high fat, high carb snacking options. Our children are also becoming addicts to gadgets, and today we have to force them to go down to play. And even in our clinic, we've seen a rise in the number of children coming to us with obesity and type 2 diabetes. So again, when I look at my journey 20 years back from where I started, we had a general diabetic diet. We used to give cyclo-style sheets in 1200, 1400, 1600, 1800 calories. The list of no's was more than the list of allowed foods. And people used to really not come back to us for a follow-up because they were so disappointed after meeting us, because there's a big list of what not to eat and a very small list of what to eat. And it was a one-size-fits-all approach. Like, you come from any part of India, whether South Indian, you will still get a diet which I'm accustomed to, and therefore people really did not follow up, and compliance was really, really poor. Now it's no longer a diabetic diet. So there is no diabetic diet. It's an entire family who follows a healthy eating plan. It's not a one size fits all. It's a customized, designer, personalized meal plan. It has to be flexible because people are working long hours, people are working in shifts, they have different kinds of jobs, routines, challenges, and therefore it has to suit even their medical management, because the kind of drugs that are available today, even in terms of insulins or the drugs, each prescription will call for a tailor-made designer meal plan. I would say designer is because it has to be really customized, but not necessarily exotic foods, your local seasonal foods which are readily available in the part of the region that you are in. It has to be personalized to meet needs as well as regional preferences. And therefore, the concept of culinary science, it's about promoting healthy behavior among everybody, because we have a large population with pre-diabetes, to improve adherence, which is the major challenge in our people with diabetes. So one is giving the right messaging about food, removing the fear of food, bringing back the joy of eating and living with diabetes. So it's all about living. We often hear the saying suffering from diabetes, and we also use it sometimes. So it's very important to give the right messaging. Language matters. Focusing on quality as well as quantity. So while we're looking at cutting down quantity, so when we're cutting down the calories, it's very important to improve the quality of nutrients that we're giving our patients. Reinforcing Indian traditional dietary practices. In fact, even the Western world is really looking at our Indian food, and they know how good it is for health, especially now in the COVID pandemic, and to boost immunity. Demonstrating healthy recipes. I think this is something that we can teach our patients because they can continue this for life. And again, this study has clearly shown that when you cut down carbs considerably, so going on a very low carb diet or going on a very high carb diet, both are not good. And therefore, moderating carbs to around 50 to 55% from your total calories is going to be beneficial. And this was a very, very interesting study done by Sarah Siddleman and group. And again, when we're looking at our carbs, so when we are planning diets, what do we look at? First thing is moderating carbs. So depending on what the person is consuming, moderate the amount of carbs. Reduce calories if the health goal is weight loss. Reduce processed and simple carbs. So that's first that we would do. And improve the amount of fiber in the diet. Even though, the ICR and IN guidelines have clearly mentioned 40 grams of dietary fiber for every 2000 calories, and 25 to 40 grams of dietary fiber is what is recommended by the RSSDI. And fiber, we know that when we add fiber to food, it definitely helps to blunt the post-glycemic blood glucose response. Improve the protein, because there is a gap in our protein intake. We are deficient in our protein intake. Not only vegetarians, but also non-vegetarians are deficient in protein intake. A lot of people, 93% of people are unaware of what are their protein requirements. And therefore, we definitely need to improve the protein. One is the quantity as well as the quality, because that as well helps to blunt the post-glycemic blood glucose response. Now, when we are moderating the carbs or reducing the carbs, we can add in the healthy fats from nuts and seeds, and that helps again to blunt the post-glycemic blood glucose response. So making small changes which are sustainable, which are easy to implement, and something that people are finding it very difficult without being very expensive. And definitely increase physical activity. And I think thanks to Dr. Ranjini and and Dr. Anjana for actually promoting this at all conferences. And I think your Tandav is a big, big hit, and we enjoy doing that, at the conferences. You're missing it really this time. Now we're looking at glycemic index and glycemic load. So just looking at glycemic index is not enough. You'll need to look at the glycemic load of food. And therefore, there's enough evidence to show that a low glycemic index, low glycemic load diet would definitely help to improve metabolic risk profiles. Now, when we're looking at this, I love this plate because this becomes very easy for us to explain to our patients rather than telling them what not to eat, how to eat right. So take a small plate, take a 9-inch plate, fill half your plate with vegetables, 1/4 of your plate with cereals, millets, and starchy vegetables, and 1/4 of your plate with protein. That way, you're making sure that there is going to be fiber, there's going to be protein, there's going to be a good cereal protein combination, and therefore you're going to get a cereal pulse combination, therefore getting good quality protein and all the essential macro as well as micronutrients. And I think our Indian diets come from any part of India, and I'm going to show you how they can be very, very well balanced and follow this plate method. And therefore portion control with emphasis on nutrient quality and density is key. Now, when we're looking at rice, and there's a lot of studies, especially done by Dr. V. Mohan's group itself, and it's very, very interesting. One is the brown rice that we advocate to our patients. It has a lower glycemic index. The Indian basmati, because it's a long grain rice, has a lower glycemic index. Whereas the most commonly, people, when we speak to our patients, they often use Sona Masuri or Surti Kolam because they think that's very, very good for their diabetes. But if you look at the glycemic index is way higher. In fact, I came across this very interesting rice called the Lalat rice, which has got more resistant starch and a lower glycemic index. Parboiled rice is another rice that we could advise our patients, and it's commonly used in some parts of India. Now, when we're looking at roti, a lot of people buying, the multi-grain roti. We're not even sure whether the multi-grain roti has really got whole wheat flour and all the other multi-grain, food groups. But whereas when we're looking at your roti, and this is a very interesting study again from, by Sudha ma'am and Dr. V. Mohan, where they've actually shown that just changing, the roti proportion in terms of you take your 2 kg whole wheat flour, you make an atta mix, which has got roasted Bengal gram flour, isabgul, which is psyllium husk, and methi seeds. So the control flour was already 45 on the glycemic index, and then you can bring down the glycemic index to 27. And this is something which is very easy for anybody to do in their house. It really does. It's not expensive. They don't have to go out and look for things. It's something which is easily available in their kitchens, which they just have to mix in the right proportions, and your atta is ready. And everybody in the family can eat this. It's not a diabetic atta, it's an atta for everybody. Another thing is barley. That's a very, very good grain and very, very popularly used in the Western countries because barley has got a fiber which is called beta-glucan, which is really good. And there's enough evidence to show that it helps to reduce the metabolic risk profile. So adding 50% of barley flour to the roti has shown that it reduces the glycemic index. Now, when we're looking at ragi, and this is something that we've seen in our experience, and all dietitians would agree with me, a lot of our patients after diagnosis of diabetes shift from wheat to ragi. And they will take a ragi satwa, or they will take this polished ragi millets, and then they see that their blood glucose levels is going high. So if you look at the GI of ragi, it's around 84. And therefore, even if you use ragi, it's very, very important not to use malted ragi, which has got sugar. Use the unpolished ragi, add some protein, add some fiber. For example, a ragi and pulse dosa, or a ragi roti or a ragi dosa with egg, chicken, and paneer. So I think our Indian meals, we'd never eat one thing. We'll always mix and eat. And that anyways brings down the glycemic index and the glycemic load. A lot of other millets to explore, especially if you go to South India, they use a lot of millets. In fact, there are restaurants which are only serving you millet food, especially in Hyderabad that, I go to, and I love that, the different kinds of variety that they have to offer. So whether it's foxtail millet, it's barnyard millet, you have bajra, you have kodo millet, you have sama, little millet, and they're all easily available on all e-commerce websites. So yes, ragi, the way you do it, but then you can also incorporate a lot of other millets and make interesting recipes like idli, your dosa, your upma, your pongal, and they turn out really nice. Lentil carbs. So again, pulses, the focus should be on consuming more pulses, more whole grain pulses, and they have got lentil carbs, which actually are have a high amount of viscous fiber within them, and then delaying the gastric emptying and helping your post-meal blood glucose response get better. Now, food order. This is a very, very interesting study done by a friend of mine, Dr. Alpana Shukla, who's in the US now. And this has really helped us advise our patients on how to eat. One is, as we say, take the small plate, fill half your plate with vegetables, protein, and your cereal, millets, and your starchy vegetables. Then how do you start eating? So this is your food order, food sequences. You always start with protein and fiber, and then move on to the carbs. By doing this, you're actually helping to blunt the post-glycemic blood glucose response, as well as achieve early satiety. And I'll take you on a virtual India tour. I haven't really seen an airport since last March, but put your mask on and make sure that you've tightened your seat belts. And I'm going to take you through the different cuisines available in India. So one is puttu. And every time you go to, Kerala, this is something which is very, very popularly consumed, which is your puttu, which is either made from rice or from ragi. How do I make it diabetes friendly? Now, if I'm going to eat so much, this is going to be a huge carb load. So how can I modify it? So I take kadla with puttu, and that's how you're supposed to eat it. So you take kadla, you have a couple of spoons of kadla first, you reduce the amount of puttu, and it becomes diabetes friendly. So you're actually reducing carbs, you're increasing lentil carbs, protein, fiber, and cereal pulse combination, making it a complete protein. Now, batate pohe. I'm from the western part of India, and I think poha is consumed by not only by the west, but even central part of India loves poha. If you go to Nagpur, Bhopal, Indore, poha is a very, very famous food that is given, especially at breakfast. And how can I make it healthy? So we have something called as dhadpe pohe, which has got a lot of vegetables. You add peanuts to it and squeeze lime. So squeezing lime also helps to lower the glycemic index, makes it more tasty, and therefore you reduce carbs, increase the fiber, protein, as well as MUFA fats. Now we're looking at East India. So let's go to East India now. So that is chura dahi, which they love. So they'll have poha, they'll have dahi, they'll add sugar or jaggery. Now we know that that is going to increase the amount of carbs in the meal. So what can I do? So I reduce the amount of poha, I add more curd, I add some seeds, I add some fresh fruit, and therefore it's becoming a complete meal, a very, very nutritious meal, and it'll keep me full till lunchtime. So this is the way I can make my chura dahi healthy. So you don't have to tell people don't eat, because the moment you tell them don't eat, they're not happy. So we have to tell them how can we modify and make it diabetes friendly. Now, aloo paratha. I think aloo paratha is another food, especially in North India. If you go, you have to eat the aloo paratha. It's delicious. So how can I make it healthy? So one is you can actually tell them to boil the aloo a previous night. The resistant starch content goes up. Use a little bit of the aloo, add some paneer, add some vegetables, make it wholesome, and then have it with curd or raita. So again, your protein quality as well as quantity has gone up, your fiber content has gone up, your blood glucose levels are bang normal. And also it gives you more satiety, because the moment you add protein and fiber, like I mentioned, you get satiety. So instead of eating 3, you may eat 2 and eat small ones. Plain dosa. I think dosa is something that is loved by everybody in the world. I call it a global food. And again, instead of having plain dosa or the varieties of dosa that you get, you have it, you can have pesarattu, especially, a moong dal dosa. And we've seen excellent results on the CGMS. In fact, we've seen very, very good postprandial blood glucose control, sustained release with pesarattu. So pesarattu with chutney is great. Or even if you're having the dosa, have it like I'm going to show you with the idli. So if you'll have 4 idlis, and nowadays you get Shezwan idli, fried idlis, and the works. But what you do is reduce the amount of idli. So instead of 4, you eat 2. You add sambar to it with a lot of vegetables and the coconut chutney. So 20 years back, I used to tell people don't eat the chutney. Today, I tell them eat the chutney, because we know that some amount of fat helps to blunt the post-glycemic blood glucose response. Thepla. Again, this is a food which is not only loved by everybody in western part of India, the Gujaratis, but you go to any part of the world, this is one thing that we would all carry with us, because this is something which is easy for us to carry and eat, especially when we're visiting a foreign country. Now, how can I make the thepla healthy? I have it with salad and curd wherever possible. And even to the thepla, I can add some millet flour. I can add besan, which is your chickpea flour, some methi leaves, some sesame seeds, and make it very nutritious, wholesome. And this is something that can be a complete meal by itself. So it again becomes diabetes friendly. Rajma rice. I think there is nobody who does not like rajma rice. Everybody, especially kids, love rajma rice. And again, rajma, good lentil carbs, good protein, good amount of micronutrients, fiber, etc. So how can I make rajma rice even more healthier? So if I'm going to, so instead of filling my plate with rice first, I take less rice, more rajma, and add a salad with it, and have the salad first. So again, it gives me satiety, it gives me more nutrients, and it is also keeping my blood glucose levels happy. So these are some of your traditional diabetes food, traditional Indian meals which can become diabetes friendly. So whether it's a pakala bhat from East India, and we're really swearing by it today, is because it's a very, very good gut friendly food. And believe me, when I talk to my East Indian patients from West Bengal or from Kolkata, when the moment I tell them you can have pakala bhat, or even from Orissa, if I tell them you can have pakala bhat, there's a big smile on their face, a broad smile on their face, because they love it. And they think that because of diabetes, they cannot eat it. But it's a very good gut-friendly food, very good for the blood glucose levels as well. Curd rice is everybody's comfort food, especially when you're not well, you just want to eat curd rice or a khichdi curry. So all your foods, whether it's a dal dhokli, or you go to Rajasthan and you have, the dal bhati, which is again a cereal pulse combination, have it with some salad, and it becomes a very, very healthy, nutritious meal. So to conclude, One is it has to be supervised. So whenever we're planning a diet, we take a lot of things into consideration. So it has to be supervised, it has to be simple, it has to be sustainable, and it has to be affordable. Choose foods high in protein, healthy fats, fiber, moderate carbs, low in glycemic index and glycemic load. It's not a one-size-fits-all approach, like I mentioned, and our traditional Indian diets with slight modification can become diabetes-friendly. So thank you so much for your patient hearing. All that I spoke in is in my book, Diet and Diabetes Simplified. So thank you so much.
Excellent, Cheryl. I think a big round of applause.
Thank you.
For such a wonderful, comprehensive coverage. And what was most beautiful about your talk was, Cheryl, it was filled with positivity, right? So I think the crowd which is listening to these sessions is a mixed crowd. I think they're professionals, they're dietitians, they're even some patients and lay people, you know. So one is that, you have to not suffer diabetes, you have to live productively with diabetes. I think it's a very, very good statement which you made. There is one question in the Anjana, are we taking the question?
No, what we'll do is let me introduce now Shilpa ma'am. Let's finish the talks,
okay,
and then we'll do the discussion at the end.
Sure.
Thank you so much.
Yeah,
Thank you,
Cheryl, that was so brilliant. She did make us all very hungry, didn't she? Okay, so moving on from one brilliant speaker to the next, it gives me great, great pleasure to introduce my dearest friend and colleague, Ms. Shilpa Joshi from Mumbai. Can I have her? Yes. So Ms. Shilpa Joshi is the director and consultant dietitian at Mumbai Diet and Health Center. She's a registered dietitian from the IDA. She's the National Executive Committee member, IDA, and honorary secretary of All India Association of Advancing Research in Obesity. She's a faculty at the SVT College of Home Science and Nirmala Niketan. She's a course director for the NDEP and has trained more than 3,000 diabetes educators and master trainer diabetes conversation maps. She's a certified pump trainer, has published several articles, and has delivered numerous lectures, and she's a very well sought after speaker. So the floor is all yours, ma'am.
So good morning, everybody. Thank you, Dr. Anjana, for kind words of introduction. And it's indeed a pleasure to meet all of you virtually. I wish we were meeting in real life, but it's a pleasure to meet all of you virtually. And let me speak about why extreme diets should be avoided. So I just wanted to say that Sir had invited me to speak on extreme diets, I think 10 or 12 years back, when nobody was speaking about ketogenic diet for diabetes. And that is the time I had done a lot of research. And this is the time I'm going to be speaking on why they should be avoided. I think making this presentation made me learn a lot of different things. So why are people actually following these extreme diets? So basic reason is, we read a lot of literature about its effect on diabetes and effect on heart disease and so on and so forth. But in reality, most of the time, people really follow extreme diets for the optics. They really follow it because they want to lose weight very fast and they want to look a certain kind. So the reasons for following extreme diet most of the time is because of a body image issue, or because they are subjected to body shaming. There's a lot of peer pressure, and of course there is a lot of effect on media, where you find Bollywood celebrities, etc., following these extreme diets, and they a lot of times propagating it. So these are advantages and disadvantages of extreme diets. And here we are seeing that the most of the times you will see pros as rapid weight loss. And then of course, there are many, many cons, and these are really well given in certain places where they are talking about, it can cause osteoporosis, inadequate intake of good quality protein and high carbohydrate diets, so on and so forth. And I'm going to take you through various effects of fad diets or extreme diets, and I'm going to show you why they are really something which should not be followed. So side effect of weight loss diet is weight loss occurs too fast, and most of the weight loss being water and muscle and not the fat tissue. Rapid weight loss can lead to various health risks such as constipation, low nutrient intake, especially micronutrients, because we see that there is a lot of emphasis on um, uh, choosing a certain kind of macronutrient, and therefore micronutrient actually suffers, and energy intake and tiredness, which actually happens all caused by eating less calories. So these are side effects which I'm going to take you through. There will be physiological side effects. Some are immediate, some are long term. Then there'll be psychological side effects. And I think the biggest side effect, which is a big concern for everybody, is the financial side effects that you're going to have. So these are few data from children following ketogenic diet, where what happens right in beginning of ketogenic diet is what they have studied, where they have shown dehydration, hypoglycemia, and vomiting, which happens when ketogenic diets are initiated. And you will see these are short-term complications of keto diet, where they are typically labeled as keto flu when they are put together. So they can be keto flu, headache, fatigue, nausea, and you can see it's a long list. And honestly, there were many more. I was just tired of typing so many, so I thought, these are good enough cross-section to show what it can do. And if you see how it goes, so first couple of days, it's very severe. Then it sort of starts settling, and it takes time up to 30 days for these symptoms to settle. So the initial thing is not only hunger and other things, but all the symptoms of keto flu, which take time. And therefore, there are remedies proposed for keto flu on online forum, where they're talking about increased sodium intake or electrolyte supplementation. They're talking about drinking broth, increasing magnesium and potassium supplementation, so on and so forth. So these are various online posts for overcoming side effects of keto diet. Now, these are general side effects of high protein, high fat diet. There is, of course, an increased risk of heart disease. There is an increased risk of colon cancer, and there have been data showing increased bad breath and sleeping disorder. Then there are certain studies which show LDL cholesterol level also increasing, and therefore risk of atherosclerosis and coronary heart disease by greater than 50% in the longer term. Then other effects are constipation, headache, hair loss, increased menstrual bleeding, so on and so forth. Then also there are studies which are showing that there is, due to high protein, high fat diet, there is an increased acid load to the kidney, maximizing the possibility of stone formation and decreased balance of calcium, leading to bone loss and osteoporosis. There is also, because of high fat intake, there is increased risk of reduction of insulin sensitivity, increase of insulin resistance. That can be a long-term effect. That is because of very high fat intake, and a lot of time this fat tends to be saturated fat. Then other side effect would be there is an increase in plasma homocysteine, which has been linked to higher risk of cardiovascular disease. Then there are other kind of extreme diets which are very low in protein and very high in fat, low in fat and very high in carb, which are diets like Pitkin's diet. So low protein, low fat diets, there is an inadequate amount of minerals such as calcium and zinc, as well as there is lack of high quality protein. There is also lowest limit of dietary requirement of essential fatty acid, especially omega-6 and omega-3. And there, in lot of cases, we find when they do a very high carb diet, limit their protein intake, or they tend to go vegan, then there is a lot of iron deficiency, especially if they do not supplement iron when they are going through these diets. So the diseases that could deteriorate on ketogenic diet, I thought this is one slide which we should know, are porphyria, pyruvate carboxylase deficiency, unrecognized carnitine deficiency, defects in fatty acid oxidation, and mitochondrial disorder. And these are all adverse effects of maintenance ketogenic diet. Especially these are given with respect to younger kids, but then these problems also will happen to older adults, where you are seeing kidney stones, poor growth, dyslipidemia, so on and so forth, even changes in ECG. Now, like I said in beginning, that there are very few people who actually use these extreme diets for health reasons. Most of the people use this to look better, or they want to look a certain way after following this diet. Therefore, health, hair, or skin health, or dental health becomes very, very important. So what is the effect of extreme diet on hair health? I think this is very important. And when I read this paper, they only spoke about women, but I think we get men in our clinic who are also as worried about how their hair look as women. So there is a temporary condition called as telogenum effluvium, which happens. Hair growth is cyclical. Each hair follicle goes through phases of growth and rest. Usually cycles are staggered from follicle to follicle. Some are growing while some are resting and some are shedding. With TE, more follicles go into resting phase at the same time, leading to a noticeable hair loss. And this typically happens after an infection, a prolonged fever, childbirth, so on and so forth. And this is the same effect which is seen after following an extreme diet. T is one of the diagnoses that describes what is happening, but it does not describe why it is happening. And it has been shown that dramatic dietary change or sudden or rapid weight loss often occurs when starting this extreme diet, and this is one of the effect on the hair health. Eating in a big caloric deficit and too little protein might also affect TE. So the other kind of diet where you are eating a lot of carbs but too little protein also will affect TE. When body has limited resource to devote to building, repair and maintenance, hair growth will go on a back burner since it's a non-vital process. Specific nutrient deficiencies have also been implicated in TE, which is particularly iron and zinc. And it has been shown that in women, iron deficiencies in TE are stronger in women, while zinc deficiencies are more strong in men, but it can be mixed in both. So this is an important effect on hair health. Then there is an important effect on dental health, because you might look pretty, you also need a pretty smile, and for pretty smile, you also need very nice teeth. So extreme dietary trend and dental health. Now there is a dietary trend of consuming apple cider vinegar in the morning, and it has been shown, and this comes from a dental journal, that it has been shown that it leads to dental erosion, thinning of enamel, so on and so forth. And actually they gave a tooth-friendly solution, which I never thought of, because we see a lot of patients drinking apple cider vinegar. We ask them to dilute it, but they said you need to use a straw while drinking it so that less teeth are exposed to these kind of drinks with a very, very acidic pH. Not that I'm recommending it, it's just a solution. Then of course for Atkins, paleo, keto diet, it causes bad breath and a dry mouth. That's a big problem. And dry mouth is what increases risk of plaque and dental cavity. And therefore, what is the tooth-friendly solution for people having a low-carb diet is to drink plenty of water, to use a mouthwash without alcohol, because alcohol can cause drying, and of course, chew a gum with containing xylitol can be advised. And this is again not my suggestion, coming from a dental journal. Hyperuricemia is a problem where we are in typically while following a high protein or high fat diet, which is low in carbohydrate, and this can be exacerbated if all the protein is coming from non-vegetarian sources. And so this is one of the side effects of high protein, high fat diet. Then any kind of extreme weight loss, whichever method you use, whichever extreme diet you use, they will find that there is an increased propensity of gallstone formation, and potential mechanisms underlying etiology of gallstone during weight loss include stasis, cholesterol supersaturation of bile, and increased cholesterol crystal nucleation. And we find that this will happen with any kind of diet which is followed. As soon as you get an extreme weight loss, the propensity to gallstone increases. Nephrolithiasis, that is kidney stone. Again, high protein diets, which are like Dukan diet, which are very high in animal protein, increases urinary calcium and decreases urinary citrate excretion, thus leading to overall high lithogenic risk. Low carbohydrate diets like Atkins or zone diet may have some protective effect against kidney stone formation, but there are also evidences stating that dietary approaches may rise calciuria, decrease citriuria, and therefore increase because it is associated with high protein. Vegan diet can be very harmful for urinary stone, especially risk of hyperuricemia and micronutrient deficiency, even if few studies have addressed this matter. There is a benefit of using a regular lacto-vegetarian diet on kidney stone risk, And the most effective dietary approach to prevent kidney stone is mild animal protein restriction, balanced intake of carbohydrate, fat, and high intake of fruits and vegetables. Other fundamental aspect which is often neglected in fat diets is normal intake of milk and dairy product and decreased intake of salt. I think that is something which is very important in kidney stone formation. Now, there is a huge impact on gut microbiota. And in fact, what is global understanding is because a person is eating these kind of ketogenic food, they become energy source for colonocytes, anti-inflammatory and antioxidative property. There is immune regulation, so on and so, which actually works on the gut health. But it has been shown that with increased ketone bodies and decreased glucose coming from the diet, not direct glucose, but in form of carbohydrate, there is decreased alpha diversity, decreased richness in gut bacteria, increased bacteroids, increased lactobacillus, and so on and so. Gut microbiota, the kind of gut microbiota actually changes. And the practical recommendations which are given to preserve gut health during a very low calorie ketogenic diet is use of whey and plant protein like pea protein, reduce intake of animal protein, implementation of fermented beverages and fermented food like yogurt, water, milk, kefir, kimchi, fermented vegetables, so on and so forth, introduction of prebiotic and specific probiotics as need be, reduced ratio of omega-3 to omega-6, introduction of accurate quantity and quality of unsaturated fatty acid, avoid sweeteners, although there is data about other sweeteners, about stevia, we do not know. And if possible, test or microbiome analysis of 16S RNA to identify biodiversity and richness. Now, this was a paper which was published by American Heart Association. I think most of us have read it, that what are the safety concerns of ketogenic diet, and everywhere it says that it is recommended that such diets should be under strict supervision. There are a lot of drugs like SGLT2 which cannot be given when these diets are followed, or if SGLT2s are given, then these diets should not be given. This is just a slide to show this has come in JAMA, the journal JAMA. It gives a very nice one-page understanding of what are ketogenic diets and who should follow it. It is coming from the Mayo Clinic. I thought it will be just a nice way of telling everybody what is, a small read for ketogenic diet. Now, these were physiological implications. Now let's look at psychological implication. Following an extreme diet leads to food obsession, continuous caloric accounting, distractibility, increased emotional responsiveness, and fatigue. Chronic dieters tend to overeat. They have low self-esteem and suffer from some kind of eating disorder and chronic depression. So therefore, these are huge impacts. And weight loss is not about 1 year, 2 years. It's a lifelong journey. And psychological impact, especially if they happen earlier in the life, can cause a lot of both physiological and psychological impact. Now, this is, I think, very important. Cost of ketogenic diet. Look at the cost. I am not propagating any of high glycemic foods, but if a bread is 26 rupees, a keto bread is 617 rupees. Wheat flour is 46 rupees a kilo. Keto flour is 799 rupees a kilo. So you're not only spending you're spending 10, not 10, maybe 100 times more just to eat a normal food. And therefore, what happens is, again, not propagating any of these Hakka noodles or muruku or anything, but trying to tell you that following these kind of extreme diet is difficult and is also very, very difficult on pocket. So these are actually differences in the cost. Again, real life implication. This is something that I think we all practicing dietitians see all the time in real life. So standard meal plans with limited options, especially for vegetarians. If you're putting them on an extreme high fat, high protein diet, there are very few options. Eating with family becomes a problem due to temptation of eating carbs. And this is with every patient I've seen who has followed extreme diet has said, we never eat with family because when we see roti and rice, we get tempted. Socialization in India, socialization is over coffees and meals. It becomes difficult. Traveling for work and otherwise also becomes difficult. It's good that we are in this era where we are not traveling much, but traveling becomes difficult because these options are not available. In COVID era, what are the problems? Difficulty in procuring specific food products due to lockdown and semi-lockdown was a challenge. People did not get their regular groceries. Getting these were a big problem. Lack of help. There were no maids in the lockdown time. So nobody was cooking at two places. Something different for the family and different for the patient was not happening. Hospitalization due to COVID. Hospitals do not provide these specific diets, and also doctors don't recommend it. So I've had patients with keto diet going to the hospital with COVID and coming back and saying that we couldn't follow that diet. And then because of the sudden change in diet, there's a huge impact on hunger. They are so hungry, and definitely there is a big change in metabolic profile, especially after steroids are administered to them. Last couple of slides. What is the holy grail of any diet? It's compliance. If you can comply to a diet, then that diet is going to work, whether it is ketogenic, whether it's Pritkins, any kind of diet, even regular Mediterranean diet, you have to comply. And you find that this is a beautiful paper, very old paper from JAMA 2005, but where they have shown that actually, if your diet, like a Weight Watchers diet, is closest to your normal eating pattern, only then you comply. Any kind of diet which removes a food group, for example, Atkins diet, where the compliance is very low as months progress. And of course, the true test of any kind of diet is relation to mortality. And this is a very beautiful paper. Again, Dr. Mohan had only suggested me to read this when it had got published. And in fact, he had sent me this paper. So where it has been shown that carbohydrate intake at extremes, whether it is high or whether it is low, both increase mortality. It is only 50% carbohydrate that has a relationship with lowering of mortality. And therefore, this just goes to show that extreme, whether high extreme or low extreme, both are really not good with respect to mortality. In conclusion, extreme diets usually restrict a food group or restrict a meal completely, like in intermittent fasting. Many of these diets have shown great results in short term and hence have become very, very popular. But one has to remember that the word diet comes from the Latin word diete, means way of life. And due to its extreme nature, these diets cannot be way of life. Compliance is going to be issue. Long-term health implications are many, both optically and real kind of health implication on metabolic health. And as suggested by many research studies, that diet which includes all food groups in the right proportion have benefits on health. Thank you so much for a patient hearing.
That was a brilliant talk, ma'am. Thank you very much. It was really good. And thank you for bringing out all those health aspects, which are usually people don't see it. They just talk about the weight loss and thing, but they don't see the metabolic benefits. Thank you so much. We'll move on to the next one. Jagmeet, ma'am, you want to?
Yeah. So thank you, Shilpa. I think you rested the case, what Cheryl built, and people are getting the right perspective of where they should be and what they should be looking at. So let's move on to our, thank you very much. It was a very nice presentation. So we move on to our next esteemed speaker, Ms. Sudha Vasudevan, a very, very dear friend. She's a senior scientist and head Department of Foods, Nutrition and Dietetics, Research Madras Diabetes Research Foundation, Chennai. She has more than 35 years of experience as a clinical dietitian, teaching faculty in national and international institutions. And I think she has been a key team member and instrumental in translating the food and nutrition research findings to evidence-based products and services to benefit the community, I think, which is very, very creditable. And she has, the development of Dr. Mohan's brown rice, Dr. Mohan's Atlas of Indian Food, and EpiNew, the nutrition software, to her credit. She is a principal investigator and co-principal investigator for several projects and has more than 75 publications in national and international journals to her credit. So we welcome you, Sudha, and we look forward to your presentation.
Thank you very much for the kind introduction, Dr. Jagmeet. Thank you, Chairperson, Dr. Jagmeet and Dr. Anjana. And I'm just, is my slide visible?
Yes, it's visible, but make it full screen, Ms. Sudha.
Yeah.
It's visible now.
Yeah.
Yes, all good.
Thank you very much. So the topic I'm going to present, the previous two speakers made my job more easier to explain the diet quality. Both Cheryl and Shilpa, the Esquire had really put me into a nice box where I don't have to elaborate more on the diet quality, because they have told that how to modify foods to make it more healthier, which means good quality. So I'm going to straight away zoom into my next slide on what is diet quality. It's a multi-dimensional concept. Diet quality has got two components: what we regularly eat and the functional property. What we regularly eat comes from various influencing factors such as socio-cultural, like what Cheryl said about each region has got their delicacies, like religious beliefs also, and their individual preferences. And the taste aspect is very important, organoleptic. This really influences the regular food consumption. And of course, for a quality, importance is the nutritional aspect. There are different attributes that describe the nutritional character of the diet quality, ranging from adequacy, diversity, nutrient density. With ever since the COVID came, now anti-inflammatory component of diet has become a big agenda now. Of course, without compromising the food safety, with food hygiene and least contamination and zero additives now. Few years back, global burden disease. I'm sorry about the poor readability of slide. You don't have to squeeze in. All I want you to see, the global burden disease evaluated the diet quality among 187 countries, published in Lancet 2015. And it's very disappointing to see the India in the 70th rank position. Perhaps this could be one of the reasons at the same time where India, next to China, ranked number 2 with the largest number of people with diabetes. Interesting survey. You'll be really, really thrilled to see this. And there's a reality in check. There's a Swiggy survey from the statistics. It's not even statistics, it's statistics, they call it. And see on my left with the most ordered food in Swiggy across 530 plus cities, the chicken biryani, masala dosa, paneer butter masala, fried rice chicken, and mutton biryani. And Swiggy could deliver it to your doorstep without even you making any physical effort. 35,000 combos with biryani. And they even suggest that absolutely time that nation calls it biryani as a national food, because every minute 95 biryanis are ordered. Isn't it amazing? You might wonder what's wrong with biryani. As we all know, biryani is very high energy dense food, high in fat, and most of the biryanis in the country are prepared out of refined carbs, what Cheryl and Shilpa mentioned earlier with the refined grain-based sources. And this is the reason that we do not recommend. As a result, today, you see the shift in the diet quality from the tradition, from the undernutrition, malnutrition. Now we are moving to the malnutrition. So it's time for us to really mull our nutrition quality in terms of diet quality. So to get an overview about how do we know to assess our diet quality, it's majorly it comes under the dietary pattern analysis in the research need. There are two forms of pattern analysis, a priori and a posteriori. My talk is going to restrict more on priori, which is basically based on scores, or the ranks are given based on the predefined ideal diet. Ideal diet meaning that the country might have a national dietary guidelines for prevention and risk reduction of chronic disease like diabetes. Or in the absence of such guideline, investigator drives based on the population reported diet data of the foods alone or the nutrients and foods combined or nutrients alone. They see the associated disease risk, either positive risk or the negative risk. And then they come out with a beautiful score with which they expect the population to adhere to those dietary scores. So examples, popular ones, many of you are aware, a DASH diet score and Mediterranean diet score and healthy eating index. We are going to see that more in the future slide. Whereas a posteriori is the data driven based on the cluster analysis, how similar groups of people in the population, they are clustered together and analyzed, or the statistical driven approach of dietary correlates that are associated with the risk through a principal component analysis. I'm going to speak more about the diet quality score restricted for this presentation. Now today, as a result, you name any acronym, you will find a world full of diet quality scores. And you call it a MIND diet. There is a MIND diet quality score, diet quality index, and Nordic diet, diabetes diet score, and dietary American guidelines, alternative healthy index. There are so many scores. The most popular ones that I've chosen today for presentation because they relate to the context of diabetes risk, which is our primary interest. And These are the DASH diets. This is dietary approaches to stop hypertension originally, but now this diet got modified to accommodate all possible chronic diseases. And healthy eating index has been continued to evolve from 2010 onwards, now 2050, on dietary-based diabetes score. And these diets, if you typically see, the score pattern or scoring system is based on both the food groups and the nutrient. So they divide the healthy foods, the quantity, how much one should eat. For example, whole grains, total grains, leafy vegetables, fruits, and the good protein source, which is a good nutrient, healthy nutrient. And they also give a minus score for unhealthy food choice. Someone eats more, an unhealthy nutrient that someone eats more. And we were wondering, why not we apply these scores to our Indian diets and check whether they are suitable. So we were asking two big questions to start a study. We did a study. I'm going to talk about those study results soon. And the two questions that we asked, seeing the diet quality score, can we extrapolate these internationally popular scores to our Indian population? And the second one, is it possible for us in India, it's easier to come out with a food-based dietary guidelines as we eat more foods than nutrients, and it's easily to translatable for a public health message with the diverse literacy rates and socioeconomic class. So we wanted to evaluate this. So we did a study, and the study's findings have been published last year in Journal of Diabetes on prospective association between a food-based diet quality score and type 2 diabetes risk among urban South Indian adults from our Chennai urban rural epidemiological study. The urban component, we had briefly the methodology. We had recruited a representative Chennai urban population, 26,000 in phase 1 in the year 2003. Out of that, all known diabetics were invited as phase 2 for a detailed investigation of biochemical, clinical, and dietary. And every 10th case of the phase 1 were also recruited. These two, phase 2 and phase 3, were followed up as a cohort for over 10 years. And 2013, we have completed the diet data out of this, having lost few numbers to follow up and expired. We ended up with 82% response rate. And as energy underreporters and overreporters were excluded and known diabetes population, then we had 1,033 adults with whom we would evaluate it with the international score and check their credibility and their association with the diabetes risk. And as you can see, the DASH Healthy Eating Index, DDS, these are the three scores we have chosen because they are three ones were popularly associated for our diabetes risk. That's our primary focus interest. Based on this DASH scoring system, our Chennai urban population dietary intake measured from validated food frequency questionnaire were assigned the scores given by the DASH scoring system and summed up for each participant the entire score. And the population scores were divided in quartiles. Higher the score is healthier in general, and the lower score is the reference. And there you would expect with the highest quality score, the hazard ratio or the risk with incidence of diabetes to be lower than 1, but it was higher. It was inconsistent results across all three international quality scores, diet scores, and none of them showed significant. This really prompted us, oh yeah, these scores cannot be applied to a population. It's time that we need to construct a new developed score, which is Indian diet quality score that we developed. And based on the food groups, as I told you, because we believe that it's easier to translate than the nutrients. And what we did is we divided the various food groups, almost 30 food groups of our Chennai urban adult population who consume, divided 30 food groups. And through analysis of variance, we found out only 8 groups were associated with risk of diabetes positively or negatively. And one, the type of cooking oil also influenced the risk. So out of these 8 food groups, you can see in the column, the first 3 food groups on the left are those healthy food groups that help to reduce the risk of type 2 diabetes incidence significantly. All are significant results. While on the contrary, the unhealthy group, even the highest amount went on to show a risk, 2 to 3-fold risk. Now the scoring, how did it work? We have divided the population intake of these food groups into 3 levels, low, medium, and high. So the healthy food, we expect somebody to consume medium or high level, and the highest level consumer was awarded a score point of 10 maximum. It's very similar to a scoring system of international scores. And those who consume the least were given 0, but those who consume in between were given proportionately the score in the scale. Similarly, and the serving size, what is required is only 58 grams of pulses and legume. It is only half a cup. When I say medium cup, it is only 150 ml water holding katori kind of thing. If somebody could take every day half a cup, that would certainly help them to reduce the risk of incidence of diabetes. Previous speakers also spoke so much about protein. And milk products, again in our study, it's shown consistently, even our baseline study we have published, it's shown that even a 2.5 serving of medium glass is 140 ml water holding glass. If somebody could take 368 grams of milk, and definitely that gives a protective effect. So it reduces the risk. Whereas rice, even a 2.5, as low as 1.5 a cup of cooked rice itself is the best, and beyond which it started showing very high risk. And similarly, edible fats and oils, if one crosses beyond 7 teaspoons of oil for cooking, it showed a higher risk. And added sugar, even at the 5% of the total calorie levels, it showed almost twofold significant risk to diabetes. And added salt, even the population consume only the lowest level 5 gram, which is the upper limit given by the national guidelines. And people who consume more than 1 teaspoon, it's clearly brought out the risk increases tremendously. So also with the animal foods, poultry and particularly, it showed a risk at a higher level of twofold risk. And the cooking oil, a previous cure study itself in urban, we have shown sunflower increases the risk of insulin resistance and metabolic syndrome against traditional oil. Hence, sunflower was given a 0 score and traditional oil 10, while the palm oil was given a mid score. Now, you know that we have developed the score only using the food group. So we need to check, validate, how does they perform nutritionally. So when we added the sum of all our scores, 8 food groups and 1 oil, so 80 plus 10, 90 is our total score. Unlike the other scores are 80, 90, and 100, we were similar like that, 90 scores. And we divided again the quartiles of score, and those who consume highest quartiles of score are healthier, a group of people with the highest quartile scores, and they had definitely significant reduction in calories and reduction in carbohydrates, and they increased fiber significantly, and their protein calories also significantly increased. In fact, it showed, though increase, it's significantly, but it is well within the recommended national recommendation of 30% fat. So it validates our development of IDQS works well, even when you translate into nutrient intake. And other construct validity we did with the non-dietary parameters, where you can see on my left side, IDQS scores were stratified in quartiles. And on the waist circumference, the green line is at 2003, and the same individuals when followed up in 2013 in the blue line. And the highest quartile score, the healthiest score, showed significant reduction in waistline, both in year 2003 and 2013. Similarly, on the right, BMI also showed a significant reduction, both in the year 2003 and 2013. So the construct validity also approved IDQS score is performing very well. And we also further did a sensitivity analysis to stratify how does this IDQS score will work with people when we stratify them by age, greater than 30, less than 30, gender, BMI, normal BMI and overweight BMI onwards, and physical activity levels greater than median score and less than median. And you can see this hazard ratio pretty well. It was very sensitive enough for people with above 30 and gender and physical activity, except for the people at greater than 30 and BMI, normal BMI. Perhaps the diabetes itself is far less with people with normal BMI and less than 30. The occurrence starts more greater than 30 years. That could be the reason for these two things. So it really, sensitivity analysis also validated our IDQS score. This really brings out to my summary of my talk, conclusion, that global diet quality varies substantially, and unhealthy patterns, not only in India, globally, it surpasses the healthy eating patterns. So hence, there is a need to develop country and population specific score like IDQS, which would be useful aid in dietary guidelines to develop, especially to address the risk reduction of or prevention of diabetes. So how do we improve, promote good diet quality is a public health challenge today. It's not only from the nutrition perspective, even from the food safety perspective, like what Shilpa said, the cost factor. Any healthy food cannot be exorbitant. So the cost factor of a good diet is important, and socio-cultural aspect and regional cultural aspect need to be really considered. And we need a major thrust from the food industry focused on to improve the diet quality, to bring in more healthier alternatives. So it's time now we need to whack ourselves. What I meant by whack is we need to attempt to improve whole grains, eat whole, and hedge horticulture produce like vegetables and fruits. You must promote more, add more dairy, of course, add no sugar, salt, and fat as far as possible. Count your portion size, count calories, and cut calories. And one can definitely kickstart a new life with good quality of diet. And thank you all. And it's time for me now to get back with more questions on this. Thank you very much.
Excellent, Sudha. I think what a wonderful presentation and what a comprehensive work. I think you touched the right chord. We as Indian researchers, we have to think differently because whatever data we may collect, we just cannot treat that data based only on Western standards which are available. And it's time that we devise our own diet scores. And it's very, very heartening to see the leads which you've got from the database. Let me also at this point share that we've just finished a study on pre-diabetes, in adolescents and young adult in the age group of 16 to 25 years. And we have a cross-sectional data of, more than 1,300 this set of population. And we are trying to analyze the baseline data. Of course, it was a randomized control trial, which we've already published. But what I'm saying is this gives us also a cue that, a lot can be derived from the data which we collect, and specifically, customized, Indian dietary scores is definitely the need of the hour. Thank you very much. It was a very well presented study.
Thank you. Thank you all. Thank you very much.
Thank you, Ms. Sudha. That was a really good lecture and on time. Thank you very much. So now if we can have all the speakers' videos on, we'll open out for panel, ma'am.
Yes, yes.
Yeah, we'll have the discussion. So there are these questions that have come in the chat box. Ma'am, would you like to, or would you want to?
I think, let me just begin.
So I think there are two questions on, I think the fad right now is reversal. So I think there are 2 or 3 questions on reversal. Now everybody is talking about reversal and things like that. So let's get started with that.
Okay, sure. So I think the question is that there have a lot of diabetes reversal remission programs that have started worldwide. With only dietary regimens. What are your take on that? I think all 3 of you can reflect on this.
I think we can start with Shilpa because she speaks on this very often. So.
Yes, ma'am. Shilpa.
If you look at programs which are happening globally, so if you're looking at direct trial or counterpoint study or trials like that, they are using a ready-to-drink formula as meal replacement for all the meals. So it's complete meal replacement. But we are also seeing many reversal programs using ketogenic diet, and we are also seeing many reversal programs using structured diets. I personally believe that, programs where there is a drink which is given as total meal replacement are very hard to sustain for 2 reasons. One is, as a part of trial, you get that drink free because you're part of trial. So it's easy. You can keep following it, although it's difficult to say no to food all the time. But the real problem happens when people start following complete meal replacement regularly on their own. Meal replacements are expensive. So beyond actually wanting to eat food, there is a huge financial implication. What I personally feel is a low-calorie diet, which has a good nutritional diversity, which has fruit and vegetable and maybe little bit of whole grain cereal, pulses, milk, and if non-vegetarian person, then some amount of non-vegetarian food with a structured, caloric intake and macronutrient composition. If it is offered, that will be really good. And we have seen reversal with people following their homemade diet. In fact, I remember Dr. Mohan sir talking about his patient who started eating just lesser and could reverse his HbA1c from 11 to 5.4, sir, or something like this. You spoke in my Insta Live and you gave that example. And that's a real example of reversal.
Yeah.
Unfortunately, the whole concept of reversal has been so much commercialized that, people have something to sell, something to think. So more than the reversal there, and the sustainability is something which is very, very important. And I think I tell people, unless you're going to take a diet for the next 10 years, don't even start it. Because what's the point for 3 months, 6 months trying something, then something else will come. All the time you're on a fat diet, or all the time you're on some extreme diet, and people believe that they're doing something, great to themselves. But for a short purpose, for something, if you have to achieve it for some purpose, you can do that. But otherwise, there's no point. Stick to whatever is natural. And of course, doesn't mean that a meal replacement need not be done. I mean, that is, different people have and there's no one size fits all. That's the other thing. There's absolutely no one size fits all.
Yesterday, we had this talk on reversal, and Neeta ma'am was talking about, and she spoke very beautifully about the counterpoint and the trials. And she was saying that, yes, reversal is possible, but I think at the cost of repeating this, is it for everyone? I think that's the important point. It's not for everybody. There are a group of people, diabetic or not, okay, who can, if you have type 2 diabetes, can you reverse? There are some people who can. And there's some clear criteria for that. Within 5-6 years, good C-peptide, etc., then you can even, try it and sustain it. And even the remission things that we have 1 to 2 years only. Whereas when you talk about any remission in general, whether it's cancer or whatever, you talk about a minimum 5-year period, and we don't have data for all of those. Shilpa ma'am was talking about the whole myriad of different metabolic consequences that can happen from long-term use of these things. So although reversal is possible, it's possible in a select population.
And even if I can add to that, see, the extreme form of weight reduction is bariatric surgery. So I'm sure all of you believe that if you do bariatric surgery, diabetes will reverse 100%. I disagree, because we have done it, and that was the PhD thesis of Dr. Chandru, who has just finished his PhD, and he got that. The series is not very large. It's about 36 patients with consecutive bariatric surgery done at our center. Now, only in a minority of these people who lost 40 kilos in weight. Weight reduction is guaranteed. Of course, 1 or 2 people who went to bariatric surgery, they didn't lose weight. That's a different scenario. We leave that. But 90%, 95% lose 30 kilos, 40 kilos in weight. After losing 30, 40 kilos, did they have reversal? No. Only about 25% of them had total reversal, which means no metformin also. Okay. Now that is only in about 25%. Why? Because we operated patients with bariatric surgery not as a first one option, but as a last option. Everything fails. They're on insulin. They finish 15 years. They finish everything. What happened? From 100 units of insulin, come down to 10 units of insulin. Instead of 3 times insulin, came down to 1 time insulin. Sometimes they went off insulin, okay? But they didn't go off medication. They did not go off medication. So where is the reversal? Even after losing 30, 40 kilos, cutting your stomach, cutting your thing, making your intestine go ulta, doing everything else, you're not able to reverse. You think just by cutting off some carbs, you can reverse? I mean, you can in that select population, early population, where your C-peptide is very good, your duration. He had a cut point. He did an ROC and he showed that 8.5 years. You had diabetes more than 8.5 is reversal not possible. Okay, less than 8.5 years, you reverse. So in early cases, pre-diabetes, heavy, guys who have 30 kilos to lose, 40 kilos to lose, you go on all that, it's possible to reverse. But we think in everyone you're going to reverse. That's what I object to all these people saying. They say anybody you can reverse. 20 years, 30 years, and 100 units of insulin, 200, I'll reverse it for you. And that too what? After giving a leaf or giving something else. These are gimmicks, and I think they are taking people for a ride, and they may almost make us feel as if we diabetologists are doing a wrong thing. If you write a prescription, it's because you're helping the pharma. If you write insulin, you're helping the pharma. We are the true saviors, who have come to save you. All those guys are villains. We are the true guys, the saviors of the world.
The nutritionists have the same problem. The nutritionists, there are plenty of these quacky nutritionists. They're worse than us, actually.
I think I just like to add here, Dr. Mohan, I think we need to be talking about preventing undiagnosed diabetes and pre-diabetes to becoming diabetic. I think that's the mandate of a nutritionist.
Absolutely.
And of course, creating success stories in diabetics by making them better, like in terms of getting their HbA1c lower and making them more productive, in terms of their quality of life. I think we have to talk this language rather than, making these tall claims of saying that, you reverse diabetes.
No. And the other thing is that, 5 years ago, 10 years ago, we're not even talking about reversal. But I've got hundreds of patients who have lived beyond 90 and even now some have crossed 100 years of age. They have not reversed their diabetes. So what? They lived to 100 years of age and they are in perfect good health. They don't have a single complication. Why should you even reverse diabetes? I'm asking you, why should I reverse? If my patient can live up to 100 years of age, you and I may not, and they are living beyond us and they're having perfect good health. They have no complication. They've lived a full span of life, finally dying of old age. Why should you reverse it? What did the diabetes do to them? Nothing it did to them, isn't it? So I think that is what I would focus on rather than reversal. If that becomes a mantra, yes, in early cases, few of you can reverse, that's good. But if you don't, keep it under control and give them a long and healthy life. I think that's what is more important.
Exactly.
Let's stop there.
Yeah.
Shall we look at some of
Yeah. I think there is a question on resistant starch. What is your opinion on resistant starch and having last night rice as breakfast? Sudha, would you like to respond to that? You're muted, yeah.
Yeah, thanks, Jagmeet. Yeah, this resistant starch, yes, at lower temperature when it stores, it might form some amount of resistant starch, but it is not significant amount enough to shift your blood glucose. You need huge. There are studies, even our own studies have done, it's under publication now, where we have tried almost with 30 grams of resistant starch being added in the diet. We did not find a major kind of a significant difference. So it all depends on to which meal it goes with. It's a combination. So it is not just the last night rice. It's in a way good to use the rice so that you don't throw. So food wastage is minimized. Definitely some amount of resistant starch is generated, but it is not adequate enough to impact your glycemic exposure.
Ma'am, can I add to this?
Yes, Cheryl. Yeah.
So basically, even when you store it in the fridge, it has to be stored at a certain temperature for so many hours. And then when you're removing it, when you heat it, if you're going to heat it at high temperature, then again, the resistant starch is broken down. So therefore, it's very important. If you're looking at it, then you have to do it in the right way to be able to get even that little benefit.
So does that mean you eat frozen rice?
No. You warm it to a certain temperature, but you don't heat it at very high flame.
Okay.
So there are different types of resistant starch. So it is RS2 that is formed or RS3. Right. That takes longer, very deep freezer kind of a temperature.
Yes, it needs to be frozen at 4 degrees for 24 hours.
But which technically should not become digestible starch even upon heating. Then it is called resistant starch.
Correct.
In fact, I can just add, because we've done some work on resistant starch as well, and where we looked at the resistant starch content of the foods at the raw state and how we treat the foods, So of course, rice, when you cook it, cool it, the resistant starch content definitely increases. But yes, when you actually again use it, how much of a benefit it can provide is still questionable. But I want to add to this conversation by saying that there are many foods which we identified, which are very, very high in resistant starch, and especially the legumes and pulses. Okay, and even simple processing like soaking, steaming, germinating, this all increases the resistant starch. And out of all the pulses, I think chickpea was the highest in resistant starch content, followed by moong, moth beans, and then of course green banana, and we had carrots. So we could identify the foods which are rich in resistant starch, and we could get 16 grams of resistant starch in an experimental diet. And we got very good leads within 2 weeks in terms of anthropometric, biochemical parameters, and the gut flora, just incorporating this through natural foods, no supplementation. Right. So what I'm trying to say is the whole thing has to be looked at not at individual food, but I think a whole checklist, if you draw and say that you incorporate X, Y, Z food, which are really significant sources of resistant starch, it can make a difference, because with resistant starch also comes dietary fiber. Yeah, so we cannot delineate the two. And that's where I think the benefit comes.
Yeah, the food matrix is very important in which the resistant starch develops. Yeah.
Okay, so in the interest of time, let me ask one last question to Shilpa ma'am about sugar. So palm sugar, jaggery sugar, is this better than white sugar? That's the question.
So not from data, but I speak from real experience. It really does not matter. Sugar, this is what I tell my patient. This is what I tell my patient, sugar is sugar and salt is salt. There is nothing like one is better than other. All sugars are same, all salts are same. So no, if you look at it in the terms of usage by patients, the postprandial sugars, if you see CGM, you see regular PPs 1 hour, 2 hour, they are all, there is no major difference. No.
Dr. Anjana, I'll just add to that. And people think because it's got jaggery or it's got an alternative form, they actually end up eating more. They assume that it's carb, calorie, and fat-free. So that is another concern. So you might as well eat the real thing and eat it in moderation with a little bit of guilt.
Yeah.
On that line, I would like to ask, yes, Ms. Sudha.
I would like to add on, people think that it is less processed, jaggery and palm sugar.
And organic.
They advertise it with, it's got more minerals and iron. Why would a fellow will eat for iron a jaggery and palm sugar instead of green leafy vegetable and least more nutrient dense and less energy dense? The calories are the calories, you know.
No, Sudha, the best conversation is that, one diabetic talking to another and saying, you know what, I have stopped taking sugar and I've stopped taking. But, I think it's really not important. You may take a little bit of sugar, but if you also pay attention to your total plate as to what you're doing. If you're doing injustice in totality and you've stopped sugar, I think it's really not helping anybody.
Yeah.
Anyway, so I think that was a wonderful discussion, but in the interest of time, we have to wind up now. Thank you, Jagmeet ma'am. Thank you to all the speakers. For the insights that you've provided. Thank you all. Thank you all very much.
Thank you so much.
Thank you, everybody.
Thank you very much.
We have winded on time. Thank you so much. So we can now move on to the next session.
Thank you, Ranjini.
Thanks, ma'am. Okay, with this now, we now move on to the last symposium and scientific session of the 8th International Diabetes Update. This is the last symposium in this hall, and with the symposium is on from old to new. The chairpersons for the session are Dr. Sarita Kakani and Dr. E. Vidya. Dr. Sarita is a consultant diabetologist at Dr. Mohan's Diabetes Specialty Center, Vijayawada. She's completed her MBBS from NTR University of Medical Sciences, Andhra Pradesh. She obtained her Master of Fellowship in Diabetology from Dr. Mohan's Diabetes Education Academy and postgraduate diploma in Diabetes and Clinical Endocrinology, UK, postgraduate course in Diabetology from Boston University School of Medicine, and postgraduate course in Advanced Diabetes from Harvard Medical School, USA. She has over 10 years of experience practicing as a diabetes care physician. She's participated in many conferences and delivered many awareness lectures, and this is a recipient of the Diabetes Awareness Initiative Award 2016 in recognition of the tremendous efforts she has put for raising awareness around diabetes. Dr. Vidya is the consultant diabetologist at Dr. Mohan's Diabetes Specialty Center, Salem. She completed an MBBS from IRT Perundurai Medical College, Diploma in Diabetology at Vinayaga Missions, Salem, and Fellowship in Diabetology at Dr. Mohan's Diabetes Education Academy. She's a member of IMA and RSSDI and has participated in many diabetes screening and awareness camps. She's delivered lectures at webinars and conferences and has also contributed to several chapters and articles. We welcome you both, and we also welcome our speakers for the symposium, Dr. Abdul Hamid Zargar. Welcome you, sir. Dr. N.G. Shastri and Dr. Bridge Makar, sir. I hand over the podium now, this virtual dais, to the chairpersons. Request you to kindly introduce the speakers.
Thank you so much, Dr. Ranjini, for that kind introduction. And very good morning to all the esteemed faculty and the august audience here. At the outset, I would like to convey my heartfelt thanks to Dr. V. Mohan sir and Dr. Anjana madam for giving this opportunity at this wonderful platform, and the entire Mohan's team who have been offering great support. And it has really been a wonderful 3-day program, and I'm happy to be closing it in the last symposium. So far we had a wonderful discussion on diet and diabetes. Now we'll be moving back to the basics, the pharmacotherapeutic aspects again. And this symposium is on old to new. We have 3 talks in this. Our first speaker is Dr. Abdul Hamid Zarkar, who will be talking on the 6-decade journey of metformin. It gives me immense pleasure, and I feel honored to introduce Dr. Zarkar to the audience. He's a consultant endocrinologist at the Center for Diabetes and Endocrinology and the chairman, Independent Ethics Committee, Fortis Hospital and Research Center, New Delhi. He's also a member of High Powered Committee, version 2035, Health and Medicine, served as a chairman at the Department of Endocrinology, director and ex officio secretary to the government, Sher-e Kashmir Institute of Medical Sciences, Srinagar. He's also served as the past president for the Endocrine Society of India and also the former editor-in-chief for the Indian Journal of Endocrinology. He has published over 200 articles in national and international journals and contributed several book chapters. Also delivered lectures in several national and international conferences, and he's also a proud recipient of several honors and awards. So with this, I hand over the session to Dr. Zarkar sir. Over to you, sir.
Welcome, Zarkar sir.
Thank you so much. Are my slides visible?
Not yet. Coming. Yes, yes.
Yes, they've come up, sir.
Welcome, Dr. Shastri and Dr. Makkar also.
A very good afternoon, dear friends and colleagues. After listening to that awesome symposium on diet and also that wonderful summary of Professor Mohan, that what is doable and what is not doable, and where ultimately we take recourse to therapeutics. Now we look at a molecule that has been in the middle of management of diabetes for a long time, has gone through rough weather in between. It is not only 6 years that we talk about metformin. In fact, its birth preceded insulin. Metformin was first synthesized in 1920s, and it originates from a natural guanidine produced by the French lilac or goat's rue, one of the earlier products that was brought to the fore. Metformin first was introduced to the market for the management of diabetes in 1960s in UK. And after a brief period of a few years only in use in the Western world, some cases of lactic acidosis were published as a consequence of consumption of other biguanides, which are fenformin and buformin. And it tarnished the image of the whole class. And metformin was banned thereafter for quite a few years. Thankfully, when metformin was introduced in the Indian market in the 70s, we continued using it all along with gratifying results. But European clinicians and FDA again returned to metformin that yes, one could use it, even though other fenformins were not allowed to be used, like fenformin, which we had used. In fact, I used it in till 2009, a very powerful insulin sensitizer. We continued using it till it was available in the Indian market. And from 1994, we have been using it liberally, and probably the most used drug after paracetamol on this planet, because diabetic numbers are so huge. Now, what made the change in the basic thought process about metformin? If we look on this cartoon slide on the left, you'll find out this is a Wikipedia's data published in Lancet in 1998. We showed there was almost a 40% reduction in myocardial infarctions in people who were on metformin than on conventional therapies that had been available from the beginning of UKPDS trial. And more amazing was the data that was published a decade later in New England Journal of Medicine, which you see on the right side. Even when the study was truncated, look at 1997, but thereafter in 1999, compared to the control arm or the conventional arm, the total number of myocardial infarction events were far lesser in metformin group. Just look at on the lower bottom two lines. The top line, 1999. In the conventional group, 83 events. In metformin group, 45. Study had already stopped. In 2001, 92 events in the people who had been conventionally treated. And in the metformin group, half as bad. And the same figures down the line till 2008, 2007, when 2008, the data was published in New England Journal of Medicine. After looking at this long-term cardiovascular benefit of metformin, identified by UKPDS, and the subsequent follow-up of people who had been intensely treated with either metformin or an alternative medication, metformin, and realizing the benefits of metformin in terms of preventing acute events, cardiovascular events, metformin became an important tool for managing diabetes right at the beginning, the initial tool. In 2015 and 2016, a lot of data was published on metformin, particularly looking at some of the conventional non-metabolic complications that patients with diabetes have, which had been conventional contradictions or contraindications of using metformin, particularly looking at kidney disease, looking at heart failure, looking at chronic liver disease, where people thought that we should not use them. There will be more chance of getting lactic acidosis or complications. Now look at this data that was published in Annals of Internal Medicine, Jan issue of 2017. It's a meta-analysis of 17 studies. Look at the top line. All-cause mortality, 5 observational studies, and data on 33,000 people. Hazards ratio 0.77 in favor of metformin. Look at the bottom line. Congestive heart failure, readmissions, 4 observational studies and data on 26,000 guys. Hazards ratio of 0.87. So was not a contraindication, in fact, was preventing rehospitalization. And this data summarized from this meta-analysis was that metformin treatment in patients with type 2 diabetes who have historical contraindications of the drugs used is associated with improved outcomes in them. So metformin is associated with reduced all-cause mortality in patients with type 2 diabetes mellitus, with chronic kidney disease, congestive heart failure, and even with chronic liver disease. So metformin also appears to reduce congestive heart failure admissions. We talk about, so ad libitum currently about SGLT2s preventing admissions for heart failure. But this was shown quite some time back with metformin in patients with moderate CKD or heart failure. And this is what came in the December issue of Clinics of North America, Endocrinology and Metabolism. Because as I said, this whole data that meta-analysis was published in Jan issue of Annals of Internal Medicine in 2017 had been published in 15 and 16. And this is the summary of that data. Metformin now should be the first-line glucose-lowering drug to control hyperglycemia in type 2 diabetes mellitus. And it is safe, very small risk of hypoglycemia, weight neutral, and some few additional gastrointestinal side effects. And the most important thing, particularly in the Indian subcontinent, it is inexpensive. So guidelines for metformin use in type 2 diabetes mellitus with mild to moderate renal impairment and congestive heart failure have changed remarkably. And this was then the FDA statement on looking at that data. They loosened the restrictions on metformin use in patients with mild to moderate kidney dysfunction. Metformin may be safely used in all patients with mild renal impairment and in some with moderate impairment. according to this new label. And metformin is contraindicated in patients with a eGFR of less than 30 ml per minute per 1.3 meters square, and should not be initiated in people who have eGFR of 30 to 45. But if somebody is already on metformin, even 40, 35, and 30 is okay. And we might need to modify the dosage of the drug that we give. Again, another decade later, first in 1997, then in Lancet, then in 2008 in NEGM, and then in this cardiovascular diabetes journal recently, again shows that metformin reduces cardiovascular mortality and all-cause mortality. Now, we in endocrinology have a huge experience with this molecule outside diabetes mellitus, and we've been using it as an ovulation-inducing drug, either alone or in combination with gonadotropins, with other counseling that we do. All of us know polycystic ovarian syndrome has emerged in the last 2 decades, a very important pathological process, particularly in young females. And it is believed in days to come, polycystic ovarian syndrome would be the commonest endocrinopathy in women on this planet. And we have been using, there's some data that we published in reproductive biology and endocrinology, looking at the ovarian morphology in women who were in the age group of 18 to 30 and in the controls, where we found out that in diabetics, polycystic ovarian morphology was almost twice common in diabetics than in non-diabetics, again telling us that there's some form of a very selective insulin resistance in these women, and we used metformin liberally. This is some data that we published about 3 decades back on infertility, and in all those women who had anovulation. At that given time, even polycystic ovarian syndrome had not been yet clearly defined when we published this data. And NIH definition, Rotterdam definition came much later. And that time, people who had anovulation, who would today be defined as polycystic ovarian syndrome, we used metformin with gratifying results. Even women who had some form of hirsutism, anyone where we thought even they had a idiopathic hirsutism, but had some suggestion of a menstrual irregularity, did respond to metformin remarkably, apart from whatever other therapies we would advocate them. Metformin has a huge action on ovaries, which time is not there to talk about. But metformin has been used for more than 2 decades to induce ovulation in women with polycystic ovarian syndrome. And there's a huge evidence that tells us, yes, it does work. And you can see this metformin use was associated with a higher clinical pregnancy rate. Look on this these are meta-analysis of different studies. And look at the midline. On the right side, benefit goes to the metformin. And you see benefit in all studies, it showed there was a high pregnancy rate when metformin was incorporated in the therapeutic armamentarium. There was less abortion rate, and there was higher carry home baby rate in women. Huge amount of data published in women who were pregnant. Now, important is look at estimated probability of a treatment being most effective in reducing a clinical outcome or an adverse outcome. Look at metformin. If you look at large for gestational age, it would reduce macrosomia by almost 94%. Neonatal intensive care admissions reduced by 60%. Neonatal hypoglycemia, we so intensely treat women with gestation diabetes or pre-gestational diabetes with pregnancy, that all those who are on intense insulin therapy, understandably we do it because it needs to be done. Hypoglycemia in the peri-delivery period is pretty high. But people who have been on metformin and have been well controlled, hardly any child goes to intensive care with hypoglycemia. In fact, cesarean rates much lower because macrosomia is far lesser. So understandably, an amazing drug there as well. Huge amount of data for the last 10 years has come in that use of metformin in cancers. Now, when you have an unbridled amount of insulin in the body, insulin basically is a growth promoting factor. We call insulin-like growth factors. And many times it has been shown that it might, if not addressed, might promote the onset of many malignancies. Time is not there to go into the individual components of this, but there's huge amount of data available. More than 100 trials are currently going on. There's a trial in Montreal University going on for the last half a decade, looking at metformin and malignancy. And it was shown that diabetes patients treated with metformin had unexpectedly low rates of cancer death and cancer incidence related to diabetic patients treated with other agents. So again, there's something yet unanswered. I think this is an amazing molecule, only that nobody owns that molecule. So nobody is prepared to spend those $1 billion or $1 million on it today. The way people will do it on newer insulins, the way people have been doing it on gliptins for the last 10 years, or currently on SGLT2 inhibitors. But if this molecule was owned by a huge pharma industry, probably many things that are associated with this molecule would come to the fore, and including this anti-cancer activity. Huge amount of data that metformin is a potent activator of activated protein kinase, which in turn inhibits target of mTOR. You know, mTOR is a gene area that is concerned directly with neogenesis and neoproliferation, and controls many signal transduction areas. Metformin has been shown to be an anti-aging drug. Studies in mammals have demonstrated that hyperglycemia and hyperinsulinemia are important factors in aging and cancer. And the drugs like metformin have been shown to reduce hyperinsulinemia in addition to hyperglycemia and decrease insulin resistance. And this has been shown to be associated with increased life expectancy and inhibits carcinogenesis in rodents. There was a beautiful paper published in Lancet 6 months back from Italy, from a basic sciences group from Milan, which shows that many age-related changes that occur in endothelium are reversed by metformin. So it seems to be an amazing molecule. Now, you know, you have many controlled drug preparations of metformin now available today. And recent data has come that metformin also has a glucagon GLP-1 enhancer activity. And that's something that needs to be understood properly. And now many people, GLP-1 enhancing activity again would mean the GLP-1 is something that is a trophic hormone for beta cells. It means that if you have a sufficient amount of GLP-1, endogenous GLP-1, or exogenous, the possibility of whatever amount of cells continue to be in the islet cells, the rate of apoptosis would slow down. And that's where this metformin right in the beginning has a huge use, because that time we still have a significant amount of beta cells. And if there is a possibility that it enhances GLP-1 or GLP-1-like activity, might play a role in furthering the longevity of beta cells. Today, these 20 minutes are not good enough to justify this molecule where you have a data for more than 7-8 decades. It has been shown to have mitochondrial activity. So mitochondrial origin diabetes, now we are aware of intestinal microbiota. And in fact, this is a huge symbiotic relationship between intestinal microflora and us. And it helps in maintaining that glucagon signaling through that GLP-1 and anti-cancer activity that I alluded to. So there seem to be many pathways that seem to be leading to the use of metformin beyond diabetes. And I think the world was deprived of a great molecule for a couple of decades, but fortunately we continued using it in late 70s and 80s as well. So in summary, metformin has been used as a safe and effective treatment for diabetes. And this particular molecule is attracting interest of investigators in fields beyond diabetes, as I alluded to. And currently now people have been using it in people with pre-diabetes. All of us know that. Obesity. Many people who have euglycemia but have morbid obesity, people have been using metformin. Polycystic ovarian syndrome, gestation diabetes, neuroprotection, and cancer protection. A greater understanding of the molecular pathways involved in all these mechanisms needs to be understood so that the benefits of this great molecule could be harnessed even beyond metformin, beyond diabetes. Thank you so much.
Thank you, Professor Zargar. I think you're absolutely right by saying that 20 minutes to talk about 60 years history of a fantastic drug. And what's very interesting about metformin is that every year we discover something new. We think we've learned all about it. Suddenly in mechanism of action, something new will come. And suddenly a new indication will come, right? From aging to cancer to everything, you name it. And there's nothing. And very little negative information. After 60 years, every molecule will have some negative effect.
Dr. Mohan,
very little.
You should see that paper in Nature. I think it came in the middle of 2020. Amazing, you can't believe it, reversing all those biochemical events that have been associated with process of aging.
Yeah.
And cancers in particular, because, I'll tell you, many things are there in, as you very aptly said, if you put something in place that gives you a benefit of 6 months, is no benefit if you expect to live another 80 years or 60 years.
Correct.
In a similar fashion, benefits of this molecule seem to be over a long period of time.
Absolutely.
You must have seen, whatever debates there are about use of metformin in pregnancy. Yeah. Endocrinologists who have been using this molecule beyond DDM have never been hesitant in using it.
Correct.
Because they've used tons of it.
And to believe that, it's difficult to believe that the US kept this molecule out for 20 years, 30 years, and in 1995 introduced it like a new drug. And I remember some of my patients who had relatives abroad. There were headlines, new blockbuster drug has come and all that. So they were asking me, my patient asked me, why don't you put us on this blockbuster drug? I said, you're already on it. No, it's new drug. Just come, doctor. Just come to US. How can it be in India before that? I said, they were 30 years behind us, and that is how they go. They couldn't believe it. How can US be 30? Just because a French drug. They kept it away for 30 years. And the moment it introduced in the market, it became a #1 drug. So whereas we have been #1 to use it,
A difference between an American or a British professor of endocrinology or diabetology is that his experience in a week is limited to 10 new patients.
Correct.
He would not be seeing a few thousand people a month like Professor Mohan or us. I'm not like, when you see those hordes of people and they are recurrently coming back to you, even, we never needed anybody's clinical trial or real world data. We are in the middle of that real world data. Yeah. When you see a lack of patients, say here, what real world data are you talking about? I have written 1 million prescriptions in my life. Isn't that?
Practice-based evidence, not evidence-based
evidence. So 4 decades. I'm so like, what else do you need?
Correct. Brilliant.
And that's chicken-hearted professor who sees those 10 patients a day and goes to courts every 3 months. Huh?
Yeah, exactly.
Would never do that.
Correct. Yeah. And because you had this wonderful talk here in the main OHA symposium, we didn't even include metformin. We kept everything for the last day as a kind of summary of everything.
I tell you, Professor Mohan, if this molecule was owned by a global concern, because now it is a generic, nobody wants to spend money on that.
Yeah.
I tell you, everything that has been associated with gliptins, you will find a paper published. You are such a prolific researcher.
Correct.
Dig it out. Whatever has been associated with SGLT2s, 80% of it, you will dig it out today also. But only that nobody proliferates it.
Correct.
And it has no rippling effect.
Because there's no money in it.
There's no money in it.
Thank you. And if there are questions,
So thank you so much, Dr. Zargar, sir, for that. You have wonderfully taken us through the journey of metformin and its uses beyond diabetes as well. I would just like to remind about a quote from the famous physicist Marie Curie, who said that nothing in life should be feared, it should only be understood. And this quote actually reflects the emergence of metformin from a poisonous herb to being most widely prescribed medicine in type 2 diabetes. So thank you so much, sir, for that wonderful talk on metformin. Sir, shall we take the questions at the end? Or
anytime you like, no issue.
Yes, sir.
The end,
we'll take it at the end in the interest of time. So I hand over the session to my co-chair, Dr. Vidya, to proceed forward with the next talk by Dr. N.G. Shastri, sir. Welcome, sir.
Dr. Vidya, just a second before we introduce the speaker. Yeah, we can go ahead, Dr. Vidya.
So good afternoon, one and all. Moving on to the next topic in the session, I'm delighted and honored to introduce Dr. N.G. Shastri, sir, who's going to present on the topic, Two Tales, One Story, CV risk and heart failure. So Dr. N.G. Shastri, sir, is the director and consultant diabetologist, Dr. Mohan's Diabetes Specialty Center, Hyderabad. He completed his diploma in diabetology and master's in diabetes care from the University of Newcastle. He underwent advanced training in diabetology at King's College Hospital, London. He serves as faculty at Dr. Mohan's Diabetes Specialty Center to train the students in diabetology. He is a member of professional bodies including IMA, APDF, and API. He conducted several diabetes awareness programs in Tamil Nadu and Andhra Pradesh, and he has published more than 15 articles in national and international journals. So with this brief introduction, I would like to welcome Dr. Shastri, sir. It's over to you, sir, to proceed with the presentation.
Thank you very much. I'll share the slides.
Dr. Shastri, could lower your camera a bit, sir?
Is it okay?
Yeah, that's much better, sir. Yeah, thank you. Yeah, its slides are visible, sir.
Thank you very much, Professor Dr. Mohan and respected chair, and also the organizing committee of Dr. Mohan's Diabetes Specialty Center, as well as Madras Diabetic Research Foundation. I'll be talking about this two tails of protection, especially sodium glucose transport inhibitor, dapagliflozin. I have some conflict of interest, like and a declaration to make, like this program sponsored by Majors Reddy's Laboratories. Like the story goes, when I want to start the tales, like I have to tell the story. Story goes back long, like when there used to be, once upon a time, there used to be a molecule called rosiglitazone. And we used to use that molecule in several people, and we used to get wonderful records, wonderful results. Unfortunately, what happened, people started gaining weight, and some of the people have to be admitted for cardiac failures and other things. After that, like the one gentleman by name Dr. Steven Nissen, like he said this, he did meta-analysis and found out those people who are taking that group of molecule are having high incidence of myocardial infarction. And he said like a cardiovascular unsafe. After that, the FDA has made it mandatory to conduct the cardiovascular outcome trials. Several trials came, like, for DPP-4 inhibitors or GLP-1 RAs or anything like that. And one such trial is declared to me. And the importance of this thing is because in type 2 diabetes, you know that more and more cardiovascular problems and more hospitalization for heart failure. And also a type 2 diabetic with myocardial infarction, it has higher risk subgroup and also high residual risk even with contemporary standards of care. In addition, the patients with previous MI, they have high risk of incident heart failure. And so it is important to preventing this major adverse cardiovascular events and hospitalization of heart failure in type 2 diabetes. And those people with a history of MI also remains a little bit of unmet clinical need. Then this wonderful study, this dapagliflozin evaluation in cardiovascular evaluation study in thrombolysis in myocardial infarction, this study. And this is a CVOT outcome trial, like a primary prevention population is around 60%. And those people with established cardiovascular disease, they are around 40%. So the major cardiovascular, adverse cardiovascular events defined as like a CV death, as well as myocardial infarction or ischemic stroke. And incidentally, like the secondary efficacy points, like more than 40% reduction in the creatinine clearance, EGFR, as also new onset of ESRD, as well as death either due to CV or renal or any cause death. They're the secondary efficacy points. Like the type 2 diabetes with the A1C 6.5 to 12, and it is event driven, and there are around 3,584 people with previous MI. Like if you see, like in this these outcome results, like the CV death and hospitalization for heart failure, there is around 17% reduction, which is statistically significant. And major adverse cardiovascular events and all-cause death and hospitalization failure, all are favoring but not reached any great significance except in the renal things. A 40% decrease in EGFR and ESRD, renal or CV death. So these group of molecules are safe, and the cardiovascularly non-inferiority has shown. As for the heart failures and CVD, both together it has shown superiority. So like this slide clearly shows that this is non-inferior to placebo. That is, there is around 7% as far as the reduction is concerned, but you see that confidence intervals 0.84 to 1.03, just cross it 1. Now, like as for the CVD and the hospitalization for heart failure, there is around 17% reduction, which is relative risk reduction when compared to the placebo, and which is statistically significant also. These cardiovascular and renal benefits of dapagliflozin in patients with short and long-standing type 2 diabetes. This analysis was done when patients were stratified with diabetes duration, like less than 5 years and 5 to 10 years and more than 10 to 15 years and more than 15 to 20 years and more than 20 years, like that stratifications done. And they say like at the those people who have the diabetes duration of more than 20 years, CV death and hospitalization for heart failure, there is a lower risk was shown, and hospitalization for heart failure across the spectrum, both CVD and hospitalization of heart failure, they have shown beneficial effects to the tune of around 25%. And major adverse cardiovascular events also come down by around 30% in those people who have diabetes duration of more than 20 years. So greater reductions in the long-standing cases was observed. With the background of a myocardial infarction, more than diabetes 20 years, like the lines are separating very well, and there is around 40%, 34% reduction that you can see in the myocardial infarction in those people with diabetes duration of more than 20 years. And also the ischemic strokes also somewhat significant, like around 39% reductions are seen, but I should say that it's a neutral, these ischemic strokes. As the duration of the diabetes is more than 20 years in the declared days, right? Like if you see the probability of the other things, like the duration of the second, there is a little bit of problem. Yeah, this there is a CV death and hospitalization for heart failure. If you look into, there is consistent decline in the CVD and hospitalization for heart failure in those people who are on dapagliflozin. So the placebo are the red and the blue are the dapagliflozin. There is a CV death and hospitalization for heart failure consistently reduced. But if you plot the duration of the diabetes on x-axis, and you can see that like initially there is not much report improvement, but after 12 years, the major adverse cardiovascular events, the duration of the diabetes is 12 years, it is showing improvement. So this data, the probability of CVD and hospitalization of heart failure and MACE with the dapagliflozin versus placebo at 1,440 days of the diabetes duration. The efficacy and the safety of dapagliflozin in elderly, the analysis from the DECLARE TIMI study, like if you stratify the people like less than 65 years and 65 to 75 years and 75 years, and two variables like CVD and hospitalization for heart failure and major adverse cardiovascular events. So across the spectrum, that is efficacy and safety are consistent as per the HbA1c reductions concerned, regardless of the age. There is a significant and similar HbA1c reductions across the all age groups. Like the solid blue lines are those people with placebo, and dotted lines are DAPA, and you can see everywhere. And also red lines are say age of 65 to 75, and the green lines are those people more than 75 years. So across the ages, like you can see, there is reductions as for the dotted lines are showing much lower when compared to those solid lines, suggesting that when compared to placebo, those people who are on dapagliflozin have significant HbA1c reductions. And also the HbA1c reduction also quick and fast when you can see there is abrupt decrement in dip in these lines. So this across the age groups, the dapagliflozin is very effective as suggested by this study. So this cardiorenal outcomes with the dapagliflozin by baseline glucose lowering agents in the background, like a post-hoc analysis from declared to me, where like people who are on, say, at the background of say metformin, as well as sulfonylureas, DPP4 inhibitors, GLP-1 RAs, and insulin. Everywhere, as far the efficacy is concerned, like add-on dapagliflozin, like definitely there is greater benefit with the GLP-1 RA plus dapagliflozin. But more and more benefit is seen when you combine with GLP-1 RA. And also the greater benefit that you see with the GLP-1 RA plus dapagliflozin here, if you see the confidence intervals, like it is a 0.07 to 0.07 to 0.60, suggesting that like maybe some chance finding. So dapagliflozin, it has reduced the composite of cardiovascular death, hospitalization for heart failure versus placebo, regardless of the baseline glucose lowering agent, whatever it may be, whether it's the background of sulfonylurea, GLP-1 RA, or metformin, or DPP4 inhibitors. Dapagliflozin and cardiovascular outcomes in patients with type 2 diabetes mellitus and previous MI. The sub-analysis, I'm just telling you. This declared to me, you know that like you have around 17,000 patients, and also who had around 3,584 patients had a previous history of prior history of MI. Like in India, like you have around 30 to 39% of the CAD patients are known cases of diabetes. And Dr. Mohan et al. Like in 2001 have shown that coronary artery disease is in around 21.4% of patients with diabetes. So this is major adverse cardiovascular events, CV death, MI, or ischemic stroke.
Moving on to the next topic, moving on to the final topic, Rashmi.
Okay, like this red line is placebo and the blue line is the dapagliflozin. The dotted lines are those people with no previous MI, and if you see in both the curves, like where those people with previous MI, also there is a significant increase in the dapagliflozin, but without previous MI, there is not much difference. And also there is a 16% relative risk reduction in the major adverse cardiovascular events. So this is those people with previous MI and these people with no previous MI. As far as the CV death and hospitalization for heart failure, like again, you can see that like in the composite, definitely those people with the previous MI, those people who are on dapagliflozin got benefited. And this the time is progressing, like maybe at around 1.5 years around that time, like there is some difference as far as the this blue line is separating. So there is absolute risk reduction of around 1.9% in those people with MI, and those people without MI, there is around 0.6%. These outcomes like major adverse cardiovascular events, this greater benefit in those people who had MI less than 2 years ago, like it is favoring those people who had MI, and dapagliflozin is better in those people who have MI less than 2 years ago. So this group of drugs are very useful, and the dapagliflozin produced significant reductions as for the renals and the cardiovascular disease, and number needed to treat is around 53 for 4 years. And as far as the major adverse cardiovascular events, like is particularly beneficial in those people prior MI, that is in the top of the pyramid, like less than 2 years, and those people with prior MI are definitely benefited by giving this drug. And also atherosclerotic cardiovascular disease, like we don't have much data, like the primary prevention, it is not as far as useful as far as the CVD is concerned. So there is a significant reduction in major adverse cardiovascular events in patients with a history of prior MI. Heart failure and renal benefits are across the spectrum, all groups it is observed. This effect of dapagliflozin on heart failure and mortality in type 2 diabetic patients with reduced ejection fraction. It is a sub-analysis of the DECLARE-TIMI trial. And heart failure with reduced ejection fraction is around around 3.9% of the population, that is of 17,160 of type 2 diabetic patients. And also known reduced ejection fraction is around without known reduced ejection fraction around 7.7%, no history of heart failure around 88.4%. And you know that in India, like 50% of the patients with chronic heart failure, they have diabetes. So those people with reduced ejection fraction, like the CV death hospitalization for heart failure have come down by around 38%, and the number needed to treat around 4 years and 11 people. CV death down by around 45%, and hospitalization heart failure has come down by 36%. All-cause mortality has come down by around 41% in those people with heart failure with reduced ejection fraction, and the number needed to treat around 4 years around 16 patients. Without ejection fraction, reduced ejection fraction, that means preserved ejection fraction, CV death and hospitalized heart failure have come down by around 12%. CV death, there is no effect. All-cause mortality, no effect, and hospitalization for heart failure around 24% reduction. That shows that like these group of molecules are wonderful in especially those, with the heart failure with reduced ejection fraction. You see the Kaplan-Meier curves in the background of combined CVD and hospitalization heart failure. There is better relative risk reduction in patients with reduced ejection fraction when compared to those people without reduced ejection fraction. And these are the people with green bars are the people without heart failure, and the blue lines are preserved ejection fraction, and red lines are those people with reduced ejection fraction, where the lines are separating so early and so fast. This is only heart failure without CVD. If you look into there statistically significant reductions you are able to see around 36%, and there is a lower risk of hospitalization for heart failure without reduced ejection fraction. It is around 26%. 28%. So hazards ratios with reduced ejection fraction around 0.64, and without REF around 0.76. So thank you very much for your patient hearing, and try to conclude saying that this dapagliflozin reduces the risk of cardiovascular disease and hospitalization for heart failure in type 2 diabetes. Dapagliflozin is non-inferior to placebo for reducing the major adverse cardiovascular events in type 2 diabetes and in patients with high CV risk. Dapagliflozin reduces risk of MACE in type 2 diabetic patients with the previous MI, especially those people that die MI within 2 years. Greater reductions in the risk of MACE in long-standing cases of type 2 diabetes. Overall efficacy and safety of dapagliflozin are consistent regardless of age. At the same time, I want to say that, you know, that the sodium glucose transport inhibitors are included in all the guidelines, either ADA or IDF or American Association of Clinical Endocrinologists, everywhere. And right on the top, almost it's there. Now, like in a country like India, where the low acquisition cost of the medication is also important, it's a compelling need. In such case, like medicines, especially of the three molecules which are available in India, DAPA, CANA, and EMPA, and DAPA is much, much cheaper, and more people have started using recently once the cost factor has come down. So I thank you very much for my patient hearing, and over to the organizers.
Thank you, Shastri. I also wanted to just congratulate you on a very nice talk, very practical points.
More stats.
Thank you, sir. With interest of time, we'll move on to the next talk by Dr. Brijmohan Makkar, who will be speaking to us on the novel agent hydroxychloroquine in the management of type 2 diabetes. The session is over to you, sir.
Before they get on with the rest of the program, I wanted to thank Dr. Makkar for taking up this important topic. It's always an honor to have you with us. And this time we've given you a slightly unusual topic, hydroxychloroquine. I think only in India this molecule is discussed, but it is approved and it does have a lot of evidence, and I'm sure you're going to do justice to that. Thank you once again for being part of our meeting every year. And
thank you, sir. Thank you. Good afternoon, sir.
No, you are not
Thank
going
you.
to be introduced now. The chairperson will introduce you. Thank you. I just butted in. Sorry.
No, sir. It's a pleasure to see you in the session. I was thinking you must be busy. You may be joining or no.
No.
It's always a pleasure to see you, and it's always an honor to be part of this meeting, sir.
Thank you. Thank you so much.
And
Sarita.
Yes, yeah, we'll proceed, sir. Dr. Brijmohan Makkar is a diabetologist and director at Dr. Makkar's Diabetes and Obesity Center, New Delhi. He's
actually,
also the
Sarita, you can skip this. There is no need.
Sir, let me brief it, sir.
Continue.
Yes, sir.
No.
He's also been course director at the Cleveland Clinic Advanced Certificate Course in Diabetes in India. He's also served as a former honorary secretary at the RSSDI, also served as immediate past chairman for the RSSDI Delhi chapter, been a member on the executive board in the Diabetes India. He's also a member of prestigious institutions like ADA, AS, and EASD and Canadian Obesity Research Network. He's certified trainer for stage diabetes management program from International Diabetes Center, Minneapolis. And he has got international work exposure at the UCSF San Francisco, at the Cleveland Clinic, Johns Hopkins, Oxford Diabetes Center, and the Mayo Clinic. He also has, to his credit, several publications in peer-reviewed national and international journals. It's an honor, sir, to have you today at this platform, and over to you, sir.
Thank you, Dr. Sarita, for that kind note. Shall I share my slides? So can you see my slides now?
Yes, sir. They are visible, sir.
Okay. So good afternoon, everyone. At the outset, I would like to thank Dr. Mohan sir once again for always keeping me on in this meeting, and sir has been a constant source of inspiration for many diabetes physicians like me in India, and I'm sure we will keep getting inspired from him in times to come. God bless you, sir, always. And thank you, Team Dr. Mohan Center, for this opportunity. As this is a sponsored session, this is my disclosure slide. So just to give you a brief background, the hydroxychloroquine was first approved for clinical usage in 1955, basically for use in rheumatoid arthritis and lupus, and then it came into the WHO essential list of medicines. In India, it got first approval for rheumatoid arthritis from the CDSCO, and in 2014, it was approved for usage in type 2 diabetes by DCGI. Now, what are the mechanisms by which hydroxychloroquine contributes in type 2 diabetes? There are 4 key mechanisms. One, it leads to inhibition of insulin degradation. It reduces the inflammation, improves insulin sensitivity, and helps in beta cell preservation. And I'll briefly show you each of them. So what hydroxychloroquine does is that it enters the cell and changes the intracellular milieu so as to reduce the degradation of insulin inside the cell. So this cartoon shows that insulin is taken up by the receptor, gets internalized, and gets degraded inside the cell by various insulin degrading enzymes. What hydroxychloroquine does is it causes the alkalinization inside the cell, leading to inactivation of these insulin degradation enzyme, and the more of insulin gets secreted from the cell as it is without degradation and is available for usage again for causing cellular stimulation. So it improves or enhances the action of insulin. And the studies have clearly shown that as the hydroxychloroquine concentration goes up, the degradation of insulin is decreased, and there is a kind of very strong correlation between the levels of hydroxychloroquine and the increasing insulin levels. Second thing is, we know that it is a very strong anti-inflammatory drug, and the studies have clearly shown that not only this leads to reduction in the A1C, significant reduction in the range of 1%, it also leads to significant reduction in high sensitivity hsCRP levels, which are very important marker of vascular inflammation. Now, third thing is that studies have also shown that hydroxychloroquine improves insulin sensitivity and beta cell function. This was a clinical pharmacodynamic study, involved I think about 30 patients, randomized, double-blind, parallel arm, non-diabetic, actually these are pre-diabetic people who were treated with hydroxychloroquine versus placebo. And the study showed that there was a significant improvement in insulin sensitivity as well as beta cell function. The improvement in insulin sensitivity was about 20% and beta cell function was about 45%. This is an experimental study done in rats. Again, this group of rats which was introduced diabetes with streptozotocin, they were given hydroxychloroquine versus no hydroxychloroquine and followed up. And the study clearly showed that the rats who had been induced diabetes with streptozotocin and given hydroxychloroquine, they had preservation of beta cell mass, and as compared to those who were not treated with hydroxychloroquine. And at the same time, there was decreased proliferation of alpha cells in these mice. This was the first Indian phase 3 trial which looked at the safety and efficacy of hydroxychloroquine treatment of type 2 diabetes. This was a double-blind randomized comparison trial with pioglitazone. 800 plus patients were screened, of which 267 finally randomized to hydroxychloroquine versus pioglitazone. And all these patients were already on metformin and sulfonylurea at the maximum tolerated dose or the optimal dose. And during the 6 weeks follow-up, 6 months follow-up, there was a significant reduction in the A1C level in the range of 0.9%, which was similar to the reduction given by pioglitazone. Not only that, there was improvement in the lipid parameters. There was reduction in total cholesterol, LDL, as well as triglycerides, which was better than the pioglitazone effect. Now, I will take you through some international studies and some Indian data supporting the the anti-hyperglycemic efficacy and safety of hydroxychloroquine. This is a very interesting study. This was a prospective multi-center observational study which involved 4,900 patients with rheumatoid arthritis, of whom about 1,800 had taken hydroxychloroquine and 3,100 had never taken hydroxychloroquine. And they did not have any known cardiovascular disease at the time of initiation of the study. And they were followed up for a mean period of 21.5 years. And the study showed that there was a significant, almost 70% reduction in patients who had been treated with hydroxychloroquine for more than 4 years. These are some studies which again looked at the impact of using hydroxychloroquine in type 2 diabetes patients who were on oral agents plus minus insulin, and 6 months usage of hydroxychloroquine was associated with significant reduction in A1C level. Another study, looked at, this was again, important is this is randomized double-blind placebo control using hydroxychloroquine versus placebo in type 2 diabetes patients for 1 year period who were not controlled on metformin 100 milligrams plus glimepiride 4 milligrams. Again showed significant reduction in fasting glucose levels, significant reduction in postprandial glucose levels, and significant reduction in A1C levels in patients who were treated with hydroxychloroquine versus placebo. Now, some studies showing you the efficacy of hydroxychloroquine when used as third agent after metformin and sulfonylurea, which is the common setting in India. And this is a study from Dr. Manoj Chawla from Mumbai, prospective investigator-initiated single center study, 15 patients with uncontrolled type 2 diabetes on metformin sulfonylurea given 400 milligrams metformin. Hydroxychloroquine showed a significant reduction of 0.88% in A1C level, significant reduction in fasting level, and improvement in lipid parameters. And there are a number of similar studies from different centers in India where hydroxychloroquine has been added to patients who are suboptimally controlled on metformin sulfonylurea or metformin sulfonylurea plus DPP4 inhibitors or insulin. And again, across board, you will see that addition of hydroxychloroquine gives you a significant reduction in fasting and postprandial glucose levels, as well as reduction in A1C levels and improvement in HSCRP levels. Now, there are a number of studies which have compared using hydroxychloroquine 400 milligram added to metformin sulfonylurea as compared to DPP4 inhibitors. And these studies have been compared hydroxychloroquine with the addition of tenaligliptin, sitagliptin, vildagliptin, and so on. And across board, again, this has been shown that there is a benefit of adding hydroxychloroquine to combine already existing combination therapy in terms of reducing A1C as well as fasting and postprandial glucose levels. Now, the most commonly, talked agent or the flavor of the season is SGLT2 inhibitors, and let us see how it compares with SGLT2 inhibitors. This was a 24 weeks observational multi-center study. Type 2 diabetes with A1C of more than 8.5% on stable treatment with glargine, glimepiride, and metformin for at least 3 months prior to inclusion were given hydroxychloroquine 400 milligram versus dapagliflozin 10 milligrams. Similar A1C reduction over 6 months period, similar reduction in the fasting glucose, similar reduction in the postprandial glucose. And not only that, there was a similar reduction to dapagliflozin in terms of weight reduction and no severe hypoglycemia. Comparison with canagliflozin in real-world studying, again, multi-center randomized parallel group, open label, uncontrolled type 2 diabetes patients on maximum tolerated dose of Vilda plus metformin, randomized to receive hydroxychloroquine versus canagliflozin 300 milligram. Similar A1C reduction don't get affected by the depth of these bars because the baseline starting here is minus 1.13. So minus 1.13 to 1.21 and minus 1.13 to 1.16. This is similar A1C reduction as compared to CANA, similar A1C reduction, similar fasting and postprandial reduction as compared to canagliflozin. Now, a number of studies have also looked at using as hydroxychloroquine in the setting where patients are already on 2 or more oral agents and insulin. And the addition of hydroxychloroquine has shown a reduction in the dose requirement for insulin across board in these patients. Now I'll show you some of the papers, recent papers presented at major international conferences like ADA. This was a real world study, included 1500 odd patients, uncontrolled diabetes, receiving metformin and sulfonylurea combination for at least 24 weeks and were added to receive 400 milligrams of hydroxychloroquine. 1,297 patients completed the study. The study showed that there was a significant reduction in A1C both at 12 weeks and 24 weeks. There was a better achievement of A1C target of less than 7%, and the A1C reduction of more than 1% was achieved in more than 60% of the patients. Not only that, there was improvement in lipid parameters as I showed you earlier, and the adverse events were not significant. Only one patient had, mild retinopathy who was discontinued. Another real life study from Dr. Manoj Chawla, 95 patients of type 2 diabetes already on anti-diabetic agents, 2 agents, plus having statin and antihypertensive therapy, improvement in A1C of the range of 1.05%, reduction in fasting, postprandial, and improvement in all lipid parameters across board. The study showed that A1C reduction was significant. There was total cholesterol and LDL improvement also, and the body weight also came down, in the range of 2 kilograms or 1.5 kilograms in this study. No cases of hydroxychloroquine induced retinopathy at the end of 52 weeks follow-up. Only one patient was detected to have mild NDPR and discontinued. Mild adverse events or drug was safe, found to be safe and well tolerated. This is a study which looked at the safety efficacy of 52 weeks usage of hydroxychloroquine, which is the first anti-inflammatory approved in India for management of diabetes. Study involved 600 type 2 diabetes patients uncontrolled on metformin and sulfonylurea, given hydroxychloroquine for 400 milligrams for 52 weeks. Of the 405 patients completed 24 weeks in the study, and 234 actually completed the study till the end. Significant reduction in A1C both at 24 weeks as well as 52 weeks, and significant A1C reduction irrespective of whether these people had increased HSCRP level or normal CRP level. The CRP stratification was done by the cutoff of 3. Now, if you look at the graphs in the lower part of the slide, there was not only improvement in the glycemic parameters, there was significant reduction in the HSCRP levels also improved, showing the improvement in the inflammatory status. So DCJ approved this drug way back in 2014, and this was approved for usage as an adjunct to diet and exercise to improve glycemic control in patients who are already on metformin sulfonylurea combination. So approved as third line drug, and it is mentioned in the RSSDI clinical practice recommendations also. Now let us move to CV protection, see what data is there supporting the use of hydroxychloroquine in terms of improving CV parameters, and do we have a CV protection data actually. So we don't have a CV outcome trial here, but this is a very interesting study which was done on RA, rheumatoid arthritis patients. So retrospective study included RA patients who were given hydroxychloroquine between January 2001 to October 2013, and the study excluded all patients who had, previous cardiovascular disease. Now, if you see these patients, the patients who were treated with hydroxychloroquine had 72% reduction in the risk of developing cardiovascular disease. This is another study published very recently, looked at the association between hydroxychloroquine and cardiovascular morbidity among rheumatoid arthritis patients. Retrospective study involving 514 patients again showed that hydroxychloroquine had a significant protective effect on all cardiovascular events, and there was a significant protective effect on myocardial infarction, stroke and TIA, and venous thromboembolism. Another study which looked at that hydroxychloroquine may reduce the risk of developing coronary artery disease in patients with rheumatoid arthritis, and again showed 68% reduction in the development of coronary artery disease events. This is a study which looked at the impact on lipid lowering when you combine hydroxychloroquine with atorvastatin. And study showed that as compared to atorvastatin, if you are using atorvastatin hydroxychloroquine combination, there is a significant reduction in total cholesterol, LDL, and improvement in HDL as compared to atorvastatin being used alone. So important lipid lowering, property shown in this study. Studies have also shown that hydroxychloroquine has anti-platelet properties, and we have a OXY trial, which is the ongoing CV outcome trial with hydroxychloroquine. The study is involved 2,500 patients who were hospitalized for myocardial infarction, and patients will be receiving hydroxychloroquine versus placebo for at least 12 months or till we achieve 350 cardiovascular events. So this is an event-driven trial. The primary endpoint is the composite of death, myocardial infarction, hospitalization for unstable angina, urgent PTCA, or urgent CABG. And this study was supposed to end in 2019, but I think we still don't have results because of the COVID and other things happening. So coming to the last part, is it safe to use hydroxychloroquine for long term? Because this question comes because this is the same molecule, so very similar to chloroquine. So we have reports that it can cause hyperpigmentation, but this is a long-term follow-up study in patients with the SLE who were on hydroxychloroquine, showed that incidence was only 7.3% at 6.1 years of continuous usage. So hydroxy addition to the chloroquine, hydroxyl group addition to the chloroquine makes it much safer for long-term usage. And the risk of retinopathy, which is a concern, studies have shown that if there is a usage of more than 5 years in the dose of less than 5 milligram per kg, continuous usage for 5 years is associated with 1% risk of retinopathy, and more than 10 years usage is associated with 2% risk of retinopathy. So we have, a recommendation from Royal College of Ophthalmology. This is 2018 recommendation. Clearly states that hydroxychloroquine long-term use is quite safe. If you are planning to use over 5 years, have a baseline examination, and if there is, macular involvement, just have another examination with optical coherence tomography, and then subsequent follow-up is required only after 5 years of usage. So it is not required on annual usage. So key consideration to be kept in mind that still we don't know the safety in pregnant lactating women, in children, in elderly. We have to keep in mind there may be concern relating to the renal function. Contraindications are known hypersensitivity or pre-existing maculopathy. You should avoid using this drug. When combining with other drugs like sulfonylurea or insulin, there may be increased risk of hypoglycemia. So take-home message, hydroxychloroquine appears to be a safe and effective anti-diabetic drug. In addition to its anti-inflammatory properties, leads to A1C reduction of 0.9 to 1.3%, has additional benefits of improving lipid profile, improving body weight, and anti-inflammatory properties. There may be cardiovascular benefits as shown in earlier studies. We still have, answers awaited from the Oxy trial. Can be started in all patients who have type 2 diabetes and are not optimally controlled on 2 or more agents. That is the current recommendation from DCGI. As for the risk of retinopathy is concerned, it is recommended to have a baseline screening at the within first year of usage and then annually after 5 years. So with this, I come to end of my presentation. I hope I should have finished in time, and over to the organizers.
Thank you so much, sir, for that very wonderful and well elaborated talk about the novel agent hydroxychloroquine. And you are well on time, finished it. So I think the session will be opened up for a few questions now. Thank you so much, sir. So I think we'll start with Dr. Zarkar, because he was the first speaker in this symposium. So there's a question for you with respect to the use of metformin in post-COVID patients who had respiratory failure. Any guidelines to restart or continue metformin? That is the question, sir.
Fundamentally, if a person has an acute critical sickness, so let us say a COVID pneumonia, guidelines for that treatment are absolutely clear. At that given time, it needs to be treated as an acute sickness and accordingly needs to be treated. But in majority of the people who have been taking metformin and are reasonably well controlled, 80 to 85% of diabetic patients also would be asymptomatic or will have borderline symptoms like some myalgias, fever, arthralgias. In them, we do not need to stop this drug. But looking at the recovery of the basic complication, if a person has been hospitalized or has been put into the intensive care, post-COVID, now we know a year down the line can be quite unpredictable. In 80% of the people, the lungs would do well, those who manage to survive. In them, in 6 weeks, you can get back to the previous therapy. But in about 20% of the people, particularly the ones who are left behind with some fibrosis or some continued respiratory embarrassment, they will need to be treated according to the time they are seen at. The random guidelines cannot, invariably, those sick periods would be covered by insulin only.
Yes, sir. Thank you. There's also one more question for you, sir. With respect to metformin and PCOD, is it necessary to start metformin in PCOD even though sugar levels are normal?
Use of metformin in PCOD has nothing got to do with diabetes. It has something got to do with insulin resistance. Even in diabetics, conventional type diabetics, insulin resistance precedes a decade before actual diabetes sets in. All of us know that PCOD, if people do not change their lifestyle, particularly the obese type, we have a very small non-obese polycystic ovarian syndrome also, which endocrinologically is different, which fundamentally is a disease at the hypothalamo-pituitary level. But this 80% of the people, almost 40% of them would develop diabetes by the 40th birthday, because that is the time frame that will have in having significant beta cell apoptosis. But when we see them initially, you see, some people coming to us in the 16th year, 18th year, 20th year for menstrual irregularity or some hirsutism. At that time, we give them for breaking that insulin resistance, because there is more selective insulin resistance at the ovarian stroma level. And we try to break it down and get the benefit of the metformin there.
One more question to you, sir. How about the real-time use of metformin in heart failure, since it has got CV benefits, sir?
If you look at the data that I was showing, there are 17 different studies that have been published prior to 2016, which have shown that rehospitalization even in heart failure is markedly reduced with a hazards ratio of 0.7, 0.6. And it is only after that, in April 2016, ADA came with the guidelines that, yes, it is not an absolute contraindication, but it's something like in the renal failure. which we will understand better in terms of quantifying it. If somebody's EGFR is 45 or above, give metformin, no doubt. If somebody's EGFR is more than 30 but less than 45, if the person is on metformin, continue it. But if you want to start this person on metformin, give half the dose. If a person's EGFR is less than 30 and a person is on metformin, give half the dose. But if you get a new patient, don't start him on metformin. In a similar fashion, you grade the heart failure. Like, currently we have so many guidelines of heart failure with reduced ejection fraction. But there is a heart failure also with the retained ejection fraction. With that retained ejection fraction, invariably you will not have a problem. But when you look at reduced ejection fraction, right from by less than 50%, less than 40%, even up to 40%, it can be easily given in a good dose. And in that also, it has been shown that it reduces hospitalization for heart failure.
Thank you, sir. So one more question. In case of obese type 2 diabetic patients who are on metformin and going for IVF therapy, okay, is it advisable to continue the metformin during the IVF procedure, or we have to stop that one?
Continue the dose, fortify it, give the maximum tolerated dose. The data have shown that whether you use ovulation induction techniques or use IVF, this is not a contraindication for giving metformin. In fact, I'll tell you, I was rather recently, a couple of years back, in a UK diabetes meeting in London, in one of the workshops. And they say many endocrinologists said in obese people who otherwise have a relatively high rate of abortion, we routinely give them metformin even if they do not have diabetes. So many benefits have been associated with this diabetes.
Yes. With any more questions to Dr. Zerkers? Otherwise, I'll take up questions for the next speaker. Yeah. So, Dr. Shastri sir, we have a question for you. They've asked you to enlighten the mechanism by which SGLT2 inhibitors would produce cardioprotection.
Yeah, like the 3 trials, like EMPA-REG, DECLARE-TIMI, as well as CANVAS program, all those clearly showed the cardiovascular benefit. The sodium glucose transport inhibitors, were like to choose osmotic diuresis, natriuresis, and there is a reason like immediately you'll be seeing some benefits. And also, Dr. Kamlesh Sharma earlier enlightened us, like even in the cardiac myocyte metabolism, there's benefits that are seen because of the phosphorylation that occurred at the cellular level, as well as the alternate fuel hypothesis, where the ketone bodies in the subclinical level that may help the cardiac muscle. And also, studies have shown that there is some reductions in the left ventricular mass. All these things contribute to the cardiovascular benefits. In addition, the uricosuric benefit, which is unique to this group of drugs, like which none of the other glucose lowering agents have, that is also a beneficial aspect. So it is several things, like only when compared to even loop diuretics, this group of drugs, they reduce interstitial edema. That is the reason, like even in addition to those people who are on ARB or even ARNI, other compounds, you add on either DEPA or EMPA, like you'll be getting the extra benefits. So there are multiple mechanisms, some are postulations and other things which contribute to the thing. I request my co-speakers also, if at all, to add anything like that.
Very well said.
Dr. Makkar sir, would you like to add anything?
Thank you. No, I think he did the job.
Okay.
Yes, sir. Thank you. So there's one more question. It is with respect to using metformin as the first-line therapy. The question says, in a newly diagnosed pre-diabetic or mildly diabetic obese patient who can be a candidate for diabetes reversal, can we use GLP-1 analogs as the first line rather than metformin?
For me?
Yes, sir. Anybody else can take it.
You see, I'll tell you, there are many drugs that can be used, but you have to look at the epidemiology of a disease and cost effectiveness. Now, it's not, when you look at pre-diabetes, you are not looking at a population of 10, 20, 30, 50, 100 people. You are looking at taking care of millions of people globally. You know, when I look at it, when I became a physician, India had a diabetic population of 11 million people. When I became a professor of endocrinology, India had 19 million diabetics. When Mohan presented his data, and the in-depth study, we had 64 million diabetics. When COVID started, we had 77 million diabetics. When COVID is still there, by the end of this year, you will have 80 million diabetics in the country. So by corollary, you can imagine how many people will have pre-diabetes. Now, many times, Professor Mohan and Makar and Ganpati will bear it out. There are so many people who have genuine diabetes where you find constraints in using drugs like GLP-1 receptor agonists. Now, for pre-diabetes, getting into that would be a bit too much. I would say, apart from lifestyle, metformin is something that is acceptable. And I'll tell you, Shastri was just now talking about this SGLT2 inhibitors. I saw that some people are now trying to contrive a study on using SGLT2 inhibitors in pre-diabetes and find out how it prevents. Because now people feel so confident with SGLT2 inhibitors after DAPA-CKD, after creatinine, where they have used the drugs in non-diabetics and found out so many benefits. Now they're saying that can these benefits go beyond, like if a person has pre-diabetes and has a tendency towards coronary artery disease or some, not of diabetic origin, of some other origin, if these drugs could be used early. There was one Paris prospective trial which was published in 1988, which showed that if you have IGT, coronary artery disease is 3 to 5-fold more. They published their subsequent data in 1992 in Diabetology. Again, they said many people with pre-diabetes may not develop diabetes, but they will be more predisposed to develop coronary artery disease. So people are from metformin handed over rather than GLP-1 to going more into SGLT2 inhibitors because, rather easily doable. But if somebody is asking from the point of view of the magnitude of obesity that world is witnessing, you see, let us look at India. The last global paper that we have been a part of, published in Lancet in 2014, showed that in 1975, Indian men and women were at globally position number 19 in terms of obesity. But currently, Indian men are at position number 5, and Indian women are at position number 3. We have the highest number of obese women in the country today, after United States and China. So if somebody is saying that you use SGLT2 inhibitors like Saxenda or something like that, for that benefit and prevent whatever happens after obesity and prevent that happening, there is a reason and rationality for that, but that will not be a general recommendation. That will be a selective recommendation by a professional on one-to-one basis.
Thank you so much, sir. Well said. And we have one question to Dr. Makkar. Sir, how long can we give HCQ safely in a diabetic patient?
So I was waiting for this actually, because I tried to answer this question during my presentation. The only concern for long-term usage is, one is the hyperpigmentation if somebody is getting it. And second is the retinopathy. And for retinopathy, if you are doing, proper screening at baseline and following up annually after 5 years, I think you can use it for long-term. Now, how long is always a question till we have very long-term studies showing 4 years or 5 years follow-up of any particular drug. But we don't have that data as of now in a prospective study in diabetes patients. But it appears to be quite safe if you look at the usage in rheumatoid arthritis patients or, patients with other connective tissue disorders, because this drug has been used for continuously 20 years and more. So it appears to be quite safe.
Thank you, sir. I think we are running short of time. Dr. Vidya, would you like to take up one last question before we wind up?
Yeah, one more question to Dr. Shastri, sir. As a primary CV prevention, Shastri, sir.
Yeah.
Is primary CV prevention necessary for all type 2 diabetic patients? If so, statins alone is sufficient. And when antiplatelets are indicated? As a primary CV prevention in type 2, yeah. Because we see a lot of prescriptions who are on antiplatelets, so because of their duration of diabetes and hypertension, they come with the antiplatelets in their prescription.
Like yesteryears, like we used to think like the diabetes, obesity, when there is other risk factors like hyperlipidemia, systemic hypertension, routinely we used to give aspirin. Okay, now like last 3-4 years, like you have seen their little change, like the Australian studies and other studies have shown that if the benefits with the aspirin, like if it is coming to around 28%, 30%, and the side effects are almost to the 30%. So that means like routine administration of aspirin now gone a little backseat, unlike years. And also injudicious use of clopidogrel is another thing that is seen in the prescription. Like actually cardiologist should prescribe that when there is a definite need when they want to give dual antiplatelet agents. But unfortunately, you know that like if the patient says a little bit of side effect, minor side effect, immediately aspirin is taken off and clopidogrel added. So that's another problem what we see in routine practice. Primary prevention is very important. Like definitely in the diabetic patients, like just stenotype, I said like just controlling diabetes never helps. Like you have to address all the risk factors. You have to make the person to understand to lose weight and make the person to stop smoking, and also control the lipids and control the blood pressure. So all the factors are absolutely essential as far as this cardiovascular disease prevention.
Thank you so much, sir. With the interest of time, I think we should
I
start
have a small
taking
question
questions.
to Dr. Makka.
Sir,
Can I give?
Running out
might
of
have to wrap up, sir,
Okay,
because
okay.
everybody's come out for the valedictory function. I'm so sorry,
Yes.
sir. You'll have to
Okay.
a message to him.
Thank you.
Thank you so much, all the three
Nice to
speakers,
see you,
Dr.
Dr.
Makkar,
Makkar.
Dr.
Nice to meet
Shastri,
you,
and
Abhirana.
Dr. Jagar.
See you
Yeah.
in person next year.
Thank you.
Thank you.
Thank you so much.
Thank you.
Thank you so much. Do join us for the valedictory, sir.
Jadgar and Professor Jadgar and Dr. Makka.
Yeah. Thanks, chairperson. Thank you. So with this, it's a wrap to our 8th Dr. Mohan's International Diabetes Update, brought to you again on this virtual platform. We request everyone to kindly join us for the valedictory function in the Professor M. Vishwanathan Hall and hear the closing remarks from our chairman, Dr. Mohan. Thank you, everyone. See you next year, hopefully in person. Sir, you're speaking something. You're on mute, though.
When I'm speaking, no, like my slides ahead, I'm not able to see in my computer. There's some problem from my computer side.
Okay, sir. Okay, sir. You did very well, sir. It was very nice.
Anyhow, how to go to the MV hall? Like,
So you just have to join to the other hall. That's all. Vishwanathan Hall.
Okay. So
I think the scientific expanse and depth of this meeting of Dr. Mohan's International Diabetes Update with the shining team has been simply spectacular. In my, own phrase, it would be like the Indian ADA. It's that good and even better because it even has your personal touch. So, sir, you, Dr. Anjana, Dr. Ranjit, Dr. Pradeepa, and the entire team, fabulous job. I can only pray that it should just remain this way. It should just get better. So, heartiest congratulations, my pranams.
Thank you.
Truthfully, we do the least in this. You see all the faces lined up here. They're the ones doing all the work.
And I'm going to start naming them as soon as anyone else who wants to talk is finished. Anyone else? Anyone stand up? I can't see so many.
No, I think you can.
Okay.
Go ahead.
So then now let me go ahead and thank, a lot of people. I have to at least mention their names. For us, as you know, we don't do anything slipshod. Anything that we do needs perfection because making excellence a habit is something I've committed in a book, and I can't give up that excellence when we do a meeting like this. And therefore, everything right up to the last comma, full stop is checked. And for that, how do we get the confidence when you're doing a million things? How do we get the confidence to do a meeting like this? Because right from tomorrow, we'll start something else. And so 365 days, you're doing something or the other, including research and so on. It's because we have people like Pradeepa. And, if I have somebody like Pradeepa, I can just leave it to her and I can see how many people in the chat and in the, WhatsApp group have congratulated her. So if I has to single out one person, it has to be Pradeepa because she will, she won't spare us. You should see how many times. Say, Pradeepa, leave me alone. She said, no, sir, one chairperson missing. I can't go to sleep without that. Please, can you give me till tomorrow? No, sir. Please tell me today. I can't sleep without putting a chairperson. That's how she nags us and gets things done. And Pradeepa, you're amazing. So it's because we have Pradeepa around that we're able to do it.
Support, all your support.
Yeah.
Dr.
And she's also supported by a huge team. And so in her own team, we have Ms. Chella, Sunita, you can see all of them here, Nirmala Lungovan, Mrs. Lakshmi and team. And probably can hold the applause until the last and then give them all a big round of applause. There's your hands will start paining. And then, of course, we have the HR team led by Mr. Appadure, who's been doing a fabulous job. Sudha, I can't thank you for talking to the farmer. That's one big load off my head. I don't even talk to the farmer. If you want me to share a secret, I don't even talk to the farmer. And I say, talk to Sudha. I'm not even getting into this. Whatever you want, you ask her, So Sudha is the, kingpin around whom.
She's the silent heroine.
Yes, silent heroine. So when one person is doing the scientific job of it, because without the pharma, we cannot run this meeting. Obviously, we need support and so on. And so she does that, and she does it remarkably well, and she's a better person to talk to than I am, because I'll go and say something stupid, whereas she knows this much better than me. So Sudha does that. But of course, we have Miss Pradeepa, Mr. Srijit, Mr. Karthik, Mr. Abdul, and the entire HR team. It's a tough job getting everybody on board. And then, of course, we have IT. Now, in every other meeting, it's normally outsourced and so on. But, we have our own team of Mr. K. Sundaraj, Mr. Pratap, Mr. Saravanan, Mr. Sheshadri, Ms. Murli, and the IT team. And believe it, somebody asked me, are you all sitting in the same place? No, we are not. We are sitting at home. This is my home. Okay, with all this is my home. And Anjana is sitting in another room. And Ranjit is taking another room. Just now he has come. So in the home itself, there are 3 places set up, And you can imagine all those 3 being coordinated. And then, of course, in the hospital, it's in a different place. And there also, there are a couple of places. And then all the, staff and everyone coming together from different places, coordinating that itself is a nightmare, So again,
there were so many people who specially praised IT. Thank you. Thank you very much. It was very smooth.
It's, we always ask my team, can you pull it off? And they say, sir, trust us, we'll do it. And I said, okay, from now on, I'm not going to ask the question. You do it and show it, So they are fabulous. I mean, absolutely too good.
And Pratap does all the designing. You would have seen
all the
your
design, everything is
individual.
done in-house. Can you imagine? Everything is done in-house, you know, and it's fabulous, the talent that we have. And of course, you know, we have 2 halls, and we have to have people who are, you know, timekeepers who keep everything going. And so we have Ranjini. You know, Ranjini, she lives in Bangalore. Believe it or not, she works for us, but she lives in Bangalore. She has come from Bangalore to here just for this meeting. Can you imagine? Because sitting in Bangalore and then coordinating will be one more level of nightmare added. So she's traveled for 3 days, and she spent 3 days. She left her family behind there, and she's come for 3 days only for this. And she's going now. Immediately after this, she'll catch her thing and go back, flight, and go back to Bangalore. And so she's here. Yesterday was her birthday, and she was still here in spite of that, without spending time with the family. So she and Pradeepa, you know, kind of alternatively managing that. It was amazing. And then of course we had Dr. Mehreen, Nitika, and the entire translation research team, Mr. Lata Venkateshan, Dr. Shushil, Dr. Hema Arti, Dr. Akshay, and the whole DMDEA team, the Education Academy team. Then we had our marketing team, Dr. Cynthia, Mr. Harish Ravindran, who puts up all the things on social media. It's Cynthia and Harish.
You've seen your pictures coming on Facebook.
Every one of your pictures coming there. Now we have to change it. You would have seen, you know, there are about 6 or 7 medals. Did you notice that none of the music was the same? None of the visuals were the same. None of the colors were the same. So for every medal, we had to change the color, change the thing, change the music, change. Everything was changed.
Hari,
and
amazing.
Amazing. And Harish, Cynthia, and the whole team, amazing. And the entire corporate team as well. So Ganesh and the accounts team, there's a lot of things to be done, and that is Mr. Dandapani and the maintenance team. You know, right from the light that I have here, the light is switched off that way, you will get a different thing. The light has to be put in the right thing, you know. So you have, and in every room, imagine that, you know, there are extra lights, extra things. So that's the perfection that we're talking about. So that is done by Dandapani and his team, Mr. Aparsami and the housekeeping team, the Joseph and the catering team. You have to get some food in between. So all that is also done.
Thank you, Joe, for feeding everybody.
Yeah.
And special lunch.
I hope you all are fed well and don't, you know, not been starved. And then, of course, coming to the virtual MNC team, they are the people who have helped us with all the platform. This time you would have seen, you know, Anjana said, when we are creating the module, she said, no, I want the ITC effect. I said, how can you get ITC effect in sitting here? You know, she said, no, we'll do it. So she never gave up. And so we created that ITC effect. If you see the halls and all that, exactly like ITC, from outside, from inside, from everything. It took so many days to see. That's not the important part of the conference. No, that's also important part of the conference. That's an image that we're giving. So we have to do that. So it was never repeated in any conference. You know, 100 conferences have been held this year. Not one conference would have had that, because we created something unique for that also. The simple thing like a photo, you know, you can just go there and click your photo and get this thing from that. That was also introduced. So behind the scenes, there's lots and lots of innovation which has gone on, and I think the virtual MNC team has helped us a lot. Thank you so much.
Anuj, Nimit, if you're
here. Where are you all? Are you all
Anuj,
there?
Nimit, we can't
Anuj,
see you.
Nimit.
Thank you guys for everything that you're doing.
Done a fabulous job there. They're all there. And they didn't even come in once into the program. Everything from the side they were doing, and no, they let us do everything, but they were there. Now I come to the pharma. Now, without the pharma, you know, Professor Sam G.P. Moses used to say, it's like salt and pepper. You know, you cannot have, you know, who's salt and who's pepper, I won't tell you. But they used to say doctors and pharma are like salt and pepper. So, you know, without salt and pepper, you cannot have any Indian meat. So without pharma, we cannot have any conference. So right from, you know, all the company, I'll quickly read out their name because, you know, I didn't even mention them in the welcome address. So I'm going to mention them all now. So bear with me. Mrs. USV, thank you so much. You've always been the pillar of support, but also Boehringer Ingelheim, Novo Nordisk, Dr. Reddy's, Lupin, Sun Pharma CVS, Novartis, Eris, Sanofi, Zydus Wellness, Torrent, Intas, Abbott Nutrition, Abbott Diabetes, Cipla, Biocon, Medtronics, Abbott AGP Division, Glenmark, Healthion, Ipca, Eli Lilly, Zydus Cadila, Mankind, MCure, Johnson & Johnson, Serdia, Panacea, Primus, Franco-Indian Diabetics, Corona, It's called
Mohan Corona Remedies. Corona remedies.
Okay, I'll correct it. Corona remedies, Wockhardt, McLeod's, Roche, and Fortis. So it's a long list of companies. Many of them have joined us newly. And thank you for the confidence you have in us, because they have not flinched in supporting us. And I used to wonder, when so many meetings are being held, whether they will still have the confidence. But then, like Ashok said, they said, no, your meeting is special. And for us, we always believe in your meeting. And so big thank you to the pharma. Thank you all for staying on. This valedictory is something which we have at every meeting of ours, even the face-to-face. And people will be surprised that at 1:30, 2 o'clock, when the lunch is being served, people are sitting and listening to the valedictory function, just like all of you all are listening now. So that is another, that's only because of the love and affection that you have with us. I'm done, I'm gone. It's not like that. People are staying on. Why should Ashok Kumar Das come and, be here, or Purvi be here? I saw many other people here. I saw Rajiv here. I saw Shalini here. So it just shows the love and affection. And it is that, if you want one secret as to why we do this, it is because of that love and affection. As long as we have that from all of it, I mentioned it in the welcome address, that more than the scientific part, more than anything else, it's a networking, it is a bonding. And that, I think, increases every year. And that is the real motivation for us to continue. So all good things must end, and so must DMDIU. And until we meet next time, au revoir from all of us.
So one more.
Yeah.
Can they all switch on and we just take pictures of?
Yeah, let's take some pictures.
Putra, Rajiv, whoever is there.
Please,
Sanjay,
can you put
you're
out the videos?
here, so it's okay. Shanti, are you there? Yes. Putra, Samuel. Yes. Get the picture.
Irene.
And a big smile. Say update.
Diabetes.
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 Once you're done, you can tell us.
You'll be smiling forever.
That's what we want, Mohan.
I need your help in this.
Done?
Done? Are we done?
Yes, done.
There are a couple of pages.
Yes,
Right, everyone.
It doesn't end without the hip hip hooray.
Yes, you forgot the hip hip hooray.
Yeah. Okay. So repeat after me. Hip hip
hooray!
Hip hip
Hooray!
hip hip
Hooray!
Thank you.
Well done, everyone.
Well done.
Thank you.